I will first share the PDF in the group. Just hold on. I think I have not done. Guys, anyone know the meeting ID? If you know the meeting ID, you can just let me know. Yeah, thank you. You're able to see now, right? Just hold on one second. Yeah, welcome back. I think we'll be able to do the class within 2 to 3 hours max. So maybe even like my idea is to finish within 1.5 to 2 hours so that I can give you a lot of spare time to revise. Hopefully, let's see. So I've actually compiled, I mean, yeah, 2 to 3 hours max. So I've actually compiled as much as possible in a kind of like small bits and pieces of information. Like you can see, like in ACS, what you're going to do, and in ECG, what all you have to see. Then, so what are the things you have to see in pulmonary medicine? What are the things you have to see in neurology and all these things? So it's going to be just simple. That's all. So because I know your exam is going to be in 3 days or 4 days, maybe. Yeah, 1 week, maybe. So hopefully, like I just wanted to make sure that you don't waste a lot of time here. Pedigree, I'll do it then, 100% sure. I'll give a flowchart for pedigree. Now only I'm getting reminded of that. I know it's hardly a week for you for exams, right? It's okay, no problem. Okay, let us start. See, the problem with the students is if I take more also, they will cry. If it is more, if I take less also, they will say like it's less, is it enough? So that's always there. Every single class, we used to keep getting those kind of queries. But it's okay, no problem. Cool. Fine. Last marathon was bigger. We did only for 3 days, no? That was big. 3 days. It is big. Cool. Nothing to say. Okay, let us move on. So don't ask any unnecessary questions. Just leave it. If you wanted to continue with whatever. Yeah. So don't disturb the class in between. Already 45 minutes are gone now. I told you the class will start by 30 minutes, 10:30 only, no? Then what is the problem where 45 minutes are gone? Okay, cool. Fine. Okay. So first we'll be starting with ACS and how to manage a patient with ACS. No. So first, what you're going to do in the emergency, what they will ask is what will be the first test you're going to do. That's been a common question for long, right? What is the first test? First test is going to be within 10 minutes. You have to do an ECG. And once you have done the ECG, depending on what you see in the ECG, your treatment is going to change. But in case if you're thinking in terms of ACS, you have to stabilize the patient with a standard MONA-BC protocol. You know what is standard MONA-BC protocol? Morphine, oxygen, nitrates, aspirin, beta blockers, and anticoagulant drugs. In case if you want to give oxygen, the saturation must be less than 94%, otherwise you should not give oxygen. And you can give NTG for pain control unless and until you are suspecting RV infarction. When you are going to suspect RV infarction, if the patient is having inferior myocardial infarction. So in the setting of inferior MI, unless and until you rule out a right ventricular myocardial infarction, you cannot give nitroglycerin. And morphine can be given as needed because this is severe pain. So some people might require morphine, but you have to be worried about respiratory depression. Morphine can cause respiratory depression. And you have to give immediate release aspirin, right? It is not an entry-coated aspirin. You should never give entry-coated aspirin. You have to give only immediate release aspirin. And the dose of aspirin will be 162 to 325 milligram. In India, we commonly use around 300 milligram aspirin. And it should be immediate release, not entry-coated aspirin. Beta blocker can be given if there are no contraindications for beta blockers. What are the important contraindications? Acute heart failure. How will you say that the patient is having acute heart failure? Any evidence of crackles in the lungs, or if the patient is having jugular venous distension, or probably if the patient is having a third heart sound. So in these three conditions, better not to give beta blockers. Avoid, it's contraindicated, especially in MI. And if the patient is having any degree of AV block, especially a second degree or a third degree AV block, or any level of hemodynamic instability, even if the systolic BP is less than 120, in MI situation, you have to take it as hemodynamic instability evidence only. And or in exam, the classic thing will be bronchial asthma COPD, but that's not important in practice. But in exams, yes, you have to consider this also, asthma COPD. Anticoagulation will be done with either heparin or probably enoxaparin, which is a low molecular heparin. So this is a standard treatment protocol to begin with. So when you know that the patient is having a suspected acute coronary syndrome. So when you talk about ACS, in exam, the clue will be rest pain. Rest pain, along with that, patients will be having diaphoresis. Or they might give something called crescendo pain also, but rest pain and diaphoresis are classic clues in exam. So what are the things that you're going to see in the ECG? The most important thing to see is ST segment elevation, whether it is there or not there. In case if the patient is having ST segment elevation, it is likely to be a STEMI. That's it. There's nothing to think about it. So in this case, urgent reperfusion, ideally within 2 hours is recommended. So in case if PCA is available within 120 minutes, then you have to do PCA only because PCA is considered to be the best option. This is also called as primary angioplasty. But the goal door to balloon time, there is something called goal door to balloon time that's less than 90 minutes, meaning so the initial decision-making time is 120 minutes, but ideally you have to do it within 90 minutes. In case if PCA is not available within 120 minutes, if you think like you cannot shift the patient to PCA within 2 hours, then you can go for fibrinolysis. That is thrombolysis. There are a lot of drugs available. You can use streptokinase, you can use alteplase, you can use ritaplase, you can give tenecteplase. But in modern practice, we prefer either tenecteplase or we are going to prefer ritaplase. So these are the two drugs that we generally prefer in modern practice. And 0.9 milligram per kilogram is not the right dose of alteplase in patients with MI. In MI, it is 1 milligram per kilogram. It has to be divided in 0.15 milligram per kilogram as bolus, and remaining you have to give us half an hour and 1 hour infusion. That is different. We have discussed that in the classes already. That is for the stroke, whatever dose you're telling. So the goal door to needle time is less than 30 minutes. Okay, not 90 minutes. Here you have to thrombolyze. If you have decided to thrombolyze, you have to do it within 30 minutes. In case if there is ST depression, or I can say if there is no ST elevation, if there is no ST elevation and if the patient is having ST depression, in exam you're going to make a diagnosis of NSTEMI, unstable angina. So there are two scores, STEMI and gray score. You can use it if you wish to, but right now it's not very important. So what you're going to do is very important. In this case, the most important treatment is going to be enoxaparin. Most important treatment is enoxaparin. This is what they will ask in exam. Of course, you're going to give aspirin. Of course, you're going to give clopidogrel or ticagrelor. But the most important treatment here is enoxaparin. So only if the patient is high risk, I'm going to do an angiogram. But in exam, mostly if it's a ST depression, NSTEMI, unstable angina, mostly they will target you to answer enoxaparin only, which is a low molecular weight heparin. Right? Have you understood this? So far, whatever I told you. So what are the initial things that you have to do? So what you have to look in the ECG, right? If there is ST elevation, what you will do? If there is ST depression, what you're going to do? So now, what are the most important complications of myocardial infarction? I'm talking about MI complications. Number one, arrhythmias. Arrhythmias are the most common reason for death, out of hospital cardiac arrest, out of hospital death. Most common cause of out of hospital death. Ventricular tachyarrhythmias, most common cause of out of hospital death in patients with MI, especially we're talking about VTVF, very, very important. So patients can develop AF and patients can develop heart blocks also, in which MI heart blocks are very common, inferior myocardial infarction, because this is due to RCA. RCA is the one that supplies so many things like your SA node, AV node and everything. So that's why bradycardias and heart blocks are very, very common in inferior MI due to RCA involvement. And second, heart failure. Heart failure is the most common cause of in-hospital death. Inside the hospital, if somebody dies, it will be because of heart failure. And especially if you want one answer, it's cardiogenic shock. That's the most common cause of in-hospital death. The most common cause of out-of-hospital death is ventricular tachyarrhythmias, right? So patients will develop LV dysfunction, RV dysfunction, and so many other problems. So mechanical complications can also occur like ventricular septal defect, papillary muscle rupture, and a free wall rupture. Papillary muscle rupture is going to produce acute mitral regurgitation, and this is again due to inferior myocardial infarction only. And the most common papillary muscle that's going to rupture is posteromedial papillary muscle. Most common papillary muscle that ruptures is posteromedial papillary muscle. Okay, and again, this is because of inferior MI only, not because of anterior MI. Other complications that you can expect is pericarditis and Dressler syndrome. We'll talk about Dressler syndrome in some time. It's a very important topic. And patients can develop recurrent ischemia and thromboembolism also because of LV dilatation and thrombus formation. And how you're going to treat an acute LV failure? Acute LV failure means patients can have congestion or low perfusion. Congestion means patients will be having S3 and crackles. That's easy. S3 and crackles will be there if there is congestion. Low perfusion means patients will be having cold and clammy extremities. Patients will be very cold and clammy in the periphery. Patients will be having low BP, altered mental status, oliguria. So these are all evidences of low perfusion. We have discussed so many times in the classes also that what is the mnemonic for treating a congested patient with acute LV failure? It is LMNOP. What is L? L stands for Lasix, M stands for morphine, N stands for nitrates, O stands for oxygen, and finally P stands for positive pressure ventilation and position. So P stands for positive pressure ventilation, typically a CPAP, and the position. Position is the Fowler's position we are talking about, where the patients will be erect with legs dangling down. Easy. And in case if the patient is having low perfusion, you have to choose your inotropes. In case if the patient is having low BP and cardiogenic shock, the most important inotrope of choice is going to be noradrenaline, and then only you're going to give dobutamine. So you should not give dobutamine straight away. The first line treatment and Sarvaloga Nivarni here is going to be the noradrenaline. In case if the patient is having normal BP, then you can play around with a lot of other inotropic drugs also. Like you can use dobutamine, you can use milrinone, which is a phosphodiesterase 3 inhibitor, or you can use levosimendan as well. So these are the other options that you have. Okay. How you're going to treat an acute RV failure or acute right ventricular failure? So in the setting of MI, see, remember acute RV failure is common in patients with RVMI. It occurs in patients with right ventricular myocardial infarction, whereas acute LV failure is going to occur in patients with anterior myocardial infarction. We know that anterior MI is the one that's going to produce an acute LV failure, whereas RVMI is the one that's going to produce acute RV failure. And you know which MI is going to commonly be associated with RVMI? Anyone? Which myocardial infarction commonly is associated with RVMI? It's going to be inferior myocardial infarction, right? So this is the one that's going to be commonly associated with right ventricular myocardial infarction, right? So in case if RVMI is producing cardiogenic shock, the first treatment is going to be fluid resuscitation. We discussed that already. IV fluids, IV normal saline is the most important because here you have to optimize the preload. We have discussed that so many times. In case if the patient is having acute LV failure, you should never give IV fluids. So I told you so many times in the classes also, if somebody wants to see how jail looks like, then probably they can give IV fluids in a LV failure. So because it's a negligence, you cannot give LV failure in a patient who's already congested and having crackles in the lungs. You have to give fluids only in acute RV failure in patients with inferior MI. And you have to avoid drugs that reduce the preload. So what are the drugs that reduce preload? Because right ventricle is very preload sensitive. So you cannot give drugs that reduce preload. So what are the drugs that reduce preload? Nitrates, morphine, and any diuretic. So nitrates mean talking about NTG, nitroglycerin. So these are the three drugs that reduce preload. So you should not give these drugs in patients with suspected right ventricular myocardial infarction. Inotropes can be given in case if the patient is having normal BP, or if the patient is having low BP, once again, your Sarvaloga Nivarni is going to be noradrenaline only. So don't choose dobutamine if the patient is having low BP. Please understand that. So another important question that examiner might ask is, in case if the patient is having VT that is persisting for more than 48 hours post-MI. So after myocardial infarction, if the VT is persisting for more than 48 hours, this must be because of the scar tissue. If it's occurring within 48 hours, then it is due to ischemia, not due to scar tissue. Their reperfusion will be the goal. But after 48 hours, if the VT is continuously occurring, it must be because of the scar tissue. So scar tissue, you cannot reverse it. So the only way where you can reduce the risk of death in this patient is ICD, that is implantable cardioverter defibrillator. And you know Dressler syndrome, right? Dressler syndrome typically tends to occur by around around 2 to 8 weeks post-MI, 2 to 8 weeks post-MI, and it is an autoimmune phenomenon. It's an autoimmune phenomenon. It occurs 2 to 8 weeks post-MI. It's going to present like a classic pericarditis with chest pain, ECG changes and all. In exam, mostly they will target treatment. Treatment is high-dose aspirin. And generally, steroids are not required. Steroids are not required usually. High dose aspirin is enough in most of the cases. And any patient with pericarditis in MI, one has to avoid anticoagulation if you have a pericardial effusion. So why you have to avoid anticoagulation in pericardial effusion patients? Because it can result in tamponade. It can result in tamponade. Why? Anticoagulation can result in bleeding. Anticoagulation can result in bleeding. So this bleeding can result in tamponade in this patient. So that's why better to avoid anticoagulation in patients with post-MI pericarditis. If you have large pericardial effusion, always avoid anticoagulation. Right? So now we have understood the complication, how to treat acute LV failure, how to treat an acute RV failure, and how to treat a Dressler syndrome. All these are important points in exam. And coming to the DAPT, the duration of the dual antiplatelet therapy in patients with acute coronary syndrome. So remember, when you talk about acute coronary syndrome, the DAPT duration must be at least 12 months. At least 12 months minimum. Very important question in exam. 12 months you have to give. And in that case, you are going to give aspirin for sure at a dose of 75 milligram generally. And one P2Y12 receptor inhibitor should be given, which can be either clopidogrel or it can be prasugrel or it can be ticagrelor. Clopidogrel, prasugrel, or it can be ticagrelor. So when you are going to prefer prasugrel, remember prasugrel should be preferred only if the patient has underwent a PCI. Only if the patient has underwent a PCI, you are going to give prasugrel. Otherwise, you are not going to give prasugrel. Very, very important. If the patient has not undergone a PCI, it must be either clopidogrel or ticagrelor. In PCI also you can use the other two drugs, but don't use prasugrel outside PCI. Outside stented patients, prasugrel is not indicated. And there are two unique contraindications for prasugrel. They will commonly ask. Contraindications for prasugrel, that is very, very important in exam. So the most important absolute contraindication is going to be stroke and TAA history. Stroke and transient ischemic attack history. That's the most important contraindication. Relative contraindication will be age more than 75 and weight less than 60 kilogram. So very young and frail patient, very old and frail patients also are at risk of developing bleeding. So in this group of patients, if you are using prasugrel, use at a half dose. Use at half dose. 50% dose of prasugrel only should be given in these patients if you are using, but it's better to avoid in this group also. But the most important absolute contraindication will be history of stroke and transient ischemic attack. And once you have completed the dual antiplatelet therapy duration for 12 months, you have to give lifelong aspirin monotherapy. Very, very important point. Lifelong aspirin monotherapy. You cannot stop just like that. You have to continue with aspirin. So in case, if you are thinking about ECG, now we are going to the ECG. So what are the important leads to see in ECG? The first lead that I'm going to see is lead 2 and lead V1 if you're thinking in terms of a atrial problem for the P waves. In that, lead 2 is very, very important for P waves when it comes to the P mitral and the P pulmonal. P mitral means, so we'll be discussing later on. So what is P mitral? So P mitral means it's a wide P wave, wide and notched P wave. P wave must be more than 3 mm with a notched appearance in lead 2. So this is suggestive of left atrial hypertrophy. That is P mitral. And similarly, we have P pulmonal. What is P pulmonal? It should be peaked or a tall P wave. Tall P wave of more than 2.5 millimeter in lead 2 again. So that is suggestive of right atrial hypertrophy or right atrial enlargement. So that is why lead 2 is very, very important for looking at the P waves. You know that. When you're thinking in terms of a STEMI, they will ask you to localize STEMI based on where you're seeing the ST elevation. In case if you're seeing ST elevation V1 to V2, this is called as septal MI. If you're seeing ST elevation V3, V4, it is called as antro MI. If you see combination, that's also called as antroseptal MI. In case in exam, if they ask you, you're seeing in V1 to V6 plus or minus 1 and AVL. So this has multiple names. This has multiple names. This is also called as extensive antro MI, or some people use the term anterolateral MI as well. Some people use the term anterolateral myocardial infarction as well. Right? Or in case you see 1 and AVL only, you are seeing ST elevation 1 and AVL only, in this case, you are going to call it as a lateral myocardial infarction. If you see 1 and AVL only, it is called what? Lateral myocardial infarction on the lateral side. So in case if you're seeing ST elevation 2, 3 and AVF, this is called as inferior myocardial infarction. Remember, in any antroseptal MI or antro MI, whatever it is, in all these situations, even in extensive anterior MI, anterolateral MI, everywhere the culprit vessel will be LAD, left anterior descending artery, which is also called as the widowmaker's artery. In case if you are encountering an isolated lateral myocardial infarction, in this the culprit vessel will be left circumflex. That will be the culprit vessel. In case if you are encountering inferior MI or RVMI or maybe posterior MI, in these cases the culprit vessel will be usually right coronary artery. Mostly right coronary artery will be the culprit in these cases. So if you are seeing elevations in V4R, it is right ventricular myocardial infarction. If you are seeing ST elevations in V7, V8, V9, this is also called as posterior myocardial infarction. And whenever you talk about a posterior myocardial infarction, do not forget the mirror image pattern in V1, V2. Do not forget the mirror in V1, V2. So this can mimic a end STEMI. So remember in V2 what you're going to see? You're going to see ST depression. You're going to see a tall R wave, ST depression and a upright T wave, something like this. Yes or no? Sorry. Okay, something like this you will see. Okay, so do not forget this mirror in V1, V2. So what is the problem in these patients? Because you're seeing ST depression in a 12 lead ECG, you might falsely think that this is an end STEMI patient and an unstable angina patient. You will not think in terms of a posterior STEMI. So never forget this in exam, very important. Right? So how to find out the axis? It's so easy. You are going to just look at two leads, that is 1 and AVF. Normal axis is going to be between -30 and +90 degree. So in this case, both 1 and AVF will be positive. Both 1 and AVF will be positive. When you are going to call it as right axis deviation, first I'll finish right axis deviation. Here 1 will be negative, 1 will be negative, but AVF will be positive. In this situation, you can think in terms of a right axis deviation. And right axis deviation is commonly seen in patients with right ventricular hypertrophy, left posterior fascicular block, not anterior fascicular block, lateral myocardial infarction, COPD where you'll see only a mild right axis deviation, and pulmonary embolism. These are classic cause of right axis deviation, very commonly asked in exam. And then how will you pick up left axis deviation? In left axis deviation, you're going to have one will be negative, sorry, one will be positive, AVF will be negative, one will be positive, AVF will be negative, and you need to prove that lead 2 is also negative. I think we have discussed that in the classes. Do you remember, guys? I told you one positive, AVF negative, and lead 2 also negative. Then only you can call it as a true left axis deviation. Then only you can call it as a true left axis deviation. But in exam, whenever you see one positive, AVF negative, always think in terms of left axis deviation. So when you will say, I mean, what is left axis deviation? It's -30 to -90 degree. That's the definition. And what are the usual conditions? Left anterior fascicular block and inferior myocardial infarction. These two conditions can produce left axis deviation. And finally, we have the extreme axis deviation, that is in the extreme side, that is -90 to -180 degree. The usual causes will be ectopics and hyperkalemia. Very rare to see extreme axis deviation where both 1 and AVF will be negative. Both will be negative. And AVR will be generally fully positive. So this is suggestive of a extreme axis deviation, or otherwise called as what? Northwest axis. It's very rare. Only bizarre conditions like VT and hyperkalemia will produce extreme axis deviation. Okay, understood this, guys? What are the important ECG things to look for in the setting of MI as well as in right atrial hypertrophy, and how to find out the axis in exam? And coming to the chamber hypertrophy, apart from atrial hypertrophies, we have what? We have the LVH and RVH criteria also. So what about LVH, that is left ventricular hypertrophy? We're going to look at something called as Sokolov-Lyon criteria. You know what is Sokolov-Lyon criteria? S wave in V1 with R wave in V5 or V6. If it's more than 35 millimeter, that's called as Sokolov-Lyon criteria, suggestive of left ventricular hypertrophy. Or you can also say R wave in AVL if it's more than 11 mm, that is also equal to RVH. So that is also kind of Sokolov-Lyon criteria only. So this is very important for exam. And coming to right ventricular hypertrophy, when you call it as right ventricular hypertrophy, R wave in V1, V1 must be bigger, taller, more than 7 mm. Patients will have right axis deviation, and RS ratio in V1 must be more than 1. If you don't know any of this, just remember that R wave in V1 must be more than 7 mm to call it as a right ventricular hypertrophy. And there are two important special cases, Brugada syndrome and Wolff-Parkinson-White syndrome. In Brugada syndrome, the most important clue will be that code ST segment elevation in V1 to V3. There will be code ST segment in V1 to V3. Along with it, there will be pseudo right bundle branch block, all these things, that's fine. These patients are at risk of sudden cardiac death at rest or probably during sleep, right? And it can be provoked with agemelin or any other sodium channel blocker. It can be provoked with agemelin or any other sodium channel blocker can worsen the Brugada syndrome, Brugada pattern. And treatment of choice for Brugada syndrome is ICD implantation, that is implantable cardioverter defibrillator. There is no other treatment for this patient. And Brugada syndrome is autosomal dominant SCN5A mutation, commonly affects males compared to that of the females. All these are important points as well. And coming to Wolff-Parkinson-White syndrome, it is due to the axillary pathway called as bundle of Kent, where the patient will be having short PR interval, delta wave, that is nothing but short PR means less than 0.12 second, less than 3 small boxes. And there will be delta wave, which is nothing but a slurred initial QRS. That's what you call delta wave. Along with that, patients are going to have wide QRS. And this is because of the so-called axillary pathway called as bundle of Kent. And treatment of choice is radiofrequency ablation. Treatment of choice is radiofrequency ablation in case if the patient is symptomatic. Remember, one common condition they will ask is if the patient is having Wolff-Parkinson syndrome, WPW syndrome with atrial fibrillation, then in this situation, there is no role for AV nodal blockers. You cannot use these drugs. Rather, what drugs you are going to give is, you are going to use either procainamide, either you will be using procainamide, or you have to use ibutylide, or you have to use ibutylide. So any one of these drugs only can be used. You cannot use any AV node blockers in patients with Wolff-Parkinson-White syndrome and atrial fibrillation. Remember how these patients will present? They will present with irregular wide complex tachycardia. Irregular wide complex tachycardia, and that too in a child. So classic. Irregular wide complex tachycardia in a child, always almost think in terms of pre-excited atrial fibrillation. That is WPW with AF, and in this case, use only these drugs as acute treatment. Don't use any AV nodal blocker. So what are the important rules for tachycardia in exam? In case if the patient is pulseless with any tachycardia, the next step is going to be CPR, that is cardiopulmonary resuscitation, because patient is in cardiac arrest. There is no doubt about that. Then, in case if the patient is having a VT or a VF, probably you can do a shock. Probably you can shock the patient. Okay, that is defibrillation. Otherwise, like, you're only going to continue with CPR. In case if the patient is unstable, okay, which means the patient is having a pulse. So these patients will be having a pulse. These patients will be having a pulse. If pulse is there and if the patient is unstable, then shocking will be the treatment of choice. I told you so many times, if the patient is in shock, treatment is shock. Very simple. Synchronized DC cardioversion will be the treatment of choice. If the patient is stable and having a narrow QRS, regular tachycardia, most commonly in exam it will be a PSVT. So in this case, the first line treatment will be vagal maneuvers. After vagal maneuvers, you are going to push on to adenosine in case if the patient is stable. Correct? If the patient is stable and having a narrow QRS and an irregular rhythm, most likely in exam it will be an atrial fibrillation. In this case, you can choose either a beta blocker, which is the first line drug, or you can choose a calcium channel blocker if the patient is having asthma COPD, or you can use digoxin if the patient is having acute heart failure. If the patient is in acute heart failure, then you are going to use digoxin as the rate controlling drug here. Or in usual situation, the first line treatment will be beta blocker, IV beta blocker. But if the patient is having asthma COPD, use calcium channel blocker like verapamil diltiazem. But if they specifically mention acute heart failure, then you cannot use beta blocker as well as calcium channel blocker. So you have to go for digitalis in this case. The patient is stable and having a wide QRS tachycardia, and if the patient is having a monomorphic rhythm, then it must be a monomorphic VT. In this case, you are going to use either amiodarone or lignocaine, or you can use procainamide also. So amiodarone is the usual preferred drug. The dose will be 150 milligram. But adenosine's dose in PSVT will be 6 plus 12 plus 12. We have discussed that so many times. The first dose will be 6 milligram. So lignocaine you will be preferring only if it's an ischemic VT. If it's an ischemic VT that's occurring post myocardial infarction, only in that situation, lignocaine will be preferred in exam. Otherwise, do not prefer lignocaine. It's not correct. Or if the patient is having digitalis induced VT, then you can prefer lignocaine. Otherwise, do not prefer lignocaine. Amiodarone will be the most important treatment in these cases. In case if the patient is stable and having a wide QRS with a polymorphic rhythm, multiple morphologies, then you're dealing with the torsades. In this case, IV Maxel will be the treatment of choice. Understood, guys? So all the TACI rules, what you have to do, in case if the patient is pulseless, what you have to do, if unstable, what you have to do, if stable and narrow QRS, what you have to do, stable, narrow QRS, regular, what you have to do, irregular, what you have to do, white QRS, monomorphic, what you have to do, and white QRS, polymorphic, what you have to do, right? Simple, that's all. So coming to bradycardia. So bradycardia wise, so you are going to have sinus bradycardia or sick sinus syndrome or AV blocks, right? In case if you're having sinus bradycardia, in exam, always think in terms of a beta blocker use or probably a calcium channel blocker use or sometimes even hypothyroidism. This is an old exam question. Hypothyroidism also can produce a sinus bradycardia very commonly, severe forms. And if the patient is having sick sinus syndrome, you have to go for a permanent pacemaker. In fact, this is the most common reason for a permanent pacemaker. Most common reason for a permanent pacemaker in the world is sick sinus syndrome, that is sinus node dysfunction as of now, which is also called as tachybrady syndrome. And AV blocks, what are the important AV blocks? We have the first degree AV block where the PR interval is more than 200 milliseconds, or we can say more than 0.2 seconds or 5 small boxes. We have second degree Mobitz 1 and Mobitz 2. Mobitz 1 is also called as Wenckebach phenomenon, where there will be continuous prolongation of the PR interval followed by one missed beat. Sequential prolongation of the PR interval followed by one missed beat. Whereas in Mobitz 2, you are going to have sudden drop in the QRS complex, which means there will be normal PR interval, there will be consistently stable PR interval followed by all of a sudden one missed beat will be there. There will be no prolongation of the PR interval. So this is Mobitz 2. Mobitz 2 is more dangerous than Mobitz 1 because Mobitz 2 indicates an infranodal block. Mobitz 2 often indicate an infranodal block. It's not a proper nodal block. And in this case, you have to go for a permanent pacemaker only. And if the patient is having a third degree AV block, it's a complete heart block, 100% you need a permanent pacemaker where there will be AV dissociation. There will be atrioventricular dissociation, P everywhere, correct. So that is basically AV dissociation, that is complete heart block. What are the rules of permanent pacemaker? Any symptomatic bradycardia, including sinus bradycardia, very, very important point. Any symptomatic bradycardia, including sinus bradycardia, you will require a permanent pacemaker. Or any third degree heart block or second degree Mobitz 2 block will require a permanent pacemaker. Very, very important point again. Any third degree AV block in the long run or second degree Mobitz 2 block, that is going to be requiring a permanent pacemaker. And post MI blocks, especially if it's after 48 hours, this must be because of scar tissue, right? After MI, if it's persisting for more than 48 to 72 hours, it must be because of scar tissue. For that also, you need to give only permanent pacemaker. There is no option because it's a scar tissue. The fibers are damaged. So first degree only beta blocker. First degree, why you want to give beta blocker? In blocks, why you want to give beta blocker? Okay. So coming to single chamber pacemaker. When you are going to use a single chamber pacemaker, it's a VVR pacemaker where you're going to use for atrial fibrillation with AV blocks, whereas DDDR, triple DR pacemaker, is for AV block in patients with sinus rhythm. Whenever the patient is in sinus rhythm, the rule is very simple. Sinus rhythm means go for DDDR pacemaker. If the patient is having atrial fibrillation, you are going to use a VVR pacemaker. That's it, nothing more. 1 second. Okay. So which electrolyte is not going to cause ECG change? Won't cause ECG change? It is sodium. Very simple. Sodium is something that's not going to produce ECG change at all. So all other electrolytes will produce some ECG change. And what are the rules of hyperkalemia? In ECG, you are going to see peak T waves or tall T waves, wide QRS, and sine wave pattern over a period of time. And at any point, they can develop VT and VF also. And it's not only wide QRS, patient will have wide P wave and absent P wave as well. So coming to treatment. So treatment, the first treatment is going to be calcium gluconate. You have to immediately push IV calcium. And you have to push it urgently, especially if the patient is having potassium of more than 6.5 or if the patient is having ECG changes. But in most cases, the first line treatment, it's going to be calcium gluconate. And after this, you're going to give insulin and dextrose. This is to reduce the blood potassium levels because this is going to push the potassium into the cell. And you can give repeated salbutamol nebulizations also. Again, this is also going to push the potassium into the cells. And you're going to give sodium bicarbonate if the patient is having acidosis. IV soda bicarbonate if the patient is having acidosis. All these things work by transcellular shift. They're going to push the potassium into the cells. And these are going to have only transient effect. So because these are only going to have a transient effect, you have to get a permanent solution to remove potassium. So how can you remove potassium permanent solution? You can give Kayexalate, that is also called as sodium polystyrene sulfonate. And in refractory cases, you can do dialysis, that is renal replacement therapy also. So what is the first line treatment? Calcium. Then give insulin dextrose, salbutamol, soda bicarbonate. Then go for removing potassium like Kayexalate, dialysis and all. Then in case in acute hyperkalemia, if the patient is having a refractory hyperkalemia, then only you are going to do dialysis. Otherwise, dialysis will not be used in mild cases and all. It's better to just treat conservatively. So in exam, they will target calcium and insulin dextrose. These are two things they are going to target. Okay. So what are the important things about dissection? So, patients are going to present with sudden tearing, chest and back pain, and the BP difference in arms will be more than 20 millimeters of mercury, or at least more than 10 millimeters of mercury. Very, very important point. So, BP difference between arms, pulse difference between arms with sudden tearing, chest and back pain, very, very characteristic of aortic dissection. In chest X-ray, you're going to see a characteristic finding called as widened mediastinum because of the enlargement of the aorta. And CT angiogram is the investigation of choice, but you can do transesophageal echo if the patient is unstable. If the patient is unstable, you can do a transesophageal echo. Otherwise, CT angiogram will become the investigation of choice. So therapy, IV beta blockers, especially esmolol or labetalol, will be given for all patients with hypertension because most of the dissections are going to present in the form of hypertensive emergency. So you can further classify into type A and type B based on the Stanford classification system. If ascending aorta is involved, it is type A. If only descending is involved, it is type B. For type A, you have to go for surgical repair only. Urgent surgery is required. For type B, you can manage more conservatively. Right? So which means initial treatment alone is enough. For type B, you can manage more conservatively. So what are the rules of venous thromboembolism? Venous thromboembolism means we are talking about a deep vein thrombosis and pulmonary embolism. In exam, always look for the risk factors. Always look for the risk factors in exam. So risk factors can be anything: immobilization, lower limb fractures, polytrauma, surgery, pregnancy, postpartum period, malignancy. So anything, or factor V Leiden mutation, anything can be given as a risk factor in exam. OCPUs, hormone replacement therapy, SERMs, correct. So look for the risk factors in exam. We have discussed that so many times. So what is the test that you can use as screening? D-dimer can be used as screening, but it's not a confirmatory test. So in case if the patient is having a DVT, patient is going to have asymmetric calf and leg swelling along with pain tenderness. In this case, the investigation of choice becomes ultrasound Doppler of the lower limb or compression ultrasound of the lower limb. In case if you're dealing with a pulmonary embolism, then in this case, patient will present with unexplained shortness of breath with pleuritic chest pain, not with a ischemic chest pain. They'll have a pleuritic chest pain. Along with it, patients may have hemoptysis. In this case, the investigation of choice is going to be CT pulmonary angiogram, which is the gold standard. Or alternatively, you can use a VQ scan in case if the patient is having a higher creatinine. So higher creatinine means you can think in terms of a VQ scan. Otherwise, gold standard is always CT pulmonary angiogram. And the treatment of choice is going to be anticoagulation. So what kind of anticoagulation you're going to use? Enoxaparin for inpatients or warfarin or DOACs for outpatients. Mostly for outpatient and discharging patients, you're going to use DOACs only. Warfarin will be usually preferred only if the patient is having antiphospholipid syndrome. Otherwise, you're not going to use warfarin. Mostly, we're going to stick on to DOACs. And the usual duration of anticoagulation is going to be 3 to 6 months on average. Extension is personal. The doctor will decide. You need not worry about that. When you are going to use the so-called IVC filters, if there is contraindication or failure of anticoagulation, then only you are going to use IVC filters. Otherwise, you don't use IVC filters. So when you are going to thrombolyze the patient, whenever the systolic BP is less than 90, and if the patient is having pulmonary embolism, then only you are going to thrombolyze the patient. In that, the agent of choice is going to be alteplase. And the dose is going to be around 100 milligram IV over 2 hours. Okay, so this is the indication for thrombolysis in pulmonary embolism. Understood, guys? Whatever I told you in this particular slide? Cool. So coming to infective endocarditis. Infective endocarditis, mostly in exam, they will target the cultures only. So I told you so many times, you have to take at least 3 sets of blood cultures. 3 sets means it sets, it includes, each set will include aerobic and anaerobic. Each set will include what? Aerobic and anaerobic. Aerobic and anaerobic. 3 sets of blood cultures must be taken before antibiotics. And yes, each aerobic should be 10 ml, anaerobic should be 10 ml, right? 20 ml per set. And in case if the patient is having a culture negative infective endocarditis, you're going to think in terms of Coxiella, Brucella, Bartonella, or sometimes has a group of organism. These are things that you're going to think in terms of culture negative infective endocarditis. You have to be very clear about it. But in India, the most common cause will be prior antibiotic exposure. Most common cause will be prior antibiotic exposure. That will be the usual reason in India. In Western countries, they will tell this, but in India, this is the most common cause. And you're going to use the modified Duke criteria for diagnosis. I'm not going to discuss right now because we have discussed so many times. So what about acute rheumatic fever prophylaxis? So they will in exam, they will target the secondary prophylaxis only. So for that, the benzathine penicillin every 3 to 4 weeks is going to be the drug of choice for prophylaxis, and it should be given IM, and the dose will be 0.6 to 1.2 million units depending on the body weight. If the patient's weight is less than 27 kilogram, you're going to give 0.6 million units. If the patient's weight is more than 27 kilogram, I'll be using 1.2 million units. And what is the duration of anticoagulation? It's going to be 5 to 10 years or 21 to 40 years of age, depending on carditis valvulitis present or not. If the patient is having carditis, then you're going to give for 10 years. Sorry, you're going to give for 5 years or till 40 years of age, whichever is longer. If the patient is having valvulitis, then you're going to give for 10 years or till 40 years of age, whichever is longer. 10 years or till 40 years of age, whichever is longer. In case if the patient is having severe valvulitis, severe valve involvement, then it has to be lifelong prophylaxis. In case if the patient doesn't want injections, if the patient does not want any injection, then oral penicillin V can be given. That's an option. In case if the patient is having penicillin allergy, if they ask you in penicillin allergy, what will be the alternative choice? It is sulfadiazine 1 gram per day. In case if the patient is having sulfa allergy and penicillin and sulfa allergy, then in this case you can use azithromycin. So azithromycin is the last resort. You're not going to use as a first choice drug. First choice is always almost going to be benzathine penicillin. Second choice is oral penicillin V if the patient doesn't want injection. Next choice will be sulfadiazine if the patient is having penicillin allergy. And then if the patient is having penicillin and sulfa allergy, then you're going to use azithromycin as a final choice for long-term prophylaxis. And coming to lipid control in CAD and PAD and cerebrovascular disease, whenever you talk about any atherosclerotic disease, you have to give a high intensity statin. High intensity statin, we are going to use either atorvastatin 40 to 80 milligram, or we are going to use rosuvastatin at a dose of 20 to 40 milligram. And the target LDL in this patients must be less than 70 when you are giving high intensity statin. In case if the target is not reached, then you can add estimab or PCSK inhibitors. What are the important PCSK inhibitors in exams? We are going to use two drugs. One is evolocumab and second is alirocumab. Evolocumab or alirocumab. And definitely you have to add an antiplatelet therapy for secondary prevention. That is very important because you're dealing with cerebrovascular disease and cardiopulmonary disease. No, you have to add some aspirin or clopidogrel for secondary prevention. In any cardiomyopathy, the first test that we are going to do is echocardiogram. It's a simple transthoracic echo. That's a kind of a day-to-day life gold standard. But the best test in any cardiomyopathy is going to be cardiac MRI, which is currently considered to be the non-invasive gold standard, where you're going to look for the late gadolinium enhancement. The pattern of the late gadolinium enhancement will tell you the diagnosis. The extent of late gadolinium enhancement will tell you the prognosis, right? We have discussed all those things already. So don't forget echo and cardiac MRI in exam. Have you understood this, guys? Let us move on. Cool. Okay. So what are the important things that you're going to see in tamponade? In tamponade, one has to look for the so-called Beck's triad. So in Beck's triad, what are the three components? Hypotension, muffled heart sounds, and jugular venous distension. When it comes to jugular venous distension, you're going to have prominent X descent with a blunted Y descent, very characteristic. And you're going to have pulsus paradoxus also. And the usual background history will be either a trauma patient, either the patient will have a trauma history, or the patient will be having malignancy. Anyone will be there, either trauma or malignancy. This will be the usual history in patient. And in echo, you're going to notice that characteristic diastolic RA-RV collapse along with a large effusion on the side, and treatment is going to be either pericardiocentesis or surgery. So when you're going to prefer surgery, if you're thinking in terms of a traumatic tamponade, or the patient is having aortic dissection related tamponade, or the patient is having a ventricular septal defect in MI. So ventricular septal defect occurs in MI, right? So in these conditions and all, surgery is preferred. Pericardiocentesis, it's better avoided. In fact, it's contraindicated. What are the rules of pericarditis? Patients are going to have pleuritic chest pain, often follows a URA history, very characteristic, and it's going to get better on leaning forward. And it can radiate to trapezius, typical pericarditis chest pain. And ECG, you're going to see diffuse widespread ST segment elevations, which will be concave in nature, saddleback ST elevations. Along with it, you're going to notice the PR segment depression. And treatment of choice is going to be NSAIDs with colchicine. Only if there is contraindication to NSAIDs, I'm going to use steroids. Otherwise, I'm not going to use steroids. And what about constrictive pericarditis? Constrictive pericarditis will have prominent excrescent and prominent wide descent in JVP. Prominent excrescent and prominent wide descent in JVP. Along with that, patients will be having Kussmaul sign. That is a paradoxical increase in JVP during inspiration. And one characteristic signature clinical finding is called pericardial knock. Very, very important diastolic sound. And CT and MRI can be seen for thickening and calcification. Exam, whenever they mention pericardial calcification, you have to think in terms of constrictive pericarditis only. The most common cause in India is going to be tuberculosis, and the treatment of choice is pericardiectomy. You have to strip the pericardium. The three clinical rules I told you so many times. So one is the rule of rate, that is inspiration is going to increase heart rate, whereas expiration is going to decrease heart rate. Then the rule of pressure, inspiration results in decreased pressures everywhere, low BP, low JVP, as well as low intrathoracic pressure. All the pressures related to thorax will decrease with inspiration and increase with expiration. Vice versa. Rule of flow, right-sided flows are increased with inspiration. This is a common rule, and left-sided flows are going to increase with expiration. Left-sided flows are going to increase with expiration. Right-sided flow is going to increase with inspiration, and left-sided flow is going to increase with expiration. This is also referred to as the de-Carlos law. That's why left-side events are heard better in expiration. Right-side events like TR are better heard in inspiration. And do not forget the pay tax. You know that the mnemonic, no? So in constrictive pericarditis, you're going to have a prominent Y descent, whereas in tamponade, you're going to have a prominent X descent. Okay, so coming to the BP difference between arms and BP difference between arms and legs. So arms leg not 120, it's arm leg difference, arm difference more than 10 millimeters of mercury. Corrected. Arm difference more than 10 millimeters of mercury indicates dissection in exam, especially if the patient is having acute chest pain. Always think in terms of dissection. Or if the pain is having chronic arm pain, if they mention more of arm pain, in this case, you can think in terms of Takayasu and subclavian stenosis. If the history says arm pain, then think of Takayasu or subclavian stenosis. If the patient is having acute chest pain, then your diagnosis must be dissection only in this case. If arm leg reference more than 20, you're going to think in terms of coactation, or you're going to think in terms of aortic regurgitation. How will you differentiate? In coactation, your lower limb BP, your upper limb BP will be more than lower limb BP, whereas in aortic regurgitation, your lower limb BP will be more than upper limb DT, upper limb BP. And coactation, aortic regurgitation causing this BP difference is also called as the so-called Hill's sign. It is also called as what? Hill's sign. Hill's sign. Okay, understood, guys? Hello? Hello? Can I call you in some time? I'm in a class. Yeah, thank you. Okay, so what are the important pulse types? Pulse types. So collapsing pulse is commonly seen in aortic regurgitation and PDA, that is persistent ductus arteriosus. Bispherians pulse will be seen in AS plus AR, or maybe it can be seen in patients with AR, or it can be seen in patients with HOCM. If you see in patients with HOCM, you are going to have a classic spike and dome pattern or spike and dome appearance. Okay, pulses alternance is a classic feature of LV failure, and pulses paradoxes will be seen in tamponade and in patients with status asthmaticus, that is acute severe asthma or exacerbation of bronchial asthma. And there are some important points with regards to loud S1 and murmurs. So loud S1 will be seen in patients with MSTS. We know that the most important is MS, or short PR, where you're going to see short PR, Wolff-Parkinson-White syndrome. It can be seen in tachycardias, or it can be seen in hyperdynamic states like fever, sepsis, beriberi, anemia, pregnancy, children, and all. Where are you going to see soft S1? Soft S1 will be seen in patients with MRTR. The most important is MR, or in any heart failure patient you can see a soft S1, or in patients with prolonged PR interval. In first degree AV block you can see, or in patients with severe bradycardia also you can see a soft S1. Absolutely possible. And yes, in patients who are having calcified valves, you're going to have a soft S1 only. And what about the murmurs? In exam, if you see ejection systolic murmur, think in terms of AS or PS. If you're seeing a pan-systolic murmur, you're going to think in terms of MR, TR, or VSD. If you're seeing an early diastolic murmur, think in terms of AR and PR. Remember, it's an old question. If PR happens in pulmonary hypertension, this is also called as the Graham-Still murmur. We know that, right? If PR murmur happens in a pulmonary hypertension, this is also called as Graham-Still murmur. And MDM, that is mid diastolic murmur, is going to be seen in MS or TS, or it can be seen in a part of acute rheumatic fever, and in that acute rheumatic fever it's called as Carey-Coombs murmur, or it can be seen in severe aortic regurgitation patients where it is called as Austin-Flint murmur. So the four murmurs that are very important will be ESM, PSM, EDM, and MDM in exam. They might ask about continuous murmurs also. It's up to you. Continuous murmur means PDA. That's the most important. Do not forget the dynamic murmur variations in patients with hypertrophic cardiomyopathy. You know the murmur is going to get louder. Austin-Flint murmur in aortic regurgitation. It is not seen in MS. So what about dynamic variations in HCM? You know the murmur is going to get louder with Valsalva or standing because this is going to reduce the preload. Whereas the murmur will become softer or less prominent with squatting or hand grip because squatting is going to increase preload. Squatting is going to increase preload, okay, whereas your hand grip is going to increase the afterload. Increase preload, whereas hand grip is going to increase the afterload, okay. So that's the reason why murmur is going to get softer with squatting and hand grip. So Valsalva standing increases, squatting and hand grip will decrease the murmur. So now we have covered the entire cardiology. Have you understood, guys? Whatever I told you so far. What are the important things? So see, this is finally what all you need to know for exam. So just if you see this, what you're going to answer, that's it. So lab 1 is different, lab 2 is different. Now lab 3 is like what you need to know, the points, that's it. So it's kind of a rapid revision, whatever you have learned already. So coming to the important points that you have to know in spirometry. So what about spirometry rules? First, you have to see whether it's obstructive, restrictive, or it's an isolated decrease in DLCO. In exam, it's very simple. If the PFT is normal and the patient is having isolated decrease in DLCO, you're going to think in terms of pulmonary hypertension. We all know that. If you're seeing an obstructive lung disease, then you're going to look at FE1 by FVC. It's going to be less than 70%. In patients who are having a normal FE1 by FVC, and if the patient is having 12% increase or 200 ml increase in FE1 post by bronchodilator, you're going to call it as bronchial asthma. But this rule is applicable only in patients with normal FE1 by FVC at baseline. But whenever you want to call it as obstructive lung disease, your FE1 by FVC, the Tiffin index must be less than 70%. And we all know that in patients who are having post-bronchial FN by FVC of less than 70, it is COPD unless proved otherwise. And further severity grading will be based on FE1. We know that. That's a very important point in FMG also. More than 80% FE1 is mild COPD, 50 to 79% is moderate COPD, 30 to 49% is severe COPD, and less than 30% is very severe COPD. And what about restrictive lung disease? Your FE1 by FVC will be normal and FVC will be reduced. FVC will be reduced. FE1 by FVC will be normal and FVC will be reduced. So this is suggestive of a restrictive lung disease, and then stratify based on DLCO. DLCO is going to be low in ILD and sometimes in emphysema. But this point is not important here. You have to write, you can strike it down and you can write. It's going to be normal in patients with neuromuscular diseases like Guillain-Barré syndrome. DLCO will be normal in intrinsic RLDs like ILD, whereas DLCO will be normal in patients with extrinsic disease like neuromuscular disease. Very, very important. And whenever you see an isolated drop in DLCO, it must be pulmonary hypertension unless proved otherwise. Remember, there are three conditions where you're going to have low DLCO. What are the three conditions where you'll have low DLCO? One obstructive lung disease called emphysema, one restrictive lung disease called ILD, and one vascular disease called pulmonary hypertension. So these are three conditions where you're going to have a low DLCO. And what is the treatment of choice for acute exacerbation of bronchial asthma? So remember, here the patient will be unable to complete sentences. are unable to speak in sentences. In exam, that's a classic clue for severe acute exacerbation. And patients will be having pulses paradoxes. Patients will be having pulses paradoxes. These are the clues for severe acute asthma. In this case, you're going to give oxygen where you have to keep the SpO2 to more than 92 percentage, and you are going to give bronchodilators with salbutamol nebulization, and you're going to give systemic steroids like prednisolone or methylprednisolone. And in case if it's life threatening, you can give urgent magnesium sulfate, which might work in certain people. And if the patient is having refractory asthma, then positive pressure ventilation, that is intubation, can be tried. Or if the patient is having signs of impending respiratory arrest, like a patient is having silent chest, altered mental status, cyanosis, in those cases also urgently intubate the patient. Okay, positive pressure ventilation. Or the treatment of acute exacerbation of COPD. Again, here oxygen will be given, but titrated to 80 to 92 percentage. Bronchodilators will be given as a part of nebulization, and systemic steroids like dexamethasone or prednisolone or methylprednisolone will be given for all patients. And here the most important adjunctive treatment is going to be antibiotic, because the most common cause of acute exacerbation is infection. The most common cause of acute exacerbation of COPD is infection. That's why antibiotics play a very important role here. And NIV can be tried. NIV means we're talking about BiPAP. NIV can be tried if there is any evidence of respiratory acidosis. It has to be started very early to reduce intubation rates. So what do you mean by respiratory acidosis? pH less than 7.35 and or PaCO2 more than 45 millimeters of mercury. In this case, you have to start with NIV, BiPAP. What are the things that improve survival in COPD? The most important is smoking cessation. We all know that. Strongest evidence for improving survival. Second is long-term oxygen therapy. That is low dose oxygen, especially if baseline PO2 is less than 55 millimeters of mercury, and lung volume reduction surgery in selected patients. These are the only three things that has been shown to improve survival as of now in COPD patients. Right? So what will be the most important treatment as far as ARDS is concerned? Remember, first of all, ARDS is diagnosed by New Berlin criteria. ARDS is diagnosed by what? New Berlin criteria that was last updated in 2012. Acute event in the last 7 days. Bilateral infiltrates in chest X-ray. Then non-cardiogenic cause of pulmonary edema. And last but not the least, severe hypoxemia defined as PF ratio will be less than 5 centimeters of water with a PEEP of more than 5. So this is the New Berlin criteria. Go through that, very, very important point. And so what is the most important strategy of ARDS treatment? It's going to be low tidal volume ventilation. Multiple times asked question in exam. You are going to use a tidal volume of 6 ml per kilogram, not more than that. And you have to use PEEP to recruit alveoli. So you have to increase the PEEP as much as possible, depending on the FiO2 status. And prone positioning can be tried if the PF ratio is less than 150. We have discussed that also. And fluid conservative strategy must be used. Fluid overload should be definitely avoided. All these things we have discussed. And what are the important contraindications for non-invasive ventilation in practice? One is low GCS altered mental status. Next is acute MI. Third is GI bleed vomiting, local causes, and don't forget hemodynamic instability, low BP, shock. In all these situations also, it's better to avoid non-invasive ventilation. These are the usual reasons to avoid NIV in exam. What are the important points in sarcoid? In exam, whenever you see or encounter a case of bilateral hilar lymphadenopathy, it is sarcoid unless proved otherwise. Another strong clue will be erythema nodosum. And do not forget the two important acute sarcoidosis syndromes. One is Lofgren and second is Hereford syndrome. Lofgren is a triad of fever, arthritis, bilateral hilar lymphadenopathy, and erythema nodosum. Whereas Hereford syndrome is a tetrad. It's also called as uveitis fever, where the patient will be having fever, uveitis, parotid enlargement, and facial nerve palsy. So this is going to be Hereford syndrome. These two very commonly asked in exam. And in biopsy, you are going to see non-casting granulomas, which is a confirmatory event, and other investigations will show increased angiotensin converting enzyme levels and calcium. This is because the granulomas expose 1-alpha hydroxylase activity, so they produce more vitamin D. That's the reason for hypercalcemia. And treatment is going to be steroids first line. That's it. So another important ILD that you're going to see in exam is IPF, that is idiopathic pulmonary fibrosis. Patients will be older, usually more than 50 years. They're going to present chronic dry cough and shortness of breath with a classic Velcro kind of basal crackles. These are end inspiratory Velcro basal crackles in the base of the lung. Very dry and fine crackles, Velcro type. And in HRCT, you're going to see UIP, because in any ILD, HRCT is the investigation of choice. And you're going to see subpleural basal honeycombing appearance. In exam, when you see honeycombing, that's the word that is usually going to tell that it is a usual interstitial pneumonia. Treatment is going to be with anti-fibrotic drugs, typically with pirfenidone or nintedanib. Pirfenidone is a TGF beta inhibitor and nintedanib is a tyrosine kinase inhibitor. And you can use lung transplantation at advanced stages. And overall, this disease has poor prognosis and steroid has no role like Guillain-Barré syndrome treatment. And what about bronchiectasis? It's an irreversible medium airway dilatation presenting with chronic cough and sputum with recurrent exacerbations. Again and again, they will get frequent infections. So chronic cough and sputum is this sputum sometimes can be foul smelling. Plus or minus they can have hemoptysis also. And one examination finding that examiner might give is bilateral coarse leathery crackles. Bilateral coarse leathery crackles. Crepitations. Very, very classic of bronchiectasis. Causes usually post-infection like tuberculosis or diphtheria or pertussis, cystic fibrosis and primary ciliary dyskinesia. You know how important is this. In exam, usually patients will have bronchiectasis and they will give history compared with cystic fibrosis and primary ciliary dyskinesia. How will you differentiate? Cystic fibrosis will be having additional GI and pancreatic problems. Patients will have malabsorption, patients will have diarrhea, patients will have steatorrhea, pancreatic problem, diabetes. All this going to tell that it is cystic fibrosis and not primary ciliary dyskinesia. Diagnosis will be based on HRCT. Here, HRCT is the gold standard for diagnosis, where you're going to see the tram track appearance and the signet ring sign. And treatment is going to be supportive with airway clearance and antibiotics for exacerbation. For Pseudomonas, you have to use ciprofloxacin, but ideal drug for Pseudomonas will be toberamycin nebulization. They might ask in exam. Toberamycin nebulization will be very ideal. So coming to paranemonic effusion. So paranemonic effusion tends to occur in the presence of pneumonia. And when you are going to drain means what are the indications for chest drain? Number one, if the effusion is loculated or if you are aspirating frank pus, that is empyema, or if the effusion is complicated. So what are the evidences of complicated paranemonic effusion? pH of the pleural fluid less than 7.2, glucose less than 60, gram stain or culture positivity. And LDH more than 1000, keep it as a last thing in exam because this is revised, but Harrison has not revised it. That's why I'm writing that also. So these are the signs of complicated paranemonic effusion. In that case also, it's better to drain the pleural fluid. In case if it's loculated pleural effusion, you have to use fibrinolytic drugs like streptokinase or alteplase. You have to use fibrinolytic drugs like streptokinase or alteplase to break the loculations. Along with it, you have to add DNase. That is recombinant DNase. You have to instill into the pleural space and you have to break the loculations. What is Light's criteria? So it defined as an exudate if any one of the three is present. If the protein is more than 50% than that of the serum in the pleural fluid, or LDH is more than 60% of that of the serum LDH, or if it is more than 2/3 of the upper limit of the normal, upper limit of the normal of the serum LDH. Okay, so all these three things define an exudate. Even if one is present, it's called an exudate. In exam, the most common cause of pleural effusion is heart failure only, where it will be bilateral effusions with cardiomegaly. And cirrhosis and nephrotic syndrome is also classic causes of transudate because of the RAS activation mechanism. Coming to tension pneumothorax, tension pneumothorax is usually going to follow trauma most of the times in exam. How will you pick up in exam? Absent breath sounds on one side with hyperresonant note on percussion. Classic, it's a clinical diagnosis. Don't wait for the X-ray. It's a clinical diagnosis. So patients might also have additional tracheal shift, mediastinal shift, hypotension, that is low BP, and patients can have jugular tension. All these will confirm that it's a tension pneumothorax only. What will be the treatment? Immediate treatment will be needle decompression either in the second intercostal space in the mid-clavicular line or in the fifth intercostal space in the mid-axillary line, especially in adults. And then you have to proceed with chest tube. You cannot just like that decompress and you can wait and watch. And coming to another important thing, that is high altitude pulmonary edema. So how will you treat high altitude pulmonary edema? Descent, the most important treatment. High altitude cerebral edema also, the most important treatment is descent, or you're going to use portable hyperbaric bag to begin with. So descent, how much? At least by 500 meters descent is going to give a lot of relief in the symptoms. And in case it's a pulmonary edema, you can try oxygen, nifedipine or sildenafil if you have it. Or if it's a cerebral edema, you can try oxygen and dexamethasone. In cerebral edema, dexamethasone is the most important treatment in case if you cannot descend down. So I'm talking about descent is the most important. But if you cannot descend, then these are the options. And in case if they mention acute mountain sickness, then treatment as well as prophylaxis will be acetazolamide. Astazolamide. Let me write. You don't think of altered mental status. In case if you think of acute mountain sickness, that is a milder form of illness, then in this case, you're going to use acetazolamide. Otherwise, no. You're going to use astazolamide for prophylaxis as well as treatment. So what about the heat stroke treatment? Heat stroke patients will present with severe increase in temperature, but they will have anhydrosis. That's a clue in exam. Classic heat stroke patient will be having no sweating and anhydrosis. The treatment of choice is rapid cooling with ice packs, immersion, evaporative cooling, and you have to give IV fluids and monitor for rhabdomyolysis and DIC. All these are important, and antipyretics won't work here. Okay, paracetamol doesn't work. And frostbite, here the most important clue will be numbness of the extremity, that is frostbite. And here the treatment of choice will be rewarming at 30 to 40 degrees Celsius of rewarming solution like water. And tetanus prophylaxis, NSAIDs and opioids for pain should be given. And you can do thrombolysis if it's less than 24 hours in MRA shows occlusion. In case if there is obvious necrosis, then amputation has to be done. But mostly they will ask about the temperature of the rewarming solution, that is 37 to 40 degrees Celsius, and the presentation will be with numbness. And grading will be done after rewarming depending on the extent of cyanosis. So motion sickness is different from mountain sickness, right? For motion sickness, what will you do? You're going to treat with scopolamine patch or diamond hydronate. So ginger acupressure does work for motion sickness, but the first line treatment will be scopolamine patch, and you can use antihistaminics like diamond hydronate. You can use meclizine, cyclizine, cinnarizine. You can use whatever you wish to. So in sepsis, the most important will be the Q-SOFA score in exam. Any one should be there. That respiratory rate more than 22, altered mental status, systolic BP less than 100. If you have at least 2 out of 3, sorry, if you have at least 2 out of 3, then it indicates a high mortality. 2 out of 3 indicates a high mortality. 2 out of 3 indicates a high mortality. So treatment will be with broad spectrum antibiotics within 1 hour. But remember, you have to take at least 2 hours after blood culture. After blood culture. So post 2 sets of blood culture. At least 2 blood culture should be taken, and then only you have to start with broad spectrum antibiotics. You know what are the broad spectrum antibiotics? The 5 drugs that we often discuss: piptazo, meropenem, imipenem, ceftazidime, cefepime. Any one of these drugs has to be given, and patient should receive a fluid bolus of 30 ml per kilogram and vasopresses in case if the patient is not responding to fluid resuscitation. So the next step after fluid resuscitation is vasopresses. Typically, the first choice drug is going to be norepinephrine. Plus or minus, if you want, you can add vasopressin according to the guidelines. Vasopressin. So first will be fluids. If it doesn't work, then give noradrenaline plus or minus vasopressin. Source control. If the vein is having any abscess or something like that, you have to drain that abscess. That's it. So have you understood the pulmonary medicine, guys? Whatever I told you, right from spirometry to asthma to COPD to ARDS treatment, NIV contraindications, sarcoidosis, IPF, bronchiectasis, Light's criteria, parapneumonic effusion, tension pneumothorax, environmental emergencies, motion sickness, and drug of choice in Clostridium difficile is fidaxomicin. Right now, drug of choice for C. diff colitis is what? Fidaxomicin. Second choice is only oral vancomycin. In nephro, what are the things that you have to look for? You have to look for what? ABG. One question usually you will get from ABG. So, what are the 3 things often you will see? You will see a pH, whether it's less than 7.4 or more than 7.4, PaCO2 less than 40 or more than 40, and bicarbonate less than 24 or more than 24. That's it. And you're going to use the classic Rome rule. You all know that. Respiratory means opposite, metabolic means equal. We have discussed so many times in our classes that if pH and other 2 arrows are moving in opposite direction, that is respiratory. If and other 2 arrows are moving in the same direction, it is going to be metabolic. So you know how to find out a metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. So in case if you're dealing with metabolic acidosis, you're going to look at anion gap. Anion gap means sodium minus chloride plus bicarbonate. If it's more than 12, you're going to think in terms of Goldmark causes. If it's less than 12 in metabolic acidosis, you're going to think in terms of DRS causes. What are the DRS causes? It is diarrhea, renal tubular acidosis, saline. Diarrhea, renal tubular acidosis, saline. Right? What are the Goldmark glycols? Oxoprolin, L-lactate, D-lactate, methanol, aspirin, renal failure, and ketoacidosis. So glycols, oxoprolin and paracetamol, L-lactate, D-lactate, methanol, aspirin, renal failure, ketoacidosis. Okay, these are the classic HAGMA causes, that is Goldmark. And you are going to use Winter's formula for sure in metabolic acidosis and alkalosis. Using Winter's formula, you can find out is there any second disorder. But generally in exam, it's not required at FMG level. I've seen so many questions in the past. It's going to be only based on anion gap and the Rome rule. That's it. If you know those two, that's more than enough. I mean, if you're running short of time. Otherwise, you can study the Winter's formula also and go, which is going to be an extra edge. Never forget sediments. So in case if you're dealing with RBC cast, glomerulonephritis is the only thing that you're going to think. In case if you see WBC cast, you're going to think in terms of pyelonephritis and acute interstitial nephritis. In case if you're thinking in terms of muddy brown cast, it indicates acute tubular necrosis. And in case if you're seeing crystals, see what crystals. If you're seeing uric acid crystal, think in terms of tumor lysis syndrome, which will be rhomboids and rosettes. If you're seeing oxalate crystals, then think in terms of malabsorption, or routine crystals are also going to be oxalate stones only. Oxalate crystals is going to be what? Which shape? It can be either envelope shape if it's dihedral crystal, or it can be dumbbell shaped if it's a monohedral crystal. Or you can see various drug-induced crystals also like acyclovir, which will be needle shaped, classic, or you can see methotrexate crystals or indinavir stones, or you can see sulfur crystals also. These are the various drug-induced crystals. And the shapes we have discussed so many times in both lab 1, lab 2, everywhere we discussed. Coming to nephrotic syndrome, what are the things that you should not forget in nephrotic syndrome? So nephrotic syndrome is characterized by RBC cause and hematuria, and they will have dysmorphic RBCs, but RBC cause are the most important. Even one RBC cause is equal to glomerulonephritis, and proteinuria will be there. It will be less than 3.5 grams per day, and patients will have hypertension and oliguria. It's not like patient will not have proteinuria. Patients will have proteinuria, but only they will have subnephrotic proteinuria. They will not have nephrotic range proteinuria. So whenever you are encountering a classic glomerulonephritis, what you have to see in exam, you have to see immunofluorescence. If immunofluorescence is negative, always test for ANCA, whether it's C ANCA or P ANCA. C ANCA means vaginous granulomatosis, P ANCA means Chuksta syndrome or microscopic polyangiitis. In case if immunofluorescence is positive and it tells a smooth linear pattern, think of Goodpasture syndrome or anti-GBM disease, right? Goodpasture syndrome or anti-GBM antibody disease. In case if it's positive and if it's a granular immunofluorescence, it's 100% confirmed you're dealing with immune complexes. Now the next step is to look at C3. If you're seeing a low C3, think about PSGN, post-streptococcus glomerulonephritis, SLE or cryoglobulinemia. In case if you're seeing normal C3, think in terms of IgA nephropathy or henoch-Schönlein purpura. Remember, IgA nephropathy is strictly kidney-limited disease, whereas HSP will be a systemic disease with purpura, arthritis, abdominal pain, and all those things. Similarly, PSGN is a strictly kidney-limited disease, whereas SLE will be a systemic disease with arthralgia, rash in the face, and all these things. And you know, in SLE, patients will have ANA positivity and anti-DST-ANA positivity. And if it's a cryo, patients will be having HCV positive. Very, very important. If there is HCV, always think of cryo in exam. I told you so many times. And what about nephrotic syndrome? So here the patient is going to present nephrotic range proteinuria, that is proteinuria more than 3.5 grams per day. Along with that, patients will be having hypoalbuminemia less than 3.5 grams per deciliter. Patients will have edema because of RAS activation, and patients will have hyperlipidemia because of loss of your HDL predominantly, right? And whenever you see a nephrotic syndrome case, and if you have a normal light microscopy in exam, it is minimal change disease unless proved otherwise. And you know, this is more common in children less than 10 years of age. And in case if you're seeing a focal sclerosis, a pinkish material within the glomerulus, think in terms of a FSGS, that is focal segmental glomerulosclerosis, where in exam the usual clues will be HIV, heroin use, bisphosphonates, blacks, and all those things. In case if you're seeing a epimembranous spike, thickened basement membrane with epimembranous spikes, think in terms of membranous glomerulonephritis, which is commonly seen in patients with hepatitis B virus or solid organ tumors, or one antibody that is related is anti-phospholipase A2 receptor antibody. So all these things are going to think. And yes, SLE also can cause membranous class 5 type. So but important is HBV in exam, and anti-phospholipase A2 receptor antibody is also important. In case if you're seeing double basement membrane contours producing tram track appearance, then think in terms of a membranoproliferative glomerulonephritis. Simple. If you see a nephrotic picture, if you see any one of this, depending on whether it's normal or abnormal, see light microscopy or others. If it's sclerosis, FSGS. If it's membranous spikes with thickened basement membrane, MGN. If it's double contour tram track appearance, think in terms of MPGN. In case if you're seeing a nodular mesangial expansion, this is characteristic of diabetes mellitus, which is also called as what? The famous Kimmel-Steele-Wilson lesions. Understood, guys? Yes or no? Got it? Okay. So coming to the management of hypertension. So in exam, if they ask you the gold standard for diagnosis of hypertension, it must be ABPM, that is ambulatory blood pressure monitoring. So what is the first line treatment for most hypertension patient? Lifestyle. Almost all patients will receive lifestyle advice like the DASH diet, exercise, weight loss, and low salt diet. All these things has to be tried. Even high potassium diet, all these things have to be tried. And in case if it's essential hypertension, the first line treatment will be ACE inhibitors with ARBs. I'm not talking about first like it is first line. First line treatment is ACE inhibitors, ARBs, or you can use CCBs, or you can use thiazides. Generally, at least two drugs will be used in combination. That's called FDC pill. That is fixed dose combination pill. At least two drugs will be used as a part of FDC, that is fixed dose combination pill. In case if the patient is having diabetes, or probably if the patient is having proteinuria or CKD, then ACE inhibitors or ARBs will be the first line drug. And in CKD, there is an algorithm that can be asked in exam. See, in CKD, whether the patient is having proteinuria or not, that's very, very important. If the patient is having proteinuria, then ACE inhibitors or ARBs will be the first line preferred drug. If the patient is not having proteinuria, then look at edema. If the patient is having edema, then in this case, you're going to use diuretics. Typically, I'll be preferring thiazide diuretics than loop diuretics in this case, because I've explained this already so many times in class. In case if the patient doesn't have edema, then once again, I'm going to use ACE inhibitors or ARBs. This will be the choice. But remember, for hypertension and CKD, thiazides will be the best drug regardless of GFR. Very, very important point. Loop is not going to be effective for treating BP. And target BP according to most guidelines is less than 130/80. In case if you see that the patient is having a resistant hypertension, what is resistant hypertension? At least three drugs are already there. In that, at least one drug must be a diuretic. And the patient's BP is still more than 140/90. You can call it as resistant hypertension. In that case, you can empirically add spironolactone, an old exam question. So coming to the types of AKI, we have something called post-renal AKI. So how will you diagnose post-renal AKI? In exam, the classic clue will be bilateral hydronephrosis on ultrasound, or they can give another important clinical clue called as palpable bladder. They might give another important clinical clue called as what? Palpable bladder. If the bladder is palpable, so that is also sign of post-renal AKI only. And patients can also have additionally increased post-viral residual urine if there is a bladder neck obstruction like prostate. So what are the usual causes? BPH, stones, tumors, obstructed Foley's catheter, and neurogenic bladder and spinal cord injury. So these are the usual causes. The most important treatment is to relieve obstruction. If it's bladder neck obstruction, Foley's will be the best option, or SPC if it's not possible. If it's a ureteral level obstruction, go for a DJ stenting. That's it. In case if it's an acute intestinal nephritis, how you're going to diagnose? In exam, classically patients will be having drug history like NSAIDs, antibiotics like penicillin group of drugs. And after that, patients will develop fever, rash, and eosinophilia. Classic triad along with AKI. And in the urine, you're going to see lots and lots of WBC. You will see WBC cast. It's not like no cast. Sorry for that. You'll be able to see what? WBC cast, and you will see eosinophils in the urine and lots of WBC. But if you do culture sensitivity, it's going to be negative. It's going to be negative if you see culture. That's why this is a very important cause of sterile pyuria. And biopsy will show interstitial inflammation. Treatment is supportive. And what about acute tubular necrosis? The typical clue in exam will be muddy brown cast, and FeNA will be more than 2%. FeNA will be more than 2%, and urine osmolality will be less than 350, and Bund creatinine ratio will be less than 15. All these three are very important parameters for acute tubular necrosis. In case if it's a pre-renal AKI, FeNA will be less than 1%, urine osmolality will be more than 500, and Bund creatinine ratio will be more than 20. All these parameters are so important in exam. It is very commonly asked. And what are the causes? Typically in acute tubular necrosis, you're going to look for ischemia or some nephrotoxins like vancomycin, aminoglycoside, something like that. And treatment is only supportive. And dialysis for standard indications. That's it. So coming to contrast-induced nephropathy versus atherembolic disease. So first, contrast-induced nephropathy will occur post-contrast, and it occurs in the first 2 days itself. Patients will not have eosinophilia, and C3 will be normal. And if you want to prevent, the only way to prevent is IV fluids, nothing more than that. In case if you're dealing with atherembolic disease, usually it happens after catheterization, then contrast. Patients will have rash called livedo-reticularis rash and occurs later, day 4 to day 7. Eosinophils will be there in the blood and low C3. There will be eosinophilia and low C3. Low C3 is a very important point. So this is how we differentiate a contrast-induced nephropathy versus atherembolic disease. And what's the TMA, thrombotic microangiopathy triad, that you should never forget in exam? So microangiopathic hemolytic anemia, that is evidence by cystocytes, thrombocytopenia, and end organ damage. In case if end organ damage is AKI, think about HUS. In exam, other clues will be children with bloody diarrhea, where there will be infection with enterohemorrhagic E. coli that produces the Shiga toxin, and the strain will be O157H7, and the treatment is going to be supportive. No antibiotic should be given. Very, very important point. And in case if end organ damage is CNS dysfunction, it is TTP unless proved otherwise, where the problem will be Adams 13 defect of less than 10% level, and treatment is going to be with plasma exchange. And platelets are contraindicated in all HUS TTP patients and HIT patients. HIT means heparin-induced thrombocytopenia. Do not use platelets in these cases. What are the dialysis complications? So one of the most common complications is going to be hypotension, which can be treated with IV fluid bolus. They can develop cramps, infection and all. And they can develop disequilibrium syndrome, which is going to produce neurologic problems like altered mental status. Treatment is going to be with mannitol. And amyloidosis can develop in the long term. And the usual reason for amyloidosis will be beta 2 microglobulin, which is going to present in the form of carpal tunnel syndrome and shoulder arthritis. Classic. And how PD peritonitis will present? PD peritonitis is going to present with the cloudy effluent. This is the first problem that happens in this patient, a cloudy turbid effluent, and patients will have abdominal pain. And if you look at the fluid, your WBC will be more than 100 with more than 50% neutrophils, or we can say more than 50 neutrophil. And treatment will be with vancomycin and ceftazidime. The most important treatment is intraperitoneal vancomycin. It's not intravenous, it's intraperitoneal vancomycin and ceftazidime, right? And what about the kidney donors? I told you so many times that live donation is always better than cadaveric donors. And when it comes to live donor, the matched sibling donor is the best donor, followed by matched unrelated donor. These are also called as MRDs, or matched related donors. When it comes to cadaveric donors, the modified Maastricht 3 and 4 are going to be better. 3 are the ones who are going to have expected cardiac arrest, and 4 are the ones who are having cardiac arrest after declaration of brain death. 3 are those patients who are having expected cardiac arrest, and 4 are those patients who are having cardiac arrest after brain death. So don't forget to study the modified Maastricht classification in exam. And what is the immunosuppression guidelines for kidney transplantation? Induction therapy can be given with besiliximab or anti-thymocyte globulin. In India, commonly we use ATG, but besiliximab is also fine. Besiliximab is a anti-CD25. It's a CD25 blocker, which is also written as IL-2 receptor alpha blocker. Both are same only. And maintenance can be done with tacrolimus with MMF and steroids. I told you. Alternative to tacrolimus will be cyclosporin, but it's less preferred. Alternative to MMF will be azathioprine, less preferred. This is a standard combo that we use for any solid organ transplantation. So what is the CMV risk in kidney transplantation? Prophylaxis has to be given for all patients with Valgan cyclovir for 3 to 6 months. And in case if the patient is having active infection or flare-up of CMV, ganciclovir is the drug of choice. And it has to be given IV ganciclovir. The most common side effect is bone marrow suppression. What about ADPKD treatment? Most patients will require BP control with ACE inhibitor, standard drug of choice. And in case if you want to slow down the disease progression, the only option is going to be tolvaptan. And ultrasound abdomen is the investigation of choice or the gold standard for both diagnosis and screening, where we use that Raven's criteria. And all the patients should be screened for berry aneurysms, because there is 5 to 10% patients will have berry aneurysms. And there is a risk of subrectal hemorrhage in these patients. So mostly they will target what is the investigation of choice, that is ultrasound abdomen, and they will target the BP control with ACE inhibitor, and they will target tolvaptan that can be used to reduce disease progression. And anemia of chronic kidney disease, how you are going to treat? You are going to treat with erythroid stimulating agents. But before giving erythroid stimulating agent, you have to rule out iron deficiency. Iron deficiency, how will you say? If the ferritin is less than 100 in CKD patients, or if the transferrin saturation is less than 20% in CKD patients, you are going to call it as iron deficiency, and you have to give IV iron always. If the patient is receiving erythroid stimulating agent, the choice of iron is always IV iron, not oral iron. When you are going to use oral iron, if the patient is not on hemodialysis and not starting ESA and having iron deficiency. So not on hemodialysis, not starting any erythroid stimulating agent, plus if the patient is having iron deficiency, then oral iron will be the choice. Otherwise, for many other patients, IV iron is the best form of iron in patients with CKD. And what about renal osteodystrophy? So renal osteodystrophy means patients will be presenting with a lot of electrolyte abnormalities like calcium, hyperphosphatemia, low calcium hyperphosphatemia, high PTH, high alkaline phosphatase. Along with that, bone issues. Along with that, patients will be having bone issues. This is typical renal osteodystrophy. In adults, the most important is actually the high phosphorus only. If it is there, always give phosphate binders. And the classic phosphate binder of choice is 7-MR. Right? That's the first thing that has to be corrected in adults. And vitamin D analogs and calcium are very important in children because of the growth. So in case if there is hypocalcemia or low vitamin D, you have to give calcium and vitamin D analogs. Typically, we are going to use calcitriol because in chronic kidney disease, they cannot convert calcitriol to calcitriol. So straight away give calcitriol. And in case if there is uncontrolled hyperparathyroidism, you can use sinacalcet, which is a calcium mimetic. It can suppress the PTH output from the parathyroid gland. Sinacalcet can release the PTH release from the parathyroid gland because it's a calcium mimetic. So, and do not forget AIOU. So, what is AIOU? These are the indications for dialysis. What are they? Refractory acidosis, refractory electrolyte imbalance, especially hyperkalemia, intoxication with dialysable drugs. What are those dialysable drugs? Blissmed. We have discussed that already. Barbiturates, lithium, isoniazid, salicylates, theophylline, metformin, methanol, methotrexate, ethylene glycol, Depakote, that is valproate. Do you remember, guys, the Blissmed drugs? Barbiturates, lithium, INH, salicylates, theophylline, metformin, methanol, methotrexate, ethylene glycol, and Depakote. Depakote is valproate brand name, right? So Blissmed are dialysable, but you know what are the drugs that are not dialysable also, like warfarin, amiodarone, anticoagulants. Anticoagulants means except dabigatran. The only dialysable drug is dabigatran among the anticoagulants. Apart from that, other anticoagulants are not dialysable, and Dig also is not dialysable. So warfarin, amiodarone, digoxin, classic non-dialysable drugs. So make a note of that also. And in volume overload state, that is refractory pulmonary edema. So that is diuretic resistant pulmonary edema. It's better to do dialysis. And uremic complications. What are the uremic complications, especially in exam? Uremic pericarditis, uremic encephalopathy, uremic pericarditis, uremic encephalopathy, and severe bleeding, refractory uremic bleeding. So in these cases, it's better to do dialysis like as a standalone therapy. And I mean, in case if they ask uremic bleeding, what is the first line treatment? First line treatment for CKD bleeding. What is the answer? It is desmopressin. It is desmopressin, right? So that will be the first line treatment for uremic bleeding. We have discussed that so many times. It's going to be desmopressin. So have you understood, guys? The nephro important topics, what all you need to know? So what's important ABG? So the sediments, what are important? Nephrotic syndrome, how to evaluate hypertension, post-renal AKI, AN, ATN, contrast nephropathy, atherembolic disease, TMA, HUS, TTP, treatment of them, dialysis complications, peritoneal dialysis, kidney transplantation, okay, CMV, ADPKD, anemia of chronic kidney disease, renal osteodystrophy, and final indications for dialysis and AKI. So if you want a break, I'll give you for 5 minutes. We'll start at 12:15. Maybe usually it will get over by 1:15, 1:30 mostly. We'll finish off in 1:15, 1:30. Don't worry about it. Okay. Okay. Anyway, no problem. So you can take a break. 5 minutes, no, 12:15 will start. Hello, guys. Welcome back. I think we can start the session. We'll try to finish off in the next 1 hour. Are you guys there? Okay. All right. So, what are the important things that you get in endocrine? So, you're going to get definitely one question on prolactinoma and acromegaly. One question surely will come, and the remaining questions will be coming from diabetes treatment. So, in prolactinoma is going to be more common in females. Acromegaly can occur in males as well as females. In exam, you'll usually get a male. It's easy to frame a question based on a male. Whereas prolactinoma, it's easy to frame a question based on a female. So the gender also matters. So the most common problem in patients with females with prolactinoma is going to be amenorrhea and infertility. Galactoria can occur, but amenorrhea infertility will be the classic presentation. And these patients are going to have high prolactin, and in MRI are going to see a mass in the pituitary. We know whenever you talk about a pituitary tumor, MRI is the investigation of choice. And what is the first line treatment? So in case if the patient is having macroprolactinoma, that is a tumor size of more than 1 centimeter, or if the patient is having symptoms, then the first line treatment will be cabergoline. Only when they mention clearly that the woman is desiring pregnancy or already pregnant, then in this case you can prefer bromocriptine, otherwise cabergoline will be the first choice. What about acromegaly? So mostly males, they'll have coarse features and they will come with enlarged hands. Coarse features means the coarse facial features, the frontal bossing, prognathism, dental malocclusion, all these things will be there. Along with that, enlarged hands will be there. So if you are suspecting acromegaly, first line treatment will be IGF-1. So it is one of the best test ever. So age matched IGF-1, screening test, best test, all that answer is IGF-1 only. And confirmation will be done with 75 gram OGTT. So this is a confirmatory test. After 75 gram of glucose load, if growth hormone is not suppressed, it is confirmed that the patient is having growth hormone excess. Treatment of choice is surgery, that is transphenodal surgery. And in case if the patient is unfit for surgery or a failed surgery, then you can use medical treatment like octreotide, lanreotide as a first choice. These are somatostatin receptor ligands or SSTR agonists. In case if that doesn't work, you can go for a newer SRL like pasireotide, or you can use pegvisomant, which is a growth hormone receptor blocker. So all these drugs you can use in case if you wish to. And what will be the treatment of diabetes? The first line treatment for type 1 diabetes is insulin. There's no doubt about that. It's an insulin dependent diabetes at the end of the day. And in type 2 diabetes, in many cases, we start with metformin only. But in case if you want a cardiovascular renal benefit, you are going to use SGLT inhibitors or GLP-1 receptor agonists. And GLP-1 receptor agonists are very, very good if BMI is more than 30. If BMI is more than 30, then GLP-1 receptor agonist is very, very good. Or the patient is wanting to lose weight. If the patient is obese or the patient is wanting to lose weight, definitely GLP-1 receptor agonists are very, very good, like semaglutide, liraglutide, tirzepatide, all these things are very, very good. But SGLT inhibitors have the best cardiorenal benefit. If they ask you the best cardiorenal benefit, it's going to be SGLT inhibitors. Okay, what are the important drug side effects? Metformin can cause GI side effects more commonly like diarrhea, which is unexplained diarrhea, and lactic acidosis. And sulfonylureas are prone for hypoglycemia. And DPP-4 inhibitors and GLP-1 receptor agonists are basically incretin drugs which can cause nausea, gastroparesis, and pancreatitis in some patients. And pioglitazone can cause fluid overload. That's the reason why it is absolutely contraindicated in heart failure patients. And SGLT inhibitors tend to produce candidiasis and euglycemic ketoacidosis. And one has to avoid GLP-1 receptor agonists if the patient is having history of MTC, medullary thyroid cancer in the family. And one has to avoid pioglitazone if the patient is having history of bladder cancer or family history of bladder cancer. All these are like kind of important questions in exam. So mostly your questions will be framed around these things only. So coming to Cushing syndrome, in Cushing's, it's easy to find out patients will present with weight gain, purple striae, and all these things. And there are three things that you can use for to screen Cushing's. One is late night salivary cortisol, which is the test with has the maximum sensitivity for Cushing syndrome, and overnight dexamethasone suppression test, which is a kind of low dose dexamethasone suppression test only. Or you can do a 24-hour urine free cortisol. Any one can be done, but in that we prefer either ODST or late night salivary cortisol. So once you know it's a Cushing syndrome for sure based on this test, the first test of localization is going to be ACTH. You need to know whether it's ACTH dependent disease or ACTH independent disease. If ACTH dependent disease means it must be ectopic or probably pituitary disease. If ACTH independent means it must be adrenal disease. Based on that, you can investigate further. But if they ask you investigation of choice for Cushing's disease means we are talking about a pituitary adenoma causing Cushing syndrome. For that, MRI will be the investigation of choice. If they ask you gold standard for diagnosis of Cushing's disease, that is the pituitary adenoma causing Cushing syndrome, it is bilateral inferior petrosal sinus sampling. This will be done only in discordant cases, only if confusing or discordant picture, then only you do bilateral IPSS, otherwise you don't do bilateral IPSS. We have discussed all these things in an algorithm beforehand. So first test of localization ACTH, investigation of choice for Cushing's disease MRI, gold standard for diagnosis of Cushing's disease is bilateral IPSS. And there is an important thyroid syndrome called as sick thyroid syndrome. So again, a common question exam, we're going to have a low T3, high reverse T3 and a normal T4 and TSH. And this happens in any critical illness. So low T3, high reverse T3, normal T4 and TSH. In fact, the only problem in the TFT will be low T3 in most cases. This requires no treatment, only treatment of underlying cause is going to be more than enough in these patients. Okay, CQ thyroid patients. And coming to primary hyperaldosteronism, the presentation will be with hypertension, hypokalemia, and alkalosis classic. In that, hypertension and hypokalemia is the most important. And some patients present only with hypertension. Hypertension is the number one feature, right? Hypokalemia is the second most common. Alkalosis is not very common. And patients are going to have high aldosterone and low renin if it's a primary hyperaldosteronism. It is also called as Conn syndrome if it's caused by adrenal adenoma. And diagnosis can be done with aldosterone renin ratio being more than 20, or you can prove high aldosterone and low renin. Anything is fine. So you have to do a CT for looking for adenoma in the adrenal gland, and treatment is going to be either spironolactone if you don't find an adenoma, or if you find an adenoma, you can do adrenalectomy on that side also. So what will be the typical Liddle's presentation? It's going to present like your hyperaldosteronism with hypertension, hypokalemia, and metabolic alkalosis. But these patients will have low aldosterone and low renin because the problem here is ENaC hyperactivation and not aldosterone. That's why the treatment of choice here will be amiloride. And what about pheochromocytoma? It can produce episodic hypertension, paroxysmal hypertension with paroxysmal headache, sweating, and palpitation. This is also called as the famous pheo triad or pheocrisis triad. And diagnosis will be done with 24-hour urinary metanephrine. So in case if the metanephrines are elevated, you're going to localize the abdomen with CT or MRI of the abdomen. And one has to definitely do PET-CT to rule out metastasis, because if metastases are there, you're going to make a diagnosis of malignant pheochromocytoma, and the standard PET-CT of choice will be the fluorodopa scans, F18 dopamine scans, or you can use gallium-68 base scans. Gallium-68 Dotadoc or Dotonic, all these Dotanox scans can be used in case if you want to. That's the best kind of scan. And the treatment will be alpha blocker to control hypertension first. In that, we are going to use phenoxybenzamine as a first choice, and then followed by beta blocker if the patient is having tachycardia. But the most important drug here is alpha blocker, that is phenoxybenzamine, and then you are going to do surgery, which is considered to be the treatment of choice. And how to diagnose SAAD, that is syndrome of inappropriate antidiuresis in exam. Patients will be usually hospitalized. The reason why I'm saying that is SAAD is the most common cause. I mean, in a hospitalized patient, the most common cause of hyponatremia is SAAD. And patients will be euvolemic. What is euvolemic? No fluid overload state, no dehydrated state also. So there will be no sunken eyes, skin turgor will be normal, mucosa will be wet. BP will be normal, JVP will be normal, no ascites edema. So clinically patient is euvolemic, and such a patient is having hyponatremia with high urine osmolality more than 100 and high urine sodium along with low uric acid. This confirms that you are dealing with the syndrome of inappropriate antidiuresis. The first line treatment in SAD is fluid restriction. Vaptans are only add-ons. In severe patients, maybe you can add on tolvaptan, but otherwise fluid restriction will be the first choice treatment. So what will you see first in polyuria? Always do intake output chart to confirm true polyuria, because many times it will be irritable bladder. So confirm true polyuria where the urine output must be more than 3 liters per day, or more than 100 ml per kilogram, 40 ml per kilogram per day, or more than 2 liters per meter square per day. So once you have confirmed case of polyuria, then check the urine osmolality. If urine osmolality is less than 300, this indicates a water diuresis. This indicates a water diuresis. There are only two causes of water diuresis in the world. One is going to be diabetes insipidus, and second is psychogenic polydipsia. Remember, psychogenic polydipsia will respond to water restriction, respond to water deprivation, right? Psychogenic polydipsia will respond to water deprivation. Urine osmolality will become more than 300. Whereas if you look at central diabetes insipidus, it will respond to desmopressin. It will respond to desmopressin. Whereas nephrogenic diabetes insipidus will not respond to nothing. It responds to nothing. which means it won't respond to water deprivation also, it won't respond to desmopressin also. This is basically nephrogenic diabetes insipidus. We know that. So this is how you differentiate in exam, right? So what will be the treatment of central diabetes insipidus? Obviously desmopressin, and treatment of nephrogenic diabetes insipidus is going to be thiazide diuretics. And one should not forget about metabolic syndrome also in exam. There are 5 parameters. Out of these 5, if you have 3, you can call it as metabolic syndrome. So waist circumference more than 102 centimeter in males or more than 88 centimeter in females. Triglyceride more than 150, HDL less than 40 in males and less than 50 in females. BP more than 130/85, fasting blood sugar more than 100. So if you have 3 out of 5, it's called as metabolic syndrome. And the most common complication of metabolic syndrome is diabetes mellitus in the future. And there are a lot of complications are there. And LDL is not a part of metabolic syndrome criteria. So obesity, what is the first treatment? First treatment is basically lifestyle modification. LDL not increased. LDL will be increased in many patients metabolic syndrome. LDL is not a part of metabolic syndrome criteria, that's all. Not included. Okay, I thought it's not increased. I got shocked. Okay, good then. Good for you. So lifestyle, okay. So lifestyle means, so diet, exercise is going to be the most important, but it's very difficult to sustain. So you can use pharmacological treatment if BMI is more than 30 or more than 27 with comorbid condition like diabetes, hypertension, OSA and all. The drugs that are used is orlistat, which is a lipase blocker, or you can use liraglutide, which is a GLP-1 receptor agonist. But liraglutide is more famous now. And you can use tirzepatide also. I didn't include that. You can use tirzepatide, which is exclusively approved for obesity separately. And when you are going to do bariatric surgery can be done if the BMI is more than 40 or more than 35 with comorbid condition. The usual treatment that we do is Roux-en-Y gastric bypass, but you can do laparoscopic adjusted gastric banding or you can do vertical sleeve gastrectomy also. So these are the options for treatment of obesity. Have you understood, guys? We have completed endo also. I started from pituitary, the most important topics, then the diabetes, the important areas, then Cushing's, uh, euthyroid, primary hyperaldo, Liddle's, pheochromocytoma, SAAD, so diabetes insipidus, psychogenic polydipsia, metabolic syndrome, and obesity. All these things are important. In exam, don't forget Addison also, very common question. So Addisonian crisis, usually patients will have hyperpigmentation. That's a strong clue. Hyperpigmentation, and the patients will be having shock whenever they're having low BP and shock. So this is almost always Addison unless put otherwise in exam. In this case, the first line treatment will be IV fluids, especially with NS, but the best treatment will be IV glucocorticoid steroid like hydrocortisone or dexamethasone. This is the best treatment. Okay, so this will be the standard thing that will be asked in exams, Addison disease. So coming to rheumatoid arthritis, so RA is a chronic, inflammatory, symmetric, seropositive, small joint erosive polyarthritis. We know that. So chronic means by definition more than 6 weeks in general. Inflammatory means patients will have early morning stiffness for more than 1 hour and the pain and stiffness will improve with exercise and it will worsen with rest. It's a symmetric seropositive arthritis. We know that. And it's going to affect the small joints, typically the MCP, PIP and the wrist joints. And you know there are two areas that are not affected, that is DIP and the thoracolumbar spine. So DIP is not affected, thoracolumbar spine is also not affected. So the only part of spine that will be affected is the cervical spine that will be affected, and it's an erosive arthritis. Over time it will produce erosions and it's a polyarthritis. It's going to affect multiple joints. So remember, rheumatoid factor will be positive in many patients, but it is not specific, but anti-CCP is very, very specific. Treatment is going to be with DMARDs. The first line treatment is methotrexate, but anti-TNF is the most effective drug. It is the best drug in patients with rheumatoid arthritis. And you know what is triple therapy, what are the side effects of these drugs, what are JAK inhibitors, all these things we have discussed, what are the deformities, what are the extra-articular manifestations, including subcutaneous nodules. Most common cancer is DLBCL. Most common cause of death is cardiovascular risk. Anything can be asked in rheumatoid arthritis. Be prepared. It's a very important topic for any exam. Coming to ankylosing spondylitis, it's going to be seen in young males less than 30 to 40 years. They'll present with inflammatory back pain, especially low back pain. So, which will have early morning stiffness for more than 1 hour again, and it will improve with exercise as usual. And patients will have very good response to hot water and NSAIDs. And the patients are going to have bilateral sacroiliitis, classic clue in exam. So to diagnose sacroiliitis, X-ray will be the first investigation, but MRI will be the best investigation. Later on, we'll do MRI if X-ray is not revealing. And patients will have reduced chest expansion due to bilateral upper lobe fibrosis because of bilateral upper lobe fibrosis, and patients, most of them will be HLA-B27 positive. And NSAIDs is the first line treatment not first line again, first line. So NSAID is the first line treatment for inflammatory back pain. In case if patient doesn't respond to it, then you can use anti-TNF drugs like infliximab or adalimumab. And what about reactive arthritis? Reactive arthritis usually occurs after a GI or a GU infection. GI means chlamydia, GU means Shigella, especially Shigella flexneri, and it's going to present the triad of can't see, can't pee, and can't climb a tree. That is conjunctivitis, uveitis, urethritis, and arthritis. So this will be the classic triad in exam, and most of the cases are self-limiting. You're going to treat with NSAIDs, maybe with a little bit of steroids. That's it, nothing more. It's a self-limiting disease, and these patients also will be having HLA-B27 positivity. What about SLE diagnosis? It's going to occur in a young female, usually in the 20s and 30s, and they're going to present mucocutaneous problems like rash, alopecia, and ulcers. Rash, alopecia, and ulcers. It will be a non-scarring alopecia, you know that, and rash will be malar rash typically, and ulcers will be painless ulcers. And patients will have arthralgia, arthritis, and you all know that the most common manifestation in SLE is arthralgia. Almost 90% plus patients will be having arthralgia, right? And patients will have multisystemic involvement like lupus nephritis, patients can have CNS involvement, or patients can have hematological involvement like ITP, autoimmune hemolytic anemia, TTP, and so on. So, ANA is the most sensitive test with 99% plus sensitivity. It's an entry criteria. Without ANA positivity, you cannot diagnose SLE. And patients, but anti-Smith and anti-DS DNA are the most specific. We all know that. And among the lupus nephritis, the class 4 lupus nephritis is the most common, that is diffuse proliferative variety, which can cause wire loop lesions as well as full dose immunofluorescence in immunofluorescence analysis. And what are the other important antibodies here? Antiro antibody, exam question. It can cause neonatal lupus, which can progress to complete heart block, which is irreversible, and patients can develop photosensitivity and subacute cutaneous lupus. And anti-U1 RNP is related to mixed CTD, and anti-histone antibodies related to DILE, that is drug-induced lupus. In that, the most important drugs is going to be the SHIP-MD group of drugs, which is sulfa, hydrolazine, INH, procainamide, methyl dopaminocycline, and D-penicillamine. We discussed that already, the SHIP-MD group of drugs. And don't forget infliximab. Don't forget infliximab. Anti-TNF drugs also can produce DILE, that is drug-induced lupus erythematosus. And anti-ribosomal protein antibody has been linked to psychiatric problems like psychosis, depression, even though this is a big question in modern practice. In exam, you have to answer, but. And what about scleroderma antibodies? So we have scleroderma means the most important thing is skin thickening. If scleroderma happens without skin thickening, that's called as sign scleroderma. We know that. But most scleroderma cases will be having some form of skin thickening, either in the distal part of the body, that's called limited disease, or in the trunk, that's called as diffuse disease. So in limited disease, the most important antibody is anti-centromeric antibody, which is related to pulmonary hypertension. In diffuse disease, the most important antibody is anti-SCL70 antibody, which is also called as topoisomerase 1 antibody, that is related to ILD, interstitial lung disease. And remember, ILD is the most common cause of death in patients with scleroderma. In RASLE, the most common cause of death is cardiovascular risk. But in scleroderma, it's always going to be ILD. And anti-RNA polymerase 3 antibody is related to scleroderma renal crisis and malignancy. All right. Coming to primary Sjogren syndrome, so these patients are going to be females predominantly in 40s and 50s, and they're going to come with Zika symptoms like dry eyes, dry mouth, and dry vaginal mucosa. ANA will be positive, and even in scleroderma patients, ANA will be positive in more than 95% of the cases. ANA will be usually positive, 100%, 95% cases will have ANA positivity. And same thing with Sjogren syndrome. And but SSA and SSB are more specific. SSA is called antiro, SSB is called antila. These are more specific antibodies, and diagnosis can be confirmed with salivary biopsy, where you can see lymphocytic infiltrate around the small glands. And the most important extraarticular manifestation is ILD, where it's going to produce one peculiar form of ILD called as LIP, that is lymphoid interstitial pneumonia. And patients can develop small fiber peripheral neuropathy, which is very painful condition with normal nerve conduction study. Arthritis, again, it's going to be non-erosive. It can be related to PBC, that is primary biliary cholangitis, and it can produce monoclonal gammopathy also, which can lead to extranodal marginal zone lymphoma, especially of the parotid gland. We discussed that already. So the most common cancer in patients with Sjogren syndrome is ENMZL, which is also called as malt lymphoma. So parotid maltomas are very common in patients with Sjogren syndrome. And treatment is going to be with pilocarpine, that is cholinergic drug to improve secretions, or you can use hydroxychloroquine, not very useful. So coming to giant cell arteritis, mostly elderly patients, ESR more than 50, tends to come with temporal headache, with palpable tender temporal artery, and patients are going to have jaw claudication, very specific manifestation, and patients will be having blindness because of AON, that is anterior ischemic optic neuropathy, that tends to produce altitudinal vision loss, and patients may have PMR, that is polymyalgia rheumatica, that will present with girdle stiffness, and pain. That's going to present with girdle stiffness and pain, That's how they're going to present. And gold standard will be the temporal artery biopsy, where you're going to prove the presence of arteritis and granulomas. Treatment will be with high dose steroids plus or minus tocilizumab. And steroids should be started even before vision loss, because you're starting steroids to prevent vision loss. You have to be clear about that. And in Takay's arteritis, patients will be young females, less than 40 years generally. They will come with pulseless radial artery on one side, and it's going to be occurring in subclavian artery predominantly because of the subclavian stenosis. This is the most common vessel involved in Takayasu arteritis. And these patients will be having skip lesions, arterial thickening, so many problems you'll be noticing in angiogram. That's why diagnosis or investigation of choice is going to be CT angiogram of the thorax and the aorta. And treatment is with steroids and methotrexate, standard treatment. So in exam, young female, pulseless, arm pain, arm claudication, subclavian involvement, CT angiogram showing like constrictions and dilatation. So that is very likely to be Takayasu arteritis. What are the four no's and pan? Remember, 30 to 40% cases will be having HBsAg positivity. That is, they will be related to hepatitis B virus. It's an extrahepatic manifestation, right, of hepatitis B virus. So what about this? The patients will be having more no pulmonary involvement, 4 no's in pan, no RBC cast, no ANCA, no granulomas in biopsy. If you know these 4 itself, you can diagnose it as pan. Otherwise, patients will have mononeuritis multiplex, GAT involvement, renal involvement without RBC cast though, and patients will be having testicular involvement and myositis. All these are so classic of pan. But these 4 no's you need to know for exams to make a diagnosis. And what about small vessel vasculitis? We have vaginous. Vaginous is going to present with ENT manifestation more commonly, that is sinusitis most common. Then they have lung nodules, especially in the lower lobes. They'll come with RPGN, that is glomerular nephritis with RBC cause. And usually C-ANCA and anti-PR3 will be negative, and immunofluorescence will be a positive, and immunofluorescence will be negative because it's a pos immune variety. DC cardioversion, non-cardioversion, adenosine amiodarone defibrillator. We already discussed in the first slide itself. No, I think he's attending only now. First slide I told you know all these things. When to use synchronous DC cardioversion, when to use defibrillation, when to use adenosine, when to use amiodarone. I told you already, no. First slide itself, that only we discussed. Okay. So what is the treatment? Treatment of vaginas will be steroids plus either cyclophosphamide or rituximab. Cyclophosphamide or rituximab. So this is the treatment of choice for vaginas. The most common cause of death in vaginas is pulmonary renal syndrome. That's the most common cause of death. So what about Chuk's syndrome? Patients will be presenting with asthma, eosinophilia, and vasculitis picture. Vasculitis will be mononeuritis multiplex, which is the most common in Chuk's, or it can be GAD and cardiac involvement. But cardiac involvement is the most common cause of death. These patients usually will be P-ANCA and anti-MPO positive. Immunofluorescence will be negative because it's ANCA related. Treatment again will be steroids and cyclophosphamide or rituximab. And giant cell arteritis, we discussed already, I think. These things we discussed. So I'm not going to discuss this again. So what about HSP? That is enoxaparin purpura. So these patients will be children, right? Children, adolescents, typically less than 20 years of age, and mostly it occurs after some URI like prodrome. And these patients are going to come with palpable purpura, arthritis, and abdominal pain. Classic triad, plus or minus they can have glomerulonephritis also. And they will have IgA deposits in the mesangium. We know that. But IgA nephropathy is different. This is different. IgA nephropathy is a kidney limited disease, but this is a renal limited disease. And it's IgA related, correct? It's IgA related. And treatment is supportive, and steroids can be given in any severe manifestation. If there is any refractory severe manifestation, give steroids. Otherwise, supportive treatment is going to be the goal, and it is a self-limiting disease. It's not going to produce any problem. So it's most cases it's a self-limiting disease. So what are the important things you have to see in cryoglobulinemia? So these patients will be having HCV positive. Mostly they will have HCV positivity, and they will have rheumatoid factor positivity also in exam. They'll come with cryoglobulins in the blood. Along with that, they will have purpura skin involvement. They will have arthralgia, and they tend to have glomerular involvement. This is a typical presentation of cryo. And type 2 and type 3 cryo will produce vasculitis, and it's usually hepatitis C virus related. Classical cryoglobulinemic vasculitis, And yes, these patients will be having low C3 and low C4. And it's not IgA, it is IgG related. Immunofluorescence will show IgG positivity, whereas in HSP, as you all said, immunofluorescence will show IgA positivity. That is why HSP is also called as IgA vasculitis. And treatment here is going to be with treatment of HCV, because most cases are related to hepatitis C virus only. And you can give rituximab if you wish to. Okay. What about Kawasaki disease? Most patients will have continuous fever for more than 5 days. Along with it, they will have conjunctivitis, the pink colored conjunctivitis. Rash in cryo C3 normal now. No, in cryo C3 will be low. No, C3 normal is only 2. So that is IgA nephropathy and henoxalin purpura. And cryo SLE, PSG and all, P3, C3 will be low only. We have discussed in Lapone algorithm also. So patients will be having conjunctivitis. That is rash. Okay, a patient will have conjunctivitis, patients will have rash, patient will have glossitis, that is strawberry tongue, patients will have cervical lymphadenopathy and extremity changes. We have discussed a mnemonic already in the form of febrile. Go through that. Febrile stands for fever, enanthems, that is rash inside the mouth, bulbar conjunctivitis, rash, and internal organ involvement in the form of cardiac involvement, and they're going to have lymphadenopathy and they're going to have extremity changes. That's a WHO criteria for Kawasaki disease. It's going to affect infants and children predominantly, and it produces coronary aneurysm, which can lead to MI and heart failure in these children, which is the most common cause of death. Treatment is going to be with IVIG with aspirin, but IVIG is the most important treatment, very commonly asked in exam. And what are the important things in Behçet? It's called as oro-oculogenital syndrome, where the patients will have oral and genital ulcers. Along with it, patients will have ocular involvement. That's why it's called oro-oculogenital syndrome. So, and these ulcers will be very painful ulcers. It's aphthous ulcers, very, very painful aphthous ulcers. And they will have a test called pathology positivity, not always, but 25-30% cases. And ocular involvement will be typically bilateral pan-uveitis, and there will be retinal involvement. Retinal involvement also may be there. And patients can have skin involvement like erythema nodosum, pyoderma gangrenosum, acneiform lesions, vesiculobullous lesions, pustular lesions, and so on. Treatment will be with colchicine, or alternative is apremilast. Apremilast is a phosphodiesterase 4 inhibitor that can be used in psoriasis, psoriatic arthritis, and in Behçet also. Or in severe disease, you can use steroids or azathioprine. In case if there is ocular involvement, the drug of choice will be azathioprine in Behçet. Otherwise, azathioprine is not required. So, oro-oculogenital syndrome. Ocular involvement will be uveitis with retinal involvement, and patients can have other problems like arthritis also. What is Kogan syndrome? It's a combination of interstitial keratitis causing blindness, vision loss, and patients will have deafness also, hearing loss also, because of vestibular auditory involvement. This is classic of Kogan syndrome. If vasculitis is producing vision loss and hearing loss, it is Kogan syndrome. And what about ATTR amyloid? So ATTR amyloid, very common question in exam again. So it's going to produce cardiomyopathy and neuropathy, and it can be a familial disease where there will be mutated transthyretin, or it can be senile where it will be a wild type transthyretin. And the diagnosis of ATTR amyloid deposition can be done with technetium-99m pyrophosphate scan. And the treatment will be tafamidis and diflunisal, which are FDA approved drugs which act as TTR stabilizers. Okay, understood, guys? We have completed rheumatoid also. So what are the important things in rheumatoid? Don't forget to read rheumatoid arthritis. Then seronegative spondyloarthritis, I told you all the important points. SLE, you know what are the important things. And all the vasculitis, you know what are important. And don't forget to top up with Behçet and amyloidosis. All these are like kind of like very basic topics that you need to know for a good pass. So honestly speaking, if you have if you have studied whatever topics I have said, if you have studied well, that itself will fetch you like 60 marks, 70 marks easily. Because in exam, the same questions are going to come. Pretty much same. Nothing. We will understand that after 1 week. At least you understand now before it's too late. Okay. Coming to stroke. So what are the important things in stroke? So number one is your MCA. So middle cerebral artery stroke. So patients are going to present hemiparesis and hemisensory loss, but the clue in exam will be arm weakness and face weakness will be more than leg weakness. Arm and face weakness will be more than leg weakness. And in case if dominant hemisphere is involved, you're going to get aphasia, typically Broca's aphasia or global aphasia, rarely Wernicke. If non-dominant hemisphere, especially parietal lobe is involved, means you're going to get neglect, anosognosia, constructional apraxia, and so many other problems we have discussed. And in ACA stroke, the leg weakness will be more than arm and face weakness. Patients may have urinary incontinence because of the paracentral lobule involvement, and patients can have abulia also. So, whenever you are suspecting stroke, the first investigation is going to be NCCT of the head, non-contrast CT of the head. But the best test in ischemic stroke will be diffusion weighted MRI, where the changes can be seen as early as minutes of onset of stroke. And in case the patient is presenting within 6 hours of onset, then you're going to do a combination of non-contrast CT and CT angiogram. This is to rule out large vessel occlusion. In case if the patient is presenting after 6 hours, then you have to do non-contrast CT and CT angiogram. And in case if there is a large vessel occlusion CT angiogram, you have to do CT perfusion imaging also to find out what is the penumbra. So in compatible patients, you can do intervention, that is mechanical thrombectomy, or we can call endovascular therapy up to 24 hours. So in the first 6 hours, if there is large vessel occlusion, you can do endovascular therapy. Or after 6 hours, if there is a large vessel occlusion and there is a mismatch in CT perfusion, if there is a large penumbra, still you can do endovascular therapy. So currently you can intervene, that is endovascular therapy can be done up to 24 hours. And how long you can thrombolize in stroke? It's only 4.5 hours. The drugs that are currently used is alteplase and tenecteplase. Here the dose of alteplase will be 0.9 milligram per kilogram. In the 10% you give as bolus, and remaining 90% are going to give it as IV infusion. In case if you are suspecting TIA, the next step is going to be to look at the ABCD2 score. Very, very important. I'll talk about the ABCD2 parameters in some time, common question exam. And then you have to do MRI. This is ideal, or at least a CT scan, but MRI is the best investigation in TIA, transient ischemic attack. So how we are going to diagnose subarachnoid hemorrhage? Patients are going to present with acute severe headache in the form of thunderclap headache or worst headache of life, and patients will have neck stiffness because of meningeal irritation. Patients may have focological deficit like sixth nerve palsy, third nerve palsy, hemiparesis, and so on. And the first investigation we do here is CT head, which is 90 to 95% sensitive if done early. But in case if CT is negative, then you have to do lumbar puncture to find out xanthochromia. That usually happens after 6 to 12 hours of onset of subarachnoid hemorrhage, and hydrocephalus is very, very common in patients with subarachnoid hemorrhage. So don't forget that also. That's because of the blood in the CSF that occludes the CSF absorption. And what is the treatment for subarachnoid hemorrhage? Nimodipine should be given for all patients. It's a vasodilator. It is to reduce the risk of delayed cerebral ischemia. Delayed cerebral ischemia due to vasospasm. Remember, DCI is the most common cause of death in patients with subarachnoid hemorrhage. That's why you need to do that. And alternatively, you have to treat the aneurysm also. How to treat the aneurysm? We are going to use either aneurysmal clipping, which is an open procedure, or endovascular coiling, which is basically a endovascular procedure. So endovascular coiling is preferred because of its low morbidity and mortality. And in case if the patient is having hyponatremia, the most common cause will be SAAD. But please, this is one SAAD where you do not opt for fluid restriction. Please don't opt for fluid restriction because it can worsen delayed cerebral ischemia. Here the treatment of choice. In case if they ask you treatment of choice, it's going to be 3% hypertonic saline. That will be the best option to reduce the ICP plus to correct the sodium also. So what are the standard things that you have to know in intracranial hemorrhage? So hypertension is the most common cause, and most commonly it produces subcortical bleeds, and the most common site is going to be putamen and the internal capsule region, followed by globus pallidus, and then thalamus, cerebellum, pons, everywhere they can have, and then in all these places they can have what? Bleeding, possibly. And what are the important scores when it comes to your neurology patients? Important score will be what? So I mean, before that, what is the target for ICH? Target for ICH is SBP of less than 140 if the patient is hypertensive, or you have to reverse coagulopathy. For example, you have to give FFP and vitamin K if the patient is having warfarin-related bleeding, and you can do surgery. When you are going to do routine surgery, if the cerebellar bleed size is more than 3 centimeter, or if it's complicated like midline shift and all those things, you're going to do surgery. Otherwise, you don't do surgery. Remember, the only indication for routine surgery is cerebral bleeds more than 3 centimeter size. And what are the important scores? Your Glasgow Coma Scale. So what is GCS? It is eye verbal motor score. The score ranges from 3 to 15. You know how to calculate. We have discussed n number of times. What is ICH score? It's a score that contains volume of bleed. If it's more than 30 ml, you get 1 point. Intraventricular hemorrhage get 1 point. Infratentorial hemorrhage get 1 point. Age more than 80 gets 1 point. And GCS also gets 1 to 2 points. If it's 13 to 14, 0 points. 5 to 12, 1 point. 3 to 4, 2 points. Prognosis assessed based on the score, which is ranging from 0 to 6. And then you have the ABCD score. What are the parameters? You have the age, BP, clinical features. It has like 1 or 2 points, and duration again 1 or 2 points. And Diabetes carries another 1 point. So these are the parameters in the ABCD score. It is used to predict stroke risk in patients with transient ischemic attack. The score ranges from 0 to 7. And finally, we have the CHADS-2 score for picking up stroke risk in patients with atrial fibrillation. So you know the CHADS score includes your congestive heart failure, hypertension, age, either more than 65 or more than 75, and S2 history of stroke and TIA, and VASC history of vascular disease, and don't forget sex also important. Females get 1 point in CHADS score. So sex also is included in CHADS score. So only score among the four that includes sex in it. And you are definitely going to go for anticoagulation if the score is 2 and above. Very, very important point. So what is the most valued thing in meningitis? I told you so many times in exam, it's always the cells that you have to look for first. If it's neutrophils, always straight away close your eyes and go for acute bacterial meningitis. If it's lymphocytic, it must be viral or TB or crypt. So then the further classification will be based on glucose. So glucose is the second most important thing, especially if it's normal, and if it's lymphocytic fluid, go for viral meningitis, easy. In case if it's lymphocytic and low glucose, it must be TB meningitis versus fungal meningitis. In case if it's a fungal meningitis, in exam, the clue will be HIV patients who are having India Inc positivity in the CSF. And the first empirical treatment in any suspected meningitis is IV zone, very common question. And you're going to give IV acyclovir. If you are thinking in terms of herpes simplex virus encephalitis, when you will think of herpes simplex virus encephalitis, if there are temporal lobe changes, temporal lobe hyperintensity MRI, or the EEG showing temporal lobe epileptiform spikes, because HSV, especially HSV1, loves the temporal lobe for whatever reason it may be. In Alzheimer disease, what are the most important things? You have to look at the age of the patient. Patients are going to be old, like more than 65 years usually, and they're going to present with 4As: amnesia, aphasia, apraxia, agnosia. In that, amnesia will be the first short-term memory loss, and patients are going to have A beta amyloid and neurofibrillary tangles. In that, A beta amyloid is pathognomonic, especially the 42 component is pathognomonic, and no treatment can change progression, even though you can use some drugs like cholinergic drugs and memantine to improve the cognition, but there is nothing that can change the progression. And what about Lewy body dementia? So patients are going to have visual hallucinations along with fluctuating cognition and consciousness presenting like a delirium, and patients will have Parkinsonian features, and you have to avoid neuroleptic drugs because it can worsen Parkinsonism and they'll be intolerant to those drugs. And how Creutzfeldt-Jakob disease will present? It's a prion disease, and it's going to present with rapidly progressing dementia with myoclonus and exaggerated startle response. EEG is going to show that classic periodic sharp waves, a slow background with the periodic sharp waves. We have discussed that. And what about frontotemporal dementia? Patients will be little younger to Alzheimer, like in the 40s and 50s. Primarily, it comes with behavioral changes if it's a behavioral variant of frontotemporal dementia, or they can come with speech problem if it's a primary progressive aphasia variant, right? So it is a tauopathy. So FTD is typically a tauopathy. Alzheimer disease is also an example of a tauopathy, and exonucleated repeat will be seen in FTD ALS complex. Only if they're having FTD ALS complex, you will see that 2G and 4C, no? Something like that. GG, CC, CC. The exonucleated repeat will be seen if it's FTD ALS complex. Otherwise, you don't see that. Yeah, 4G, 2C, whatever. So coming to Parkinson disease. Parkinson disease is going to present the trap features. What are the trap features? Patients are going to have tremor, rigidity, akinesia or bradykinesia, and patients can have postural instability. In that, tremor is the earliest manifestation. Tremor is the earliest manifestation. Akinesia or bradykinesia is the most specific manifestation, whereas postural instability is the last manifestation. So, and this is because of the Lewy bodies, you know that, and which is nothing but alpha-synuclein inclusions. We have discussed that. Patients are also going to have reduced facial expression, that is hypomimia, festrinant gait, that is a slow shuffling gait with the leaning forward position, and there will be gait freezing, and these patients are prone for depression and subcortical dementia also. So, in case if the patient is younger than 60 years, dopamine receptor agonist will be the first choice. If older than 60 years, levodopa will be the first choice. In case if the patient is having advanced disease with severe motor fluctuations with levodopa carbidopa, we can use deep brain stimulation also. Both subthalamic nucleus DBS and GPA DBS has equal outcomes. So you can use either a subthalamic nucleus DBS or you can use a GPI DBS. I think iPad 2 LIA. Why LIA is coming all of a sudden? I think it's a search, I think. That's the problem. I think you have been searching for LIA. So that's why his browser is telling him that more than Lewy bodies, Lia Gotti is more important for him. Okay. Okay, cool. So subthalamic nucleus or probably, yeah. So globus pallidus internus, isn't it? So these are going to be the options for DBS, that is deep brain stimulation. Yeah, when a patient is having depression, then probably you're going to use GPA DBS, or the patient is having severe dementia also, GPA DBS is better. So how NPH is going to present? It's going to present Hakim stride or Adam stride in exam. It is wet wobbly wacky. So what is wet wobbly wacky? Patients will have urinary incontinence, patients will be having subcortical dementia, and patients will be having gait apraxia resulting in falls. In that falls will be the early presentation because of the gait apraxia. So patients will have disproportionately dilated ventricles, meaning the ventricles will be huge, but patients will have a normal CSF opening pressure. That's why it's called normal pressure atrial Treatment is going to be VP shunt. How classic absence seizure will present in exam? Patients are going to have brief staring. So these are children, usually younger than 5 to 10 years. Just brief staring without any postictal state or no loss of tone. EG will show characteristic 3 to 6 hertz, 3 hertz spike and wave, and treatment will be ethosuximide. Only if it's atypical absence, you're going to give valproic acid, but it is contraindicated in children less than 3 years of age in view of heterotoxicity. And juvenile myoclonic epilepsy is going to present myoclonic jerks on awakening in an adolescent patient. And EEG will typically show 4 to 6 hertz spike and wave pattern. Treatment is going to be with valproic acid. And status epilepticus, you are going to use IV antiepileptics only if the seizure lasts for more than 5 minutes. Otherwise, do not use antiepileptic drugs. The treatment is only supportive. So you have to give IV lorazepam only if the seizure is exceeding more than 5 minutes. Don't give IV lorazepam otherwise. And once IV lorazepam fails to control seizure, you are going to give IV levetiracetam or phenytoin or fosphenytoin or valproic acid. Then after that, you are going to proceed to propofol or midazolam continuous infusion. This is the next step. That's IV general anesthesia. Focal motor seizures, I told you the three things that you should never forget in exam. One is going to be the Jacksonian march, where the seizure marches along the motor homunculus. Todd's palsy, that is post-ictal weakness, that is Todd's palsy, and epilepsia partialis continua, where the seizure can occur for weeks and months together also. And remember, this is one pharma area that is very, very important. All the side effects of AEDs we have discussed in class also, but all the side effects of AEDs and drug interactions are very, very important. Okay, anything can be asked in exam. So coming to Guillain-Barré syndrome, neuromuscular disorders, GBS is almost always a clinical diagnosis. This is the most common cause of acute to subacute paralysis in the world right now after stroke. And there are 5 A's in Guillain-Barré syndrome. I told you that so many times. That is acute ascending areflexic autonomic instability with albuminocytological dissociation. What are the 5 A's? Acute ascending areflexic albuminocytological dissociation with autonomic instability. And now conduction study is going to show demyelination. And treatment is going to be IVG or plasma exchange, anyone only, definitely no steroids or immunosuppression. Important variant in exam is Miller-Fisher syndrome, which is going to have the triad of ataxia, areflexia, and ophthalmoplegia. Ataxia, areflex, and ophthalmoplegia. So which is going to be associated with the classic anti-GQ1B antibodies. How will you diagnose multiple sclerosis? You're going to prove the dissemination space and dissemination time, and you're going to have that. I mean, we're going to use that MRI with gadolinium contrast is the gold standard to prove that. And in exam, you will get the Dawson fingers. Classically, it's fine, but apart from that, so this is the gold standard to prove that dissemination in space and time. And CSF is also going to show something called as oligoclonal bands. It's very sensitive, but it is not specific. It is not specific. And patients, the most common presentation in patients with multiple sclerosis is going to be the sensory issues like numbness, and patients will have human weakness, and over time it's going to progress to spasticity, and patients can have internuclear ophthalmoplegia because of MLF involvement, and patients can have cerebellar issues, typically Charcot triad, SIN triad, staccato speech, intentional tremors, nystagmus, and patients can also have brainstem signs like facial palsy and all over a period of time. And symptoms tend to worsen with heat. This is called as Uthoff phenomenon. This is also called as heat intolerance, and patients very commonly experience Lermit sign also, where sudden forcible flexion of the neck will result in electric shock-like sensation down the spine. This is called Lermit sign, which is not a specific sign of MS, but it's often asked in association with MS. How to identify neuromyelitis optica? Patients will have longitudinal extensive transverse myelitis, where at least 3 or more spinal cord segments will be involved. Many patients will have bilateral optic neuritis. Along with that, they can have anti-aquaporin antibody positive, which is also called as NMO antibody. This will be positive in many patients. So this is not the case in MS. And what are the rules for amyotrophic lateral sclerosis? In exam, it's very simple. You have UMN and LMN in the same patient. If you have spasticity, Babinski positivity, along with it, if you have fasciculations, the most important is fasciculation and atrophy at the same time. So this is an element. So how we are going to treat riluzole? This is something that can improve survival by 3 months. Edrovone is something that can improve functional status of the patient by some amount. So these are the usual things about ALS. And what about myasthenia gravis? It's going to produce a fluctuating and a fatigable weakness, very, very important point, with a diurnal variation. Fluctuating, fatigable weakness with diurnal variation, where the weakness will be more in the evening than in the morning. And the most common ocular manifestation is ptosis, followed by diplopia. And patients are also going to have proximal limb weakness. And myasthenia gravis by default is going to be asymmetric in nature, not symmetric. And single fiber EMG is the most sensitive test, but not a very good test. And the most specific and the best test is going to be the antibody. You're going to do either acetylcholine receptor antibody or anti-MuSK. The most common antibody is acetylcholine receptor antibody, but in 40 to 70% of acetylcholine receptor antibody negative patients, anti-MuSK may be positive. Okay, and CT test should be done in all confirmed cases to rule out thymoma, because myasthenia gravis can be a paraneoplastic syndrome due to thymoma. And first line treatment is pyridostigmine in most patients. Then you're going to start with steroids and other immunosuppression agents. Rituximab gives the best response, especially in patients with anti-MuSK antibodies. We have discussed that so many times, right? So another investigation that we commonly do, one of the most commonly done investigation, is repetitive nerve stimulation. If you see a decremental response by more than 10% in exam, it is myasthenia gravis. If you see an incremental response, you're going to diagnose LEMS, that is Lambert-Eaton myasthenic syndrome, which is commonly related to small cell lung cancer. Yes, in these patients, thymectomy can be done. Even without thymoma, thymectomy can be done. We have discussed that already. So what are the important alcoholic issues? Wernicke's, where the patient is going to have the co-track features. So that is confusion, ophthalmoplegia, ataxia, and thiamine is the treatment. It's a reversible form of the disease. It's an acute disease. Whereas Korsakoff is an irreversible form of the disease, where the patients will have retrograde and antegrade amnesia, confabulation, and Korsakoff. It is irreversible. And patients can have DSPN, that is peripheral neuropathy, and patients can have refeeding syndrome. It's very, very, very important, especially in alcoholic and malnourished individuals. If you give too much of calories, patients can end up with refeeding syndrome, where the most important clue in exam will be hypophosphatemia with multiple other electrolyte abnormalities after giving calories in a malnourished alcoholic. Very, very classic. And the rule of thumb in alcoholism is very, very simple. First, always thiamine, then only glucose, then only other treatment. Very, very important. This has to be followed even in patients who are having hypoglycemia, right? That's it. So now we are moving on to gastroenterology. Have you understood these guys? So what are the important things to be remembered in exam in stroke patients? Yes. And in patients who are having neuromuscular disorders? Okay. If you're not understanding, then you're not attended the previous classes. Simple. Simple, that's all. What else I can say? Do you expect me to teach Parkinson disease pathophysiology now? Do you expect me to teach how levodopa works now? Do you expect me to teach how ECG is understandable now with one week time in your hand? Or what leads are inferior, what leads are anterior? You expect me to explain that now? Really? So Haima Ratala is asking which notes to study, lab 2 or this? Ideally, you have to study lab 1. Lab 2 is a revision. It is a concise revision. Lab 3 is a further concise revision. Lab 3 is going to tell you only like what are the points that you have to note that are very, very important for exam, isn't it? So ideally, you have to study lab 1 only. Lab 2 is a revision course. Lab 3 is just to concise and tell you what points. That's it. So these points are the most important. That's it. That's the idea, no? So that's why we kept lab 1, lab 2, lab 3. Now students are telling only if I study lab 3 can I crack. How will you first even understand lab 3? If I'm not having any background knowledge, if you don't know like what you have studied in lab 1 or lab 2, how will you even understand lab 3? It's very difficult, no? If you don't have any background knowledge. Would lab 3 be, if I have not attended any medicine and as a last resort, would lab 3 be enough? I mean, of course, with some basic knowledge. Something is better than nothing, no? I mean, if you don't know, if you have not studied medicine in the past, then okay, fine. Something is better than nothing, no? At least you can look at the lab 3 and at least you can study, no? What? Something. Let's see. Hope it works. Okay, let us move on. So in gastro, when you look at dysphagia, what is the most important thing to look for? First, you need to see whether it's a esophageal or oropharyngeal dysphagia. In oropharyngeal dysphagia, the most important clue will be regurgitation and drooling. In esophageal dysphagia, the most important problem will be food getting stuck in the chest, or patients will complain there is chest pain. So these are the typical clues. And in case if you're dealing with esophageal dysphagia, you have to see whether it's only for solids or liquids and solids together. If it's only for solids, think of structural problem like cancer or peptic ulcer stricture. If it's if it's predominantly for liquids, then think in terms of a neuromuscular cause, right? So in case if you're having a structural problem, the next investigation will be an upper gastrointestinal endoscopy to find out what is the problem. If it's a neuromuscular problem, if it's predominantly for liquids, the best investigation will be high resolution manometry. Of course, you're going to do UGScopy also along with that. But HRM will tell you the diagnosis if it's a neuromuscular problem. Right. If it's structural problem, endoscopy is enough. HRM is not required. HRM stands for high resolution manometry. So what are the rules in manometry? We have discussed that so many times. If integrated relaxation pressure is more than 15, it is achalasia, which is going to present with a triad of dysphagia, regurgitation, and weight loss. And in barium, you're going to see the classic Bird's beak. And the first line treatment is endoscopic dilatation. Best treatment is going to be, endoscopic dilatation. The best treatment is going to be your Heller's laparoscopic myotomy that will be done later on. In case if distal latency is less than 4.5 seconds, you are thinking in terms of diffuse esophageal spasm. We are going to see a corkscrew esophagus in barium swallow, and DCA, distal contractile integral, is more than 8,000. This is also called as jackhammer esophagus. And only two things that will cause peptic ulcer disease, NSAIDs and H. pylori. We know that spicy diet doesn't cause peptic ulcer disease. Non-invasive diagnosis of H. pylori means you're going to do urea breath test, which is the best test for both diagnosis and follow-up, followed by stool antigen test. Remember, serology is useless, especially for follow-up. In exam, please don't answer serology for anything. It's a useless test. The best test always is going to be the urea breath test. Because urea breath test has C14 in it, avoid in pregnancy. In pregnancy, it has to be avoided because it has C14. It's a radioactive compound. Even though however tiny amount of radiation it is, don't take chance, don't give in pregnancy. And what is the current preferred treatment for H. pylori? It is bismuth quadruple therapy. It's a combination of bismuth, PPI, metronidazole, and tetracycline. This is to be given for 14 days. Triple therapy is less favored nowadays. Currently, the newer options are available with vonoprazan with amoxicillin. So even dual therapy with vonoprazan is considered to be better. This is considered to be newer option. That is vonoprazan with amoxicillin. Make a note of it. So how you are going to treat varicose UJ bleed? First, always ABC. Remember PRBC only if HB is less than 7. Only if hemoglobin is less than 7, you're going to give PRBC, otherwise no PRBC. And you're going to give vasactive agents like either octreotide or terlipressin, vasactive agents to reduce the portal pressure. And you have to give antibiotics. A broad spectrum antibiotic like ceftriaxone or probably piperacillin tazobactam has to be given. And then you are going to do endoscopy. In the scopy, you're going to see whether it's esophageal varices or gastric varices. If it's esophageal varices, you're going to do varicose band ligation or endoscopic varicose ligation. If it's gastric varices, you're going to do glue injection, that is cyanacrylate glue injection. This is also something that were discussed in lab 2 also, if you remember. Okay, another option for gastric varices is your coil embolization. That also can be done. Radiographic coil embolization. So if it's non-varicose UGA bleed, so usually it will be peptic ulcer disease only. So again, ABCs are important, and you're going to give IV proton pump inhibitors, and you're starting to give us a continuous infusion. And after this, you're going to do endoscopy based on forest classification. If it's forest 1A to 2B, 1A is spurting bleed, 1B is oozing bleed, 2A is going to be adherent clot, 2B is non-bleeding visible vessel, and 2C is flat pigmented base, 3 is clean ulcer base. If it's 1A to 2B, you have to give double treatment. So what is the double treatment? You have to give epinephrine injection, plus you have to use either hemoclips or probably thermal coagulation, that is cautery. So double treatment is very, very important. Epinephrine plus either clipping or cautery. And how will you diagnose acute pancreatitis? You have to have at least 2 out of the 3. So you have to have abdominal pain, typically epigastric or left upper quadrant pain that is radiating to the back, classic pancreatitis pain. And the most common cause of acute pancreatitis is going to be gallstones followed by alcohol. The most common cause of chronic pancreatitis is going to be alcoholism. There's no doubt. And patients will have elevated amylase lipase, but lipase is supposed to be the most specific, and patients will have imaging abnormalities. Generally, the first investigation that we do is ultrasound, but it's not good enough. But after 72 hours, we are going to do contrast enhanced CT to look for complications. This is the best investigation. CT to look for complications of acute pancreatitis. So what is the first treatment in patients with acute pancreatitis? It's going to be IV fluids with NPO for maybe 24 hours at least, and pain control with opioids. And you have to address dyselectrolytemias, especially the most important is going to be hypocalcemia. Calcium has to be addressed. And early enteral feeding is recommended. As soon as possible, start them on oral diet, or at least put a nasogastric or nasogenital tube and start feeding. And there is no role for octreotide right now, and routine antibiotics also has no role. Only in infected necrosis we give antibiotics. There are two scores which are very important: BISAP score, which is a clinical score that predicts prognosis, and Atlanta score is a CT and clinical base score that predicts the prognosis. And the ERCP should be done within 24 hours if the patient is having cholangitis or sepsis. And elective cholecystectomy for all patients should be done if it's gallstone-related pancreatitis, right, at the time of discharge. And what about chronic pancreatitis? Alcohol is the number one cause. 70% cases are due to alcohol only, and it presents with chronic episodic abdominal pain. Chronic episodic abdominal pain with the diarrhea malabsorption, and they will have steatorrhea. Because of that, they will have extreme and profound weight loss, and they're going to have pancreatic diabetes, that is type 3C diabetes. Typical triad: abdominal pain, diarrhea, steatorrhea, weight loss, and pancreatic diabetes. And treatment is going to be pancreatic enzyme replacement therapy, like Creon, something you can use. So what are the indications for cholecystectomy? So if the patient is symptomatic, definitely sure. If the patient is asymptomatic, then patient should have gallstone size of more than 3 centimeter, polyp of more than 1 centimeter, or patient should have a porcelain gallbladder, which has a very high risk of gallbladder cancer. Okay, understood, guys? The gastro part, the most important points. Now coming to the hepat part. So the liver part. So one thing that can ask in bilirubin is the Gilbert syndrome, which is an asymptomatic condition with mild elevated unconjugated bilirubin, and they are going to have completely normal liver enzymes. This is due to a mild UGT1A1 conjugation defect. No treatment is required. And alcoholic hepatitis will have a AST-ALT ratio of more than 2, but AST level will still be less than 300 to 400. And in case if AST-ALT ratio is less than 1, in exam always go for NASH, that is non-alcoholic steatohepatitis. And whenever ALT in the thousands, only three causes are possible. One is going to be acute viral hepatitis, second is drug-induced liver injury like paracetamol poisoning, and third one is going to be ischemic hepatitis, where ischemic hepatitis will produce the maximum AST-ALT elevation. And what are the important scores in hepatology? Don't forget the Child-Turcotte-Cook score, which is a score based on total bilirubin, PTNR, encephalopathy, ascites, and albumin. So 5 important parameters are there. Go through that. And we have the MELD sodium score, which is also called as the CBI score, which includes creatinine, bilirubin, INR, and sodium. We have the NASR score, which includes bilirubin, INR, and SGOT or AST, which is used in patients with Wilson disease, acute liver failure and Wilson disease. And don't forget the matrix discriminant function also, which is based on two things, INR and total bilirubin. And if the score is more than 32, you're going to give steroids in patients with alcoholic hepatitis. We know that this is a very, very important point. If the matrix TF is more than 32 in patients with alcoholic hepatitis, give steroids. Otherwise, no steroids. And last lab 2 also we discussed the three markers are enough to make a diagnosis of hepatitis B in exam. It's going to be HBsAg, which is a marker of infection, anti-HBc, which is a marker of exposure, and anti-HBs, which is a marker of immunity. I told you that E antigen and DNA are helpful only in patients with chronic HPV. Otherwise, do not see E antigen and confuse yourself. Okay, just see surface antigen, anti-HBc, and anti-HBs, and try to make a diagnosis based on that. It's easy, simple. You can watch at lab 2. And what will be the HBV treatment? So if the patient, only if the patient is having chronic HBV, plus if the HBV DNA is more than 2000 international units per ml, you're going to start treatment. This is the standard rule. We have discussed that already. And treatment is going to be either tenofovir or entecavir. So you can use either tenofovir disoproxil fumarate or tenofovir alafenamide, or you can use entecavir also. Any one of the drug can be used. And what is the HCV treatment? The most important treatment of HCV currently is the DAAs, that is direct acting antiviral drugs. So the one combination that has pan-genotypic effect is sofosbuvir with velpatasvir. Another one that has pan-genotypic effect, but it's not used, not available in India, is glecaprevir with piperentasvir. Glecaprevir with piperentasvir. This also has a pan-genotypic effect, but it is not available in India. In India, the most commonly used regimen is sofosbuvir with velpatasvir for approximately 12 weeks. It can be used across all the genotypes of hepatitis C virus. And what about acetaminophen poisoning? So the most important question they will ask in exam is what is the nomogram used? That's called as Rumac-Matthew nomogram. And N-acetylcysteine is the best antidote here. The triple N is the glutathione stores. And King College criteria can be used for transplant referral. And what is the first test that you're going to do in cholestatic jaundice? Cholestasis means you're going to have elevated ALP. Along with it, you'll have elevated GGT. So in cholestatic jaundice, the first thing that you will do is ultrasound abdomen. In ultrasound abdomen, you're going to look for the extrahepatic biliary radical dilatation. If there is a biliary radical dilatation, you're going to do MRCP to find out what is the further cause. In case if it is normal in exam, always think in terms of drugs or PBC. That is primary biliary cholangitis. Very, 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 very important. Okay, so what are the rules of PBC? That is primary biliary cholangitis. It's going to be a middle-aged female, person with a cholestatic picture with elevated alkaline phosphatase, pruritus, xanthelasma, and AMA M2 will be positive, and treatment is going to be with ursodeoxycholic acid. That's the first line treatment. And in primary sclerosing cholangitis, it will be young male generally presenting with IBD history, that is ulcerative colitis especially, coming with the cholestatic jaundice again. But in MRCP, you will see bleeding. Here, MRCP will be normal in patients with PBC because it's an intrahepatic cholestasis. But in PSC, it's extrahepatic, so MRCP will show changes, bleeding, and these people may have P ANCA positivity, but it's not very important. And autoimmune hepatitis is going to occur in a middle-aged female with hepatocellular picture, meaning that AST-ALT will be elevated more than ALP, and patients will be having ANA positivity, SMA positivity, and anti-LKM1 positivity. ANA SMA positivity is more common, and this is seen in type 1 autoimmune hepatitis. Whereas anti-LKM1 positivity is common in type 2 autoimmune hepatitis, which is not very common. Treatment is going to be the combination of steroids and azathioprine. First line is steroids. And Wilson disease, you're going to think in terms of this disease in a young individual, person with hepatitis and neuropsychiatric problem like wing beating tremors, psychiatric problems, behavioral issues, chorea, Wilsonian smile. Along with that, they might have hemolytic anemia because of copper excess in the blood. It will be a normocytic, normochromic, Coombs negative anemia. Normocytic, normochromic, Coombs negative anemia. And diagnosis can be done with ceruloplasmin being less than 20, but that will not confirm. What will confirm is the presence of KF ring with 24-hour urinary copper being more than 100 micrograms per day. So these two are the most important confirmatory tests, KF ring and 24-hour urinary copper being more than 100 micrograms per day. Even though liver biopsy is often mentioned in textbooks, that's not done nowadays. So treatment will be with D-penicillamine or trientine. Trientine is having lesser side effects, but it's more costly. So we use D-penicillam as the first choice, maintained with zinc therapy to reduce copper absorption from the gut. Coming to alpha-1 antitrypsin deficiency. So you're going to suspect alpha-1 antitrypsin deficiency in patients who are having pan-SNR lower lobe emphysema, pan-SNR lower lobe emphysema in a young non-smoking individual with probable family history. So family history of emphysema, young emphysema, non-smoking with emphysema, pan-SNR lower lobe, all these things are going to tell alpha-1 antitrypsin. These patients may have liver disease if they are belonging to that PiZZ phenotype. Only that Z phenotype will produce liver disease. In these patients, you are going to have PAS positive granules in liver biopsy. Ascites, what is the most important? Everything is about the SAG ratio in exam. If it's more than 1.1, it's portal hypertension. Less than 1.1, it's not portal hypertension. If it's less than 1.1, think in terms of TB, pancreatic ascites, malignancy, and all those other things. So what is the treatment of refractory ascites? Remember, first of all, the main treatment, first line treatment for ascites is sodium restriction. But most patients won't be compliant, so add diuretics. So first line diuretic is spironolactone, but we anyway add with Lasix, and the ratio of spironolactone to Lasix is 100 to 40. And in case if it's refractory ascites, the treatment is going to be large volume paracentesis, and which is also having equal efficacy to that of TIPS, that is transjugular intrahepatic portosystemic shunt. HRS treatment, HRS is nothing but cirrhosis and AKI or CKD, and the patients will, the first line treatment will be terlipressin with albumin, refractory cases again TIPS. And spontaneous bacterial peritonitis can be suspected if neutrophils in the fluid is more than 250, and you can start with either ceftriaxone or piperacillin tazobactam, and one can use prophylaxis with quinolones or cotrimoxazole. This is, prophylaxis has to be given after an attack of your SBP. In case if alcoholic patient is coming confused, so there are two options, hepatic encephalopathy or Wernicke's, but always thiamine will be first, followed by glucose, and then only lactulose. Okay, lactulose is for hepatic encephalopathy. In case if you're thinking in terms of hepatic encephalopathy, first line treatment will be lactulose plus or minus rifaximin. Okay, but never forget this order. Are you understanding? thiamine, glucose, lactose. Lactose can wait. You can give later on also. What is the important, urgent thing in giving lactose? So always thiamine, thiamine, thiamine. Because it's Wernicke's unless put otherwise. Got it, guys? So what are the must-know things that you should never forget in exam? Okay. So these two are with regards to the liver, isn't it? Must know things. Okay, coming to some of the important parts of hematology. So when you're thinking about a microcytic hypochromic anemia, the first test that you're going to do is iron studies. Okay, iron studies are the first thing that you're going to look for. If you have a low ferritin of less than 10 to 30, less than 30 is suggestive, less than 10 is confirmatory, and you have a high TABC, 100% it's an iron deficiency anemia. No doubt about that. In case if you're dealing with a normocytic normochromic anemia, the first test is actually reticulocyte index only. If reticulocyte index is less than 2, think of a aplastic anemia. If it's more than 2, think in terms of a hemolytic anemia. And in thalassemia, the first test that we do is hemoglobin. In case if you're suspecting thalassemia, you're going to do hemoglobin electrophoresis. So most common scenario that you get in exam will be a thal minor. So we are talking about a beta thal minor. In the beta thal minor, you're going to have an asymptomatic patient with mildly reduced hemoglobin, but a very low MCV like in the 50s and 60s. So the Menzer index will be less than 13. In iron deficiency, Menzer index will be more than 13. But here Menzer index will be less than 13. And hemoglobin A2 will be more than 3.5 percentage in electrophoresis. Classic presentation of a beta thal minor. So confirmation of thalassemia can be done with genetic testing only. But electrophoresis is the first line test that we used to do. And there is something called HBH disease that is very commonly asked. This is due to 3 alpha gene deletion. And this results in formation of beta 4 tetramers. This is the one that is called as hemoglobin H. And in these patients, you're going to have golf ball inclusions in the peripheral smear. In the vital stain, you're going to see golf ball inclusions. And what are the important clues in peripheral smear you should not forget? If you see spherocytosis, think in terms of warm autoimmune hemolytic anemia and hereditary spherocytosis. In hereditary spherocytosis, you will get a family history and patients will be having jaundice and gallstones. And if they ask you investigation of choice, it's going to be EMA binding assay, which will be reduced. EMA binding will be reduced. Okay. And treatment of choice is splenectomy. We know that. In case if you're seeing cystocytes, always think in terms of TMS like HUS, TTP in exam. In case if you're seeing drepanocytes, that is sickle cells, think of sickle cell disease. If you're seeing bite cells, blister cells or Heinz bodies, think in terms of hemolysis due to G6PD deficiency, which is usually provoked by drugs like quinolones, primaquine, dapsone, sulfur drugs, rasburicase, pegloticase, methylene blue. So think in terms of those drugs. So acute chest crisis in sickle cell disease. Acute chest crisis in sickle cell disease, how will you treat? So acute chest crisis will present like a pneumonia. This patient will present like they will present like pneumonia only. There will be no difference. We are going to give IV fluid, oxygen, antibiotics, and exchange transfusion is the most important. The goal of exchange transfusion is to keep the hemoglobin S, the sickle hemoglobin, to less than 30%. That is the goal. So what are the drugs that are used in sickle cell disease? All patients will receive hydroxyurea. This is the first line for every single patient because hydroxyurea tend to increase hemoglobin F levels. That is going to reduce the sickling. And you can use voxelotor that is going to reduce the P50, and you can use crizanlizumab also, which is an anti-P-selectin monoclonal antibody that is used as prophylaxis for painful crisis. Okay, so B12 folate deficiency, again a common question. In exam, you can differentiate based on diet. If it's a vegan, think of B12 deficiency. If it's a person who doesn't eat greens at all, think in terms of folate deficiency. And whenever there's a problem in the stomach, like pernicious anemia or gastrectomy, or problem in the terminal ileum, like Crohn's disease or TB, so you're going to think in terms of B12 deficiency because stomach and terminal ileum is very, very important for B12 absorption. And second is homocysteine and methylmalonic acid will tell you the difference. Homocysteine will be increased in both, but methylmalonic acid will be increased only in B12 deficiency. We know that. And coming to paroxysmal nocturnal hemoglobinuria, it is an acquired defect. So many times asked question exam, it's an acquired defect due to the PIG-A gene defect, which is going to result in reduced production of GPA anchors. That in turn is going to have reduced expression of CD55 and CD59. CD55 and CD59. And the patients are going to come with pancytopenia, but with a cellular marrow indicating peripheral destruction, and they're going to have a bland peripheral smear, meaning you don't see anything special in the peripheral smear except pancytopenia. Most common cause of death is thromboembolic manifestations like Buchiari syndrome. So treatment of choice is pegcetacoplan, or you can use eculizumab, which is an anti-C5 monoclonal antibody, and investigation of choice is flare-based flow cytometry. And in aplastic anemia, you're going to have pancytopenia with a hypocellular or acellular marrow, where the marrow will be replaced with fat. I showed you the image also. And these patients also will have a bland peripheral smear, but the marrow will be hypocellular. Treatment is going to be with triple immunosuppression, where you're going to use a combination of calcineurin inhibitor with L-thrombopag and antithymocyte globulin. So idiopathic ATP is a diagnosis of exclusion. It's an isolated thrombocytopenia, which means you have to rule out secondary causes like drugs and infection-induced thrombocytopenia. So the first line treatment is going to be corticosteroid with or without IVIG. IVIG will be used only in extremes of cases. I think we have discussed in detail about the ITP treatment. And what are the rules of myelodysplastic syndrome? Mostly patients will be old males, more than 50 years or 60 years. They will come with cytopenia, most commonly anemia, and they tend to have dysplastic cells in bone marrow and the peripheral blood. Usually number of dysplastic cells will be more than 10%, but blast will be less than 10%. Remember, if blasts are more than 20%, this is equal to what? Acute leukemia, unless proved otherwise. Right? Acute leukemia, unless proved otherwise. So treatment of choice will be azacitidine or decitabine, and you can use lenalidomide in case if you're dealing with the isolated 5q deletion syndrome. Otherwise, it's going to be azacitidine or decitabine only. So if you're thinking in terms of CML, how you're going to diagnose CML, patients are going to have massive splenomegaly, anemia, and leukocytosis with left shift and absolute basophilia. And these patients will have thrombocytosis also. The key point here is leukocytosis with left shift and basophilia. Very commonly given in exam in a middle-aged to old-age person. And fish for Philadelphia chromosome, that is BCR-ABL fusion, is the gold standard right now. So you have to do in the bone marrow. And treatment of choice is imatinib. The most important side effect of imatinib is edema. In case if you're dealing with a T315A mutation, then ponatinib becomes the only drug of choice. Otherwise, first line treatment is imatinib. So massive spleen, patient will have a dragging pain on the left upper quadrant because of the big spleen, leukocytosis with left shift, basophilia, thrombocytopenia, and anemia will be there. Thrombocytosis and anemia will be there. Classic presentation. And what about polycythemia vera and essential thrombocytosis? These patients are going to have vasomotor symptoms. Typically, they will have something called as erythromelalgia, intense burning and painful sensation in the feet and hands. They will have aquagenic pruritus, and the most common mutation in any myeloproliferative disorder apart from CML is JAK2 mutation. That too in PCV will have the JAK2V617F mutation, which is the classic. And in case if you're dealing with polycythemia vera, the first line treatment will be phlebotomy. In case if phlebotomy is ineffective, you can use hydroxyurea. Very, very important treatment for both polycythemia vera and essential thrombocytosis. And aspirin should be given for all patients with PCV and ET in view of thrombosis risk. And how PMF will present? Primary myelofibrosis. They'll come with pancytopenia with a massive spleen because of extramedullary hematopoiesis, and they will have leukoerythroblastic picture, which is a triad of teardrop cells, that is dacrocytes, NRBCs, nuclear RBCs, and immature WBCs in the peripheral smear. And these patients are going to have extreme degrees of bone marrow fibrosis. So that is going to be the classic manifestation of PMF. And of course, you're going to have dry tap, yes. And leukemia-wise, we have APL, that is acute promyelocytic leukemia, which is also called as AML M3 in the past. In exam, the clue will be multiple OIR rods, which are also called as Faggot cells. And patients will have DAC at presentation, which is the most common cause of death in these patients. And most of these patients will be having T15-17 translocation, which is the fusion of PML and RARA together. Treatment will be with all-trans retinoic acid and arsenic trioxide. And 25% of those patients who receive ATRA will develop differentiation syndrome, where the patients will have fever, shortness of breath, AKI, hypotension, altered mental status, and so on. The treatment of choice for differentiation syndrome is going to be dexamethasone. And what are the important cytogenetic changes? So don't forget the CBF, core binding factor AML, so which is T821 and T1616, which has excellent prognosis, high cure rates, and even T1517 has a very, very good prognosis, excellent prognosis with high cure rates, APL patients. In ALL, the most common cytogenetic abnormality in children is going to be hyperdiploidy followed by T1221. In adults, it's going to be the Philadelphia positivity. That's the most common. Philadelphia positivity indicates worse prognosis. Anywhere outside AML, anywhere outside CML, if you see Philadelphia positivity, it is worst. And Burkitt's lymphoma is due to c-Myc overexpression. You know that. That's T814 is classic, but anything related to 8. Mantle cell lymphoma, cyclin D1 will be overexpressed in a classic cytogenetic abnormality called as 1114. In follicular lymphoma, BCL2 will be overexpressed with the classic cytogenetic abnormality called as T1418. And in hairy cell leukemia, you're going to have trap positive hairy cells in the peripheral smear, that is tartrate resistant acid phosphatase positive, massive splenomegaly in an old man, 50 plus, having cytopenias with anemia, thrombocytopenia, and the typical hairy cell markers will be these four: CD11, C25, 103, and 123. And patients will have BRAF mutation positive. Treatment is cladribine. And marginal zone lymphoma, I mean, not very important. T11, 18 may be asked in exam, but I don't think it's important. When it comes to marginal zone lymphoma, don't forget the parotid maltomas in Sjogren syndrome patients. CLL, the clue will be smudge cells in peripheral smear with absolute lymphocytosis. Almost 90% plus will be lymphocytes. The lymphocyte count will be like 50,000, 1 lakh, and there will be a lot of smudge cells in the peripheral smear. And most common cytogenetic abnormality is 13q deletion, which has actually a good prognosis. And the first line treatment for CLL is ibrutinib right now. And what about multiple myeloma? Don't forget the CRAB. Okay, the hypercalcemia, fludarabine. No, fludarabine is no longer used for CLL. It's actually ibrutinib. That's the first line treatment for CLL, chronic lymphocytic leukemia. And what about CRAB? CRAB stands for hypercalcemia. You can search in Google if you wish to. So hypercalcemia, renal failure, anemia, bone pain. Okay, this is a myeloma defining event. So anyone, if it's present, you can call it as myeloma. In that, what is going to differentiate multiple myeloma from others is the lytic bone lesions. Very, very important. In exam, if you see lytic bone lesion in a hematological condition, it's multiple myeloma unless proved otherwise. Diagnosis can be done with two things. One is bone marrow aspiration. We're going to have more than 10% clonal bone marrow plasma cells, more than 10% clonal bone marrow plasma cells. And along with it, you're going to have serum protein electrophoresis with immunofixation electrophoresis. So most common immunoglobulin that is seen in multiple myeloma is IgG followed by IgA followed by light chain only myeloma. Plasma cells more than 10% only. That is diagnostic of multiple myeloma to begin with. If it's more than 60%, that becomes a myeloma defining event. I didn't say more than 60% is a diagnostic criteria. More than 60% becomes a myeloma defining event. Okay. And treatment is going to be with triple therapy. So what is the triple therapy? We are going to use bortezomib, you're going to use lenalidomide, that is R, and you're going to use dexamethasone. Along with that, in high-risk patients, you can use daratumab, which is a CD38 blocker. So bortezomib, lenalidomide, dexamethasone, daratumab. These are the options. Most common cause of acute kidney injury in multiple myeloma is hypercalcemia followed by cast nephropathy, according to Harrison. And the first treatment in any multiple myeloma related AK is going to be IV fluids. Lots and lots of IV fluids. That's going to be helpful in hypercalcemia also. That's going to be helpful in cast nephropathy also. That's correct. In Waldenstrom's macroglobulinemia, I didn't write that, but it's important. Mid-88 mutations will be positive, and these patients will be very old. Plus, at the same time, they'll come with anemia, hepatosplenomegaly, and they will have lymphoplasmoid lymphocytes in the bone marrow and in the peripheral blood. Lymphoplasmoid lymphocytes in the bone marrow, not plasma cells, rather lymphoplasmoid lymphocytes, which will be CD20 positive. Multiple myeloma cells will not be CD20 positive. And these patients will have elevated IgM levels. They'll produce IgM spike in the electrophoresis, and treatment will be with bendamustine rituximab combination. Bendamustine with rituximab. Here you can use rituximab because they express CD20. You're going to use a combination of bendamustine and rituximab. Remember, these patients will not have lytic lesions. I've been telling this for so long. These patients will not have lytic lesions no matter what. If you have IgM spike with lytic lesions, it's going to be IgM myeloma only in exam. Don't mistake. Very common trap. If you have IgM with lytic lesions, it must be IgM myeloma only, even though it is a rare possibility, but still in exam it becomes a multiple myeloma. It cannot be a Waldenstrom. Understood, guys? Haven't part? What are the important things that you have to look for? The must-know points in exam, right? These are the absolute must-know points. In the sense, you cannot miss out on these points. Very, very important. Essential points. 100% you will get many questions from these points. Okay. So this thing I'm just telling because ID, I'm not going to teach you. Okay. So HIV treatment, currently we are going to use the TLE protocol only. So TLD only. So not TLE, TLD, that is tenofovir lamivudine dolutegravir first line, and I'm not going to teach more. Drug sensitive TB, you're going to use the 2 HRZT plus 4 HRE. Okay. So what can be asked in drug-resistant TB? In drug-resistant TB, you can be asked about the shorter MDR regime. Be very clear about that. Shorter MDR and the longer MDR regime. Longer MDR regime. They might ask about the BPAL regime also. So BPAL and BPAL-M regime is there. Even that can be asked in exam. Make a note of it. I mean, study that and go. So then we have the TPT, that is tuberculosis preventive therapy and cotrimoxazole preventive therapy in HIV. So right now, according to NACO guidelines and WHO, if CD4 is less than 350 itself, you have to start with cotrimoxazole. So previously it was 200, now it is 350. So when you start with tuberculosis preventive therapy, all patients, all HIV patients without active TB, all HIV patients without any active TB, you are going to start with tuberculosis preventive therapy. The standard drug of choice for TPT is H. That is, you're going to start with isoniazid for 6 months. That's a standard therapy. Most important opportunistics in HIV will be the Candida, TB, and so many other things are the toxoplasma. All these things are exam questions. Toxoplasma, then cryptococcal meningitis, all these things. So drug side effects of TB and HIV is very, very important. And what are the important tropical infections? So tropical infections will be, I think most importantly, the lepto part is very important. The clue will be the farmers or probably paddy field workers or probably those who are exposed to monsoon, or they can give scrub typhus where there will be eschar and the treatment of choice is doxycycline, and they might give enteric fever. They won't give mostly, but yes, enteric fever is possible. Or another thing is malaria and dengue. Another fever is malaria and dengue. Another thing is malaria and dengue. So all these things are very important for exams. You have to have a look at it. Otherwise, and some questions will come from this for sure. Okay. So what about the staphylococcus treatment? Staphylococcus, if it's MSSA, if it's methicillin sensitive Staph aureus, in exam, you're going to use what? Either cefazolin or you can use a nafcillin. Cefazolin or you can use a nafcillin or cloxacillin or dicloxacillin. If it's methicillin resistant Staph aureus, in exam, always you're going to use either vancomycin or linezolid, or you can use daptomycin, but important thing is that daptomycin is ineffective for pulmonary conditions. For lung problems, you cannot use daptomycin. Ineffective for lung conditions. For enterococcus, what treatment you're going to use? Enterococcus, it depends. The first line treatment is going to be ampicillin plus gentamicin. That will be the first line treatment for most cases. But in case if they mention penicillin resistance, then the treatment of choice will be vancomycin and gentamicin. In case if they mention vancomycin resistance, then you are going to use either linezolid or daptomycin. This will be the treatment of choice for vancomycin resistance. So vancomycin resistance is dangerous. It's going to show vancomycin resistant enterococcus. So CAP treatment, so the most important score we have discussed so many times, it's actually CURB 65. And you have to know the outpatient treatment, inpatient treatment, and ICU treatment. All these things we discussed already, okay, in a detailed manner. So meningitis treatment also we discussed already. So what treatment you're going to give. And UTI treatment also we discussed in one of the classes. So, but remember, if they say about community-acquired UTI, which is very common in females and uncomplicated UTI, you're going to use one of these 3 drugs, either a nitrofurantoin, or you're going to use a cotrimoxazole, or you can use a single dose of fosfomycin. Nitrofurantoin, you're going to use 100 milligram BD for 5 days. Cotrimoxazole, you can use 1 double strength tablet 2 times a day for 3 days. And fosfomycin, you can use 3 gram single dose. Just 1 dose is enough. Okay. And do not forget the sexually transmitted infections and color kits. Generally, examiners, I don't know, in FMG exam, definitely there will be 2 to 3 questions on HIV, STIs. And definitely there will be 1 to 2 questions on alcohol. This is a must. So 100% you will get 2 to 3 questions on HIV and sexually transmitted infections, and there will be definitely 1 to 2 questions on alcohol. This is like easy area to score in exam. So you have to know about those things. So BCC treatment is not important for you. That's a names question. Atypical treatment, I told you, you're going to use either doxycycline or azithromycin or levofloxacin. These are the standard options for atypical treatment in pneumonia. We have discussed that already. Leprosy treatment, the new guidelines, the MDT guidelines. So again, in FMG, leprosy is an important area. They will ask the You know that, right? The possibacillary and multibacillary, how will you treat? So now it's the same three drug only, but only the duration of treatment is different, right? It's the same three drugs you're going to use, but the duration of treatment will be different. 6 months and 12 months. That's it. No difference. Apart from that, the regime is the same. And don't forget the lepra 1 and lepra 2 reactions. Very, very important for exam. Last exam also they have asked this lepra 1, lepra 2 reaction. So type 1 lepra reaction is going to present with nerve thickening palsy. Nerve thickening and nerve palsy. And there will be flaring of the pre-existing skin lesions. Whereas type 2 lepra reaction is a systemic reaction where they'll come with erythema nodosum leprosum, nodular lesions in the skin. Along with that, there will be diffuse systemic reaction. Isn't it? So that is type 2 lepra reaction. So don't forget that, very important. And NTMs may be asked, not common. Not tuberculous mycobacteria may be asked, not very common, but may be asked, possible. Okay, understood, guys? Whatever I told you. I told you, the class will be like before 2 o'clock, I'll be finishing the class. Because the reason why I finished early is because I don't want to waste a lot of time. I just want to take like 3 hours of session and I just want to finish as much as possible. So just go through the PDF, you'll be understanding. I don't know, people are asking about the pedigree for a long time, but I have to go also. There is one important work that has come to me. So I wish you wholeheartedly all the very best and please study well. And I wish everyone to be on the other side, like once the results have come. And I'll post something in the about the pedigree in the group also. Don't worry about that. 100% I will put a flowchart and I'll show in the group. Don't worry. I'll put it in the group. 100%. Okay. Don't worry. Okay. Thank you so much. Once again, I'll be more than happy to see you on the other side. In fact, extremely happy. Take care. Bye. See you.
Voice coming to everyone? Yes or yes, please let me know in the comment section. Thank you so much. I should take out my jacket because my inside t-shirt is looking very nice. That's why. Once again, good evening, everyone. A beautiful day today should share some immense amount of knowledge. My name is Dr. Anand. Let's study something about pediatrics, beautiful topics, rapid revisions, lot of questions. In this segment, very importantly, we have, what you called spoken about the last 3 year 4 years PYQ. So that is why this class is really very important. So I'm connecting my cable over here and connecting my AirPods. So I hope everyone is doing great. How is everyone's health? I hope you guys are doing great. Life is beautiful, life is amazing. How is my new t-shirt? Zudio, only 399. Thank you so much. So yes, we'll start off and I'll just get my AirPods. Yes, my AirPods are ready. Let's start off this class. So this class is important. It is a marathon. Everyone will clear the exam. Life is beautiful. Everyone is amazing. Please keep studying very, very positively. Everything will make sense. All you have to do is just focus, focus, and focus. God has been kind. Everything is beautiful. And I have this FMG previous year topics and questions from 2021 to 2025 and 2027 also. So quickly, I'm asking for the last time, is my voice coming to everyone? Quickly tell me, hi, hello, is my voice coming? Please let me know. Yes or yes, 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 yes. Perfect. Let's start off this class. Lot of questions are there. I request everyone to participate as much as possible. बिना मुंह बनाए भगवान का नाम लिए कोशिश करें participate करने की. And life is beautiful. Before starting any segment, we always have a quote, and the quote for today is: "Your only limit is your mind. Your only limit is your mind." Life is beautiful. Tell yourself you're a beautiful soul. Tell yourself you know everything. And most importantly, in the exam time, if you open a question paper, your first question, your first answer is the best answer. Listen, everyone, hello. Your first answer is the best answer. Your first thought is the best answer. Are you understanding? Don't overthink on the questions. Remember that, okay? So let's start off this class. Question number one. We are talking about FMG June 2021. We will start and we'll end up by 2025. All the previous year questions. Let's finish them off. 24-year-old woman came for an antenatal checkup who is currently on lithium for her bipolar disorder. This drug must be stopped due to risk of the development of which of the following infection? So what do you think, guys? If the mother has taken lithium during pregnancy, the baby can land up into Epstein anomaly. What is the shape of the heart you have in Epstein anomaly? Kaun batayega? So very importantly, you see a box shape heart, number one. Number two, next question, why the mother has taken lithium? Who will tell me why the mother was taken lithium during pregnancy? Because lithium is a drug of choice for the bipolar disorder. If the mother has taken lithium during pregnancy, the baby can have Epstein anomaly. If the mother has taken danazol during pregnancy, if the mother has taken danazol during pregnancy, the baby can land up into virilization, important for the exam purpose, number one. Number two, if the mother has taken misoprostol during pregnancy, if the mother has taken misoprostol during pregnancy, the baby can land up into Mobius syndrome. The baby can land up into Mobius syndrome. M for misoprostol, M for Mobius syndrome. If the mother has taken erythromycin during pregnancy, if the mother has taken erythromycin during pregnancy, the baby can land up into congenital hypertrophic pyloric stenosis. Very importantly, yes, very true. So these are the important pointers must appreciate for the exam purpose. So if the mother has taken, very importantly, thalidomide, if the mother has taken thalidomide during pregnancy, the baby can land up into phocomelia. If the mother has taken alcohol during pregnancy, if the mother has taken alcohol during pregnancy, the baby can land up into fetal alcohol syndrome. Fetal alcohol syndrome. So these are the important teratogenic drugs. An infant, which of the following milestones is achieved at the earliest? So let's very easy. So if I ask you a simple question, mature pincer grass kab aata hai? When does mature pincer grass comes? Yes, very good. So mature pincer grass, very important. Mature pincer grass basically comes by 1 year. Mature pincer grass, so basically it comes by 1 year. If the baby is holding something, if the baby is holding something with thumb and index finger, that is known as mature pincer grass. Very importantly, तनुज जो ऑप्शन मुझे लगेंगे ना रेलेवेंट है समझाने एक्सप्लेन करने के लिए, बाकी तो मैं अपने आप ही बता दूंगा, टेंशन ना लो, ठीक है. So if the mature pincer grass holding something with two finger only, that comes by 1 year. And immature pincer grass comes by 9 months. Now we have something known as radial grass and ulnar grass. जब भी बच्चा कुछ उठाता है ना, if you look at the camera, if this is something is there, if baby is holding something, first he will hold by the ulnar grass, and then he will hold by the radial grass. First the baby 6 month old baby वो ulnar aspect से कोई चीज उठाएगा, and 8 month old baby radial grass he will have. So this is very important, the one which is earliest to achieve. Remember very importantly, 6 महीने का बच्चा ulnar aspect से उठाता है और 8 महीने का बच्चा radial aspect से उठाता है. Please remember. Yes, very good. So 6 month old baby will have a ulnar grasp, 8 months old baby will have a radial grasp, 9 months old baby will have a immature palmar grasp, and whereas 1 year old baby will have a mature pincer grasp. The following image is one of the most common cause for stridor in children. Yes, कोई कुत्ता भी बता देगा. Oscar, which is the most common cause of stridor in pediatric age group? Oscar is like, I don't answer such silly questions. Please ask middle class questions. So very importantly, the most commonest cause of stridor, very importantly, that is laryngomalacia. And which epiglottis you see in laryngomalacia? So where do you see omega shape epiglottis? The answer is laryngomalacia. Please remember that, number one. Number two, very importantly, I have a baby who has distress which improves on crying. I have a baby who has a distress which improves on crying. If the distress improves on crying, we are talking about choanal atresia. Very, very important. I have a baby who has a distress. Which increases on supine position and relieves on prone position. ऐसा कौन सा बच्चा है कि distress increases on supine position and relieves on prone position? The answer is laryngomalacia. Laryngomalacia. I'll just have water, 1 second. Yes, cheers. So these are the important points must appreciate for the exam purpose. The first primary tooth to appear in a baby, which is the first अमिताभ बच्चन कह रहे पानी था, दूध पी रहा था मैं, दूध. The first temporary teeth to appear in a baby. The first temporary teeth to appear in a baby is a lower central incisor, which comes by 6 to 7 months. Which is the which is the first permanent teeth to appear in a baby? Yes, the first permanent teeth to appear in a baby is the first molar, which comes by 6 to 7 years. The first permanent teeth to appear in a baby is what is important is first molar, which comes by 6 to 7 years. Which is the last permanent teeth to appear in a baby? The last permanent teeth to appear in a baby is the third molar, which comes after 18 years. The last permanent teeth to appear in a baby is the third molar, which comes after 18 years. And which is the last temporary teeth to appear in a baby? The last temporary teeth to appear in a baby is the second molar, which comes after 18 months. So these are the very, very important questions for the exam purpose. And how do you, so what is the normal human dental formula? Any idea? In adult, what is the normal human dental formula? So it is 2123 by 2123 is the normal human dental formula. We have to clear the exam. Okay, life is beautiful. By 8 o'clock it is a 2 to 3 hour session. Very beautifully we'll cover all the 5 years PYQ. Try to revise and finish it off. Identify the condition as shown below in the X-ray radiograph. So we all know that kind of intestinal contents have gone out over here. There's a beautiful picture of congenital diaphragmatic hernia. Question number 1, diaphragm is supplied by which nerve? कौन बताएगा? Yes, diaphragm is supplied by phrenic nerve. What is the root value of phrenic nerve? कौन बताएगा? The root value is C3 C4 and C5 is very important. Number one. Number two, so congenital diaphragmatic hernia. Congenital means by birth, and diaphragm. This is a diaphragm hernia. Hernia. So hernia means very importantly all the intestinal contents have gone out. Now exam entrance question number one. Which is the most commonest type of congenital diaphragmatic hernia? MCQ. It is the posterolateral type. It is the posterolateral type, which is known as Bocker-Dulac hernia. Which is known as Bocker-Dulac hernia. The most commonest type of congenital diaphragmatic hernia is Bocker-Dulac hernia. Number one. So सारा का सारा अगर intestine ऊपर चला जाएगा, when all the intestine will go up into the chest, what will happen to the abdomen? Very importantly, what will happen to the abdomen? Please remember, the patient will have scaphoid abdomen. The patient will have scaphoid, मतलब पिचक जाएगा, क्योंकि सारा का सारा intestine, all the intestine have gone up. That is why the abdomen has become shrunken, known as scaphoid abdomen. So scaphoid abdomen, baby having distress, and very importantly, अगर auscultate करोगे तो क्या मिलेगा, कौन बताएगा? If you auscultate, you will have bubble sound in the chest. You will have bubble sound in the chest. So bubble sound in the chest, scaphoid shaped abdomen, all these important pointers are, and the most commonest type of congenital diaphragmatic hernia is Bog-Dulac hernia. Yes, Pranay has told a very beautiful point. What is the, okay, we talk about bag and mask ventilation. So bag and mask ventilation, very importantly, kaun batayega, which is the absolute indication and which is the absolute contraindication of bag and mask ventilation. So we all know that hum bag and mask kab haath lagayenge? Yes, life is beautiful. Yes, life is so beautiful. So when the heart rate is less than 100, the absolute contraindication of bag and mask ventilation is heart rate less than 100. And what is the absolute contraindication of bag and mask ventilation? The answer is congenital diaphragmatic hernia. So if a baby has a heart rate less than 100 with congenital diaphragmatic hernia, तो आपने तो बोला कि don't do bag and mask, अभी क्या करना चाहिए फिर? So now, of course, in congenital diaphragmatic hernia, you will not do bag and mask. What we will do, you will intubate and ventilate. You will intubate and ventilate. That is important if you do heart rate less than 100 with congenital diaphragmatic hernia. Every single second counts. Life is amazing. We're gonna have a cerebellum party with drinks, as in vegetarian drinks, not non-vegetarian drinks, and a lot of selfies, lot of meeting. Dr. Zainab, everyone will be there. Please finish this exam, crack this exam. We're gonna have a very, very big party in a very five-star hotel. So it's gonna be amazing. And we're gonna meet, that day you will come and hug me. Anand sir, you were there and I can meet you now. So 200 plus, we can do it. It's not that bad also. I swear to God, please finish it off. Revise, 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 and finish. 5-year-old child is brought to you with complaints of 18 episodes of loose stools in the last 24 hours. So 18 episodes sunke pehle aayega chakkar. 18 episodes. Oh my God, looks like a severe dehydration. And he's vomiting twice in the last 4 hours. The child is irritable but drinking fluids. But if he is drinking fluids, so obviously he is into some dehydration. Very importantly, like you can say no, mild to moderate or no to some dehydration. And in this case, what will you do? Of course, ORS, ORS, ORS. I would have given IV fluids, if the child was not at all drinking. Yeah, plain water and ad libitum. No. ORS, 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 ORS is the best answer. Yes, Rohit Sharma, very good. Someone has told pink category. Pink कब देंगे? जिसने pink बोला है अपने आप में बहुत गंदी सी गाली दें, because we have diarrhea with no dehydration, diarrhea with some dehydration, and diarrhea with severe dehydration. So severe dehydration comes under pink category, some dehydration comes under yellow category, and no dehydration comes under any idea. So we have the green category. So this patient comes, looks like he's drinking the fluids and all that, looks like some dehydration to me. So ORS is the best answer for this question. Now, very importantly, ORS. So here also ORS and zinc. Here also it is ORS at the rate of 75 ml per kg. But I have a doubt. My doubt is how much is sodium in ORS? कौन बताएगा? How libitum is nothing, वो ऐसी बकवास है. How much is sodium in ORS? Any idea? So very importantly, yes, you are right. Sodium is 75. Do we have something else also 75? Any idea? Glucose. Glucose is 75. So 75, 75, and 65. What is 65? Chloride. Chloride is 65. If chloride is 65, what is 20? 20 is potassium, and what is 10? Citrate. Citrate is 10. So this is very important. Sodium 75, glucose 75, chloride 65, potassium 20, and citrate is 10. Yes, Dr. Avinash, very good. कि ये पूरे पैकेट का ऑस्मोलैरिटी कितना होता है? The whole packet osmolarity is 245 milliosmoles per liter. 245 milliosmoles per liter. If this is ORS, then what is Resomal? Have you heard of Resomal? Resomal is rehydration solution for the malnourished. Sam बच्चों का पैकेट, ORS पैकेट, that is Resomal. Normally the ORS packet, no, you take 1 liter bottle of water and you add 1 packet of ORS. But here you have 2-liter bottle of water and you add 1 packet of ORS. Water will be double. 1 liter of water and 1 packet of ORS, that is ORS. And in Risomol, you have 2-liter bottle of water and 1 packet of ORS. So potassium kitna hota hai? Who will tell how much is potassium in the Risomol? So very importantly, yes, please remember, potassium will be double, that is 40, and sodium will be half. So sodium will be 45, potassium will be 40. Normal ORS potassium is 20, here it is 40. Normal sodium is 75, and here it is 45. So yes, very importantly, you can do it. Do you think you have the guts to do it? What do you think, guys? Do you think you have the balls to clear an exam? Do you think it's that difficult? I don't think so. We can do it. हो जाएगा. इतना भी मुश्किल नहीं है. कोई कुत्ता भी clear कर. Oscar, can you clear an exam? Oscar is saying, of course I can clear. So much of revision I have done. Then why will I not clear? You tell me that. Okay. Now, which of the following biochemical parameters are corrected in vitamin D dependent rickets? Now, in the case of vitamin D dependent rickets, very importantly, vitamin D dependent rickets. So, rickets, we all know that serum calcium in a case of rickets, the best answer over here is option number B. Now, listen very carefully, it's very easy. In a case of rickets, we all know there is vitamin D or there is a serum calcium basically कम हो जाता है. Serum calcium decreases or even body tries to compensate also, so it can behave normal also. Listen very carefully, okay? In a case of rickets, there is deficiency of vitamin D or deficiency of calcium, but still the body will try to compensate, so you can get either decrease or a normal calcium. Number one, that is the first point. Now, very importantly, if the calcium is low, very importantly, then my parathyroid hormone definitely will increase, because parathyroid hormone releases the calcium, right? That's why. So hyperparathyroidism leads to hypercalcemia. So I'll repeat again. Number one, calcium will be decreased or normal. That will lead to increase in the parathyroid hormone, क्योंकि वहां से calcium निकलता है, because calcium releases from there. And automatically parathyroid hormone, when it increases a lot of calcium, उसके साथ साथ phosphate also release. धन्या, इसको बंद कर देगा दरवाजा, ठीक है? So phosphate also, very importantly, remember, serum alkaline phosphatase also, that will increase, and serum phosphate level will decrease. So that is the best answer for this question. Please remember, so in the case of vitamin D dependent rickets, serum calcium will be normal or slightly decrease, and that will lead to increase in the parathyroid hormone, and parathyroid hormone will increase, and even serum alkaline phosphatase also, ALP also will increase. Now remember one thing also, there is something known as vitamin D dependent rickets type 1 and vitamin D dependent rickets type 2. Now who will tell me what is the difference between vitamin D dependent rickets type 1 and vitamin D dependent rickets type 2? Now, very importantly, the enzyme problem over here is when 1-alpha hydroxylase. 1-alpha hydroxylase. So remember, very importantly, 25 hydroxy vitamin D gets converted into 125 dihydroxy vitamin D, and the enzyme responsible is 1-alpha hydroxylase. Number one. I'll repeat again, in vitamin D dependent rickets type 1, there is a deficiency of the enzyme 1-alpha hydroxylase. Normally, 25 hydroxy vitamin D gets converted into 125 dihydroxy vitamin D, and the enzyme responsible, MCQ, the enzyme responsible is 1-alpha hydroxylase. In a case of vitamin D dependent rickets type 1, there is a deficiency of enzyme 1-alpha hydroxylase. That is why you're gonna have the deficiency hoga to conversion nahi hoga, and there is decreased level of this vitamin D3. Whereas in a case of vitamin D dependent rickets type 2, this 1-alpha hydroxylase is perfectly normal. This 1-alpha hydroxylase is perfectly normal. This 25 hydroxy vitamin D is very beautifully getting converted into 125 dihydroxy vitamin D. फिर प्रॉब्लम कहाँ पे होती है? प्रॉब्लम होती है एंड ऑर्गन रेजिस्टेंस. एंड ऑर्गन रेजिस्टेंस मतलब विटामिन डी बनता तो है पर हमारी बॉडी में एब्जॉर्ब नहीं होता. सो देयर इज एंड ऑर्गन रेजिस्टेंस. दैट इज व्हाई आई एम गोना हैव एलोपेशिया. Vitamin D levels are normal, but they are not getting absorbed in my skin, in my hair. I'm gonna have alopecia and gonna have a dental decay, dental, you can say dental delay. दांत भी नहीं बनेंगे, malocclusion will be there, and there'll be alopecia. So this is an extra point you should know. Quickly, I'm putting it again. There are two types of vitamin D dependent rickets, type 1 and type 2. In a case of type 1, the enzyme deficiency is 1-alpha hydroxylase, and that's why the conversion will not happen, and you will have a decreased level of vitamin D3. Whereas in vitamin D dependent rickets type 2, the enzyme, this enzyme is beautifully working, the conversion is beautifully happening, but the problem is end organ resistance. Yes, my dear Ayush, life is beautiful, I love you. Next question, please. Steroid resistant nephrotic syndrome is defined as failure to achieve remission after weeks when on daily corticosteroid therapy. Now, this is important for the exam purpose. What is the meaning of steroid resistant nephrotic syndrome? If you give if the baby is on prednisolone, we all know that the drug of choice for nephrotic syndrome is prednisolone. If you give prednisolone at the rate of 2 mg per kg per day for 6 weeks, उसके बाद भी आराम नहीं आ रहा है. Yes, आयुष, still the patient is not going into remission. Remission का मतलब क्या होता है? आराम आना, means proteinuria खत्म हो जाना. So that is why it is known as, very importantly, steroid resistant nephrotic syndrome. And the best answer, 4 to 6 weeks is the best answer. Okay, remember that, latest guidelines. Okay, remember. Number one, I'll repeat again. What is steroid resistant nephrotic syndrome? If I'm giving prednisolone at the rate of 2 mg per kg per day for 6 weeks, still the patient is not getting into remission, then it is known as steroid resistant. And what is the drug of choice? The drug of choice, very importantly, we have the mnemonic, that is CT. C for cyclosporin and T for tacrolimus. Cyclosporin and tacrolimus are the two important drugs we have in a case of what you call steroid resistant nephrotic syndrome. So important for the exam purpose. Okay, here also if I ask you extra question, what is the normal proteinuria? Kaun batayega? What is the normal proteinuria? We have normal proteinuria, we have yes iPad, we have non-nephrotic range proteinuria, and we have nephrotic range proteinuria. Important for the exam purpose. We have normal proteinuria, non-nephrotic range proteinuria, and nephrotic range proteinuria. Less than 4 to 40, and more than 40. Less than 4 to 40, and more than 40. So less than 4 milligram, yes, less than 4 milligram per meter square per hour is normal proteinuria. 4 to 40 milligram per meter square per hour is non-nephrotic range proteinuria, and more than 40 is nephrotic range proteinuria. 9-year-old girl was brought to the emergency room with fever since 2 days, along with dyspnea, drooling, and stridor. Dyspnea, drooling. Lateral X-ray neck findings were as seen below. So yes, very importantly, what can you see in the X-ray? We can see very beautifully a thumb sign. So it is a case of acute epiglottitis. is, and very importantly, what is the most commonest cause? It is Haemophilus influenza type B. It is Haemophilus influenza type B. And what is the treatment? क्या दवाई देते हैं इसके अंदर? This omega shape epiglottis and not omega shape, this word called thumb sign and cherry red epiglottis, distress, dysphagia, dysphonia, and drooling of saliva. Undoubtedly, yes, Raj, you're right. That is antibiotics. Antibiotics is a treatment of choice. Yes, definitely ceftriaxone. Yes, Sachiv, you're very, very right. Identify the abnormality in the following X-ray of newborn with respiratory distress. The same, very importantly. So respiratory distress. So we all know it is a case of congenital diaphragmatic hernia. Now, one more question, let me ask you. Congenital diaphragmatic hernia. So we all know diaphragm is supplied by phrenic nerve. Which is the thickest nerve of the body? Kaun batayega? Which is the thickest nerve of the body? The thickest nerve of the body is the sciatic nerve. What is the root value for sciatic nerve? Any idea? The root value for sciatic nerve is L4, L5, S1, S2, S3. L4, L5, S1, S2, S3. Which is the smallest bone of the body? Let me see your general knowledge. Which is the smallest bone of the body? The smallest bone of the body is stapes. It is stapes. Which is the Taylor's muscle? Who will tell which is the Taylor's muscle? Taylor's muscle is known as sartorius. Taylor's muscle is known as sartorius. So Taylor's muscle is sartorius. Smallest bone of the body is stapes. Thickest nerve is the sciatic nerve, and diaphragm is supplied by the phrenic nerve. Next, which of the following statement is true? First, hand-to-hand transfer appears and then palmar reflex appears. What do you think? क्या पहले आता है? Palmar reflex पहले आएगा कि hand-to-hand आएगा? So we all know that naturally the best answer for this question is option number B. बच्चा पहले palmar, see, naturally first the palmar reflex disappears, then you have the hand-to-hand transfer, na? So palmar, so every time the baby is holding something like a unidextrous approach. So first is the palmar reflex appears, then the baby will have hand to hand. उसके बाद बच्चा एक हाथ से दूसरे हाथ से वो करेगा. So when does hand to hand transfer appears? When can a baby transfer objects from one hand to another? The baby can transfer objects from one hand to another by 6 to 7 months. Number one. Yes. So very importantly, see, there is something known as unidextrous approach and something known as bidextrous approach. So who will tell me when does unidextrous approach comes? If the baby is holding something with both the hands, दोनों हाथ से पकड़ रहा है, that is unidextrous approach, comes by 4 months. Then we have bidextrous. We are very so I'll repeat again. Yes, we are very right. So first we have, of course, that is the bidextrous approach, which comes by 4 months. He will hold something with both the hands. Then we have the unidextrous approach, which comes by 6 months. पहले बच्चा दोनों हाथ से पकड़ेगा, comes by 4 months. फिर बच्चा एक हाथ से पकड़ेगा, comes by 6 months. And फिर बच्चा क्या करेगा? He will transfer objects from one hand to another, that comes by 6 to 7 months. Okay, so yes, I'll repeat again. The holding something with both the hands, bidextrous, comes by 4 months. Holding something with one hand, unidextrous, comes by 6 months. Okay, if I ask you a random question, who will tell me when can a baby draw a straight line? Any idea? When can a baby draw a straight line? Yes, very good. A straight line has two ends. So a 2-year-old can draw a straight line. When can a baby make a plus? A plus has, very importantly, 1, 2, 3, 4 ends. So 4-year-old baby can make a plus. Between 2 and 4, you have a 3. A baby can make a circle by 3 years. When does handedness appears? P by Q for FMG. My daughter is a left-handed or right-handed? 3 years. So handedness comes by 3 years. When can a baby make a square or a rectangle? So by roughly around 4.5 years, a baby can make a square or a rectangle. When can a baby make a triangle? A baby can make a triangle by 5 years. When can a baby make a diamond? A baby can make a diamond by 7 years. A baby can make a diamond by 7 years. Then we have 8 year, 9 year, 11 year. 9 साल का बच्चा क्या बनाता है? 8-year baby he can make a, so 8-year baby he can make a doctor sign. 9-year-old baby he can make a cylinder, and 11-year-old baby he can make a 3D cube. He can make a 3D cube. So these are the beautiful drawing skills at various ages. And if baby can make a straight line by 2 years, अगर एक 2 साल का बच्चा straight line बनाता है, उसके पहले वो क्या करेगा? Before that, what he will do? He will do something known as scribble. And when can a baby scribble? A baby can scribble by 15 to 18 months. A baby can scribble by 15 to 18 months. And 15 months baby, remember, he can make a tower of 2 cubes, and 18 months baby, he can make a tower of 3 cubes. 30 minutes of class is over. Has everyone understood? Yes or yes, 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 yes. Aruna, did you understand little bit? क्या ढक्कन जैसे दिमाग में 250 ग्राम इंफॉर्मेशन गई कि नहीं गई? Please let me know. Thank you so much. Quickly, a 1 minute of break. 30 minutes are over. Let's have a quick 1 minute of break. Yes, 30 seconds of break. Relax yourself. Life is beautiful. Life is great. We have to clear this exam. It's very easy. Please make your timetable properly. Please pushing yourself as much as possible. लाइफ इज जिंदगी भगवान की एक बहुत महंगी गिफ्ट है. लाइफ इज रियली ब्यूटीफुल. प्लीज डोंट वेस्ट योर टाइम. इफ यू आर फीलिंग बोर, स्टडी समथिंग एल्स. If you're tired, you sleep, but you please make a timetable, and please don't waste your time. Every single seconds count. Anxiety, it's okay. If you have anxiety, you can not have anxiety. You can do it. Everything is possible. सब हो सकता है, कुछ नहीं, हलवा है हलवा. And very importantly, please, you should know where is your exam center. You should know the whole structure of the exam: negative marking, positive marking, how much far is your center. Please have good breakfast and go during the center, and of course you will get a plus very, 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 very soon. That is you. Next question, please. So yes, very importantly, a child presents with generalized weakness. His hemoglobin level was low and serum iron was low. Which of the following vitamins help in the iron absorption? Whenever we give iron to a child, we always tell them to have citrus fruits. Citrus fruits खाएं, because citrus fruits is rich in vitamin C. That is why. Number one. Next question, very importantly, that a boy present with features of shock and cold clammy skin. Okay, shock and cold clammy skin. What is the next management? So naturally, of course, for hypovolemic shock, the first fluid is normal saline. So you will give normal saline at the rate of 20 ml per kg. You will give normal saline at the rate of 20 ml per kg. Then again, you will check, for example, 10 kilo का बच्चा है. Who will tell me 10 kilo का बच्चा है? He is in shock. So how much NS you will give? So 1 kg baby, you will give 20 ml. So 10 kg baby, 10 into 20 is very importantly, 1000 कहाँ से आ गया? So yeah, 10 kg, 20 into 10, yeah, very importantly. So 1 kg baby, you will give 20 ml. So 10 kg baby, you will give 200 ml. किस कुत्ते ने 1000 बोला? It is 200 ml only. This is not diarrhea with dehydration. We are talking about shock. This is not diarrhea with dehydration. This is a normal shock, hypovolemic shock. Okay. So very importantly, Tanuj, मेरा भी maths weak है. So if a baby is 10 kg, he's in shock, then you will give 20 ml per kg of normal saline. Then you check the vitals again. If still the vitals are negative, still means the patient is not having pulse properly, then you repeat the NS same at the rate of 20 ml per kg. So basically you can give 3 bolus. This is the first bolus, this is the second bolus, and if still the vitals are coming negative, then you will give the third bolus, same normal saline at the rate of 20 ml per kg. So 20 20 20 means after 60 ml per kg total, still the vitals are negative, then you tell the patient is land up into fluid refractory shock. फ्लूइड रिफ्रैक्टरी शॉक, मतलब फ्लूइड से आराम नहीं आ रहा है. दिस इज द मैनेजमेंट ऑफ शॉक. दिस इज नॉट डायरिया, दिस इज द मैनेजमेंट ऑफ शॉक. सो फर्स्ट बोलस 20 ml, सेकंड बोलस 20 ml, थर्ड बोलस 20 ml, टोटल 60 ml पर kg देने के बाद भी the vitals are negative, then I'll say very importantly it is fluid refractory shock. उसमें हम क्या करेंगे? After that क्या होगा? What do you think, guys? This is stat, Spartan. This is not like 5 minutes. It's a bolus. Bolus का मतलब होता है बस जल्दी दो, ठीक है? Patient is very sick. Give then and there only. After 20, what do you think, guys? After 20 of normal saline, abhi bhi BP nahi aa raha hai. Still the BP is not there. Then what will you do? You will call this is a fluid refractory shock. Then you will go on inotropes. Then you will go on inotropes. What are the inotropes we have? The inotropes option we have dopamine, we have dobutamine. So we have dopamine, we have dobutamine, and we have adrenaline. So dopamine, dobutamine, and adrenaline. Very importantly, remember, dopa very importantly has a, it acts on the alpha receptor. Dobutamine has a B, it acts on beta receptor. And adrenaline, it acts on alpha plus beta receptors. Like that you should know. For example, in a case of, very importantly, cardiogenic shock. In a case of, if I ask you a question, in a case of cardiogenic shock, which inotrope do you think will be very nice? So beta receptor acts on heart and it causes tachycardia, increases the heart rate. So in a case of cardiogenic shock, you will give dobutamine because beta receptor acts on the heart, which causes tachycardia. So dopamine acts on alpha receptor, dobutamine acts on beta receptors, and adrenaline acts on alpha plus beta receptor. These are the examples of inotropes you will give in a case of fluid refractory shock. Next question, please. Mutation in which gene is seen in Wilson disease? Very importantly, you should know. अभी डायरी आगे आएगा दोबारा. So we have ATP7B. Definitely ATP7B gene mutation you see in Wilson disease, and ATP7A gene mutation. Yes, ATP7A gene mutation you see in a case of Menkes disease. Next, very importantly, FGFR3. FGFR3 gene mutation you see in a case of achondroplasia. FGFR3. Number one, PTPN11. PTPN11 gene mutation you see in a case of Noonan syndrome. GABRA1 gene mutation you see in a case of juvenile myoclonic epilepsy. Very good. Where the drug of choice is sodium valproate. Where the drug of choice is sodium valproate. We have to clear this exam. Just padhte raho. Keep listening. You will remember. Acha, juvenile myoclonic epilepsy. So juvenile means it is a pediatric patient. Myoclonic. Myo का मतलब क्या होता है? What is myo? Myo means muscle, and what is clonic? Clonic means contractions. Bar. There's a involuntary contractions again. Tuck like that. So very importantly, what you call, how the question comes. The question comes. We have a child who has twitching of fingers and dropping of objects. He has twitching of fingers. See, this word examiner tells twitching of fingers and dropping of objects. So where do you see twitching of fingers and dropping of objects? Very importantly, someone is saying Rett syndrome. I'm so sorry. This is not Rett syndrome. Rett syndrome will have a hand wringing movement. Rett syndrome, the highlighter will be a hand wringing movement. And what is the gene mutation? The gene mutation is MECP2. And what is the drug of choice? Trofinetide or trofenetide, you can say. That is Rett syndrome. Remember that. Hand wringing, haath chalega. Now this one is not just hand wringing. This is twitching of fingers and dropping of objects. Seen in juvenile myoclonic epilepsy, the drug of choice is sodium valproate, and it has a very good prognosis. Okay, yes, Zoom user, you are very right. Next important point we have over here is SLC39A4 FMG PYQ. SLC39A4 gene mutation you see in a case case of acrodermatitis enteropathica. And acrodermatitis enteropathica, it is because of deficiency of zinc. So these are the important points you should know. Has everyone understood this much? 40 minutes, total 40 minutes are over. Quickly put a like button. Are you able to understand? Yes or yes, 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 yes. So we're gonna finish the class soon. दुश्मनों को भी यही खल रहा है, दुश्मनों को भी यही खल रहा है कि अब तक हमारा दिया कैसे जल रहा है. The next question we have over here, the condition seen in this child could be due to which of the following? The condition seen in child, so we all know this is again a PYQ. These are 2021 to 2025 PYQs. So this patient has abdominal distension. So where do you see abdominal distension? Kwashiorkor or marasmus? So very importantly, Kwashiorkor, and Kwashiorkor is deficiency of proteins. Yes, the best answer for this question, it is Kwashiorkor due to less protein intake. Kwashiorkor is deficiency of protein. Yes, in Kwashiorkor, what are the liver finding? Liver में क्या मिलेगा? Kwashiorkor is a fatty baby, so you will see fatty liver. Number one. Number two, what is the hypoglycemia cutoff in severe acute malnutrition? The hypoglycemia cutoff is less than 54. Dr. Bhatura, he said 45. Someone who said 45, अपने आप को एक बहुत गंदी सी गाली दीजिए, because neonatal hypoglycemia, yes, the cutoff is less than 45, but SAM baby hypoglycemia, it is less than 54. And severe acute malnutrition, it is seen in 6 months to 5 years baby. Severe acute malnutrition 6 महीने से 5 साल के बच्चों में देखा जाता है. Please remember that. Number one. Number two, so these are the important points you should know in a case of this one. Okay, next question please. Which drug is preferred in a premature neonate for closure of PDA? Yes, very nice question. So we all know that PDA. So PDA, what is PDA, my dear family? We have to clear the exam. Okay, आगे कब बढ़ेंगे? When are you going to buy a BMW? It's only 65 lakh rupees. Okay, any Oscar, can we buy a BMW? Yes, he is very possible it is. So very importantly, please remember patent ductus arteriosus. Patent ductus arteriosus, it is present between the pulmonary artery and descending aorta. It is present between the, yes, Donald Trump, Donald, I'm saying Donald, I said Donald. Yeah, please focus. So very importantly, yes, so patent ductus arteriosus, it is between the pulmonary artery and descending aorta. Okay, number one. Number two, I have a doubt, bro. Is PDA, is it a right to left shunt or left to right shunt? What do you think? Yes, Sachin. So PDA, we all know that at the left side of the heart, has a higher pressure. That is PDA. It is always a left to right shunt. Number one. Number two, very importantly, sir, is it a what do you call cyanotic congenital heart disease or acyanotic congenital heart disease? In this condition, all the blood is going to the lungs for the purification. That is why it is a acyanotic congenital heart disease. This condition has a oligemic lung filled condition or plethoric lung filled condition. So this one has a increased pulmonary artery blood flow, which is also known as plethoric lung filled condition. So if I ask you name some congenital heart disease with plethoric lung fields, the answer is ASD, VSD, PDA. And very importantly in PDA, what is the murmur do you see in a case of PDA? You will see a continuous machinery murmur. You will see a continuous machinery murmur that you see in a case of PDA. And where do you see pansystolic murmur? So please remember, pansystolic murmur you see in a case of VSD. So pansystolic murmur you see in VSD, continuous machinery murmur you see in a case of PDA. Now, very importantly, we all know once the baby is out, we all know once the baby is out. So normally placenta secretes PGE2. Placenta secretes PGE2, which keeps the ductus arteriosus open. Once the baby is out, placenta is cut, PGE2 levels go down, and ductus arteriosus closes. And if it is not closing, then what is the drug we'll give? We will give ibuprofen followed by indomethacin. Ibuprofen followed by indomethacin we will give. So these are the beautiful points we have in a case of PDA. Now, next important, अगर हम PDA को खुला रखना चाहते हैं, if you want to keep the PDA open, then what is the drug of choice? The drug of choice is L-prostadil. The drug of choice is L-prostadil. So very importantly, yes, the drug of choice is L-prostadil. ये कौन सा prostaglandin है? It is PGE1 analog. It is PGE1 analog, that is L-prostadil. What is the probable diagnosis in this child with a bull neck? So bull neck appearance, nasal twang, and nasal regurgitation. So bull neck appearance, nasal twang, and nasal regurg, that happens in diphtheria because it is a swelling. These all are cervical lymphadenopathy. All cervical submandibular lymph nodes are activated. So this is nothing but diphtheria. हाँ बोलो, लगा दे कोई करना तो है ही, ऑप्शन नहीं और. So very importantly, this is diphtheria. Remember that, number one. Number two, this is in general, we should know for the exam purpose. And diphtheria means leather. The Greek meaning of diphtheria is leather, leathery appearance. Remember that. Okay, number one. Number two, 7-year-old immunized child. Now, this is an immunized child who has a thumb sign on X-ray. So thumb sign on X-ray, very importantly, that is acute epiglottitis. So we all know the most commonest cause of acute epiglottitis, definitely it is Haemophilus influenza type B, but in immunized baby, it is Streptococcus pneumoniae. In immunized child, it is Streptococcus pneumoniae. Remember that, number one. A 3-year-old child came with recurrent episodes of diarrhea and abdominal distension. On examination, he has anemia, short stature, and not gaining weight and height. एंडोस्कोपी कराया था और एंडोस्कोपी में मिला है डियोडिनल बायोप्सी में विलस एट्रोफी. वेरी स्ट्रेट फॉरवर्ड क्वेश्चन. diarrhea. We are talking about celiac disease. So we all know celiac disease, it is a disease of G and G. G for gluten, the patient has a gluten sensitivity, and G for genes. Which genes mutation do we have? We have HLA-DQ2 and HLA-DQ8. The mutations we have is HLA-DQ2 and HLA-DQ8. So diarrhea, my patient will have because of the gluten problem. Yes. So very importantly, gluten problem. And what is not allowed? So we all know BROW, bro is not allowed. So what is bro? Any idea? B for barley and bread. B for barley and bread. R for rye. O for oats, and W for wheat. W for wheat. So this is something is not allowed. ये खाएगा तो baby will have diarrhea. Remember that. Yes, you're right, Amitabh Bachchan. Rice chalega, definitely rice chalega. What is the name of the classification? What is the name of the classification for celiac disease? We have Marsh classification. Pura naam, the full name is Marsh Oberhuber classification, but Marsh classification is the name of the classification, number one. Number two, in the GI, in the abdominal symptom, yes, the patient will have diarrhea. Not just the diarrhea, he can have constipation also. And once he have constipation, he is going to have a pain abdomen known as tenesmus, pain abdomen, pain while passing stool. So chal jayega Shubham. So these are the GIT manifestation, but the MCQ, which is the most common extra intestinal clinical feature, which is the most common extra intestinal clinical feature of celiac disease, the answer is iron deficiency anemia. Because my child is having diarrhea, I am gonna have iron deficiency anemia. No, dermatitis herpetiformis in pediatric age group, dermatitis herpetiformis it is a clinical feature, but it is not a most common extra intestinal manifestation. Adult की बात करें तो हो सकता है, but in a pediatric population, the most common extra intestinal clinical feature of celiac disease, very importantly, is iron deficiency anemia. Remember that. Dermatitis herpetiformis, yes, it is seen in celiac disease, but it is not the most common extra intestinal clinical feature. Now FMG, after FMG June 2021, now we are coming FMG December 2021. Which of the following is the absolute contraindication of breastfeeding? What do you think, guys? Yes, very importantly, yes. So the most common extra, the absolute contraindication of breastfeeding is galactosemia and lactose intolerance. Galactosemia and lactose intolerance, these are the absolute contraindication of the breastfeeding. And lactose intolerance, so okay, number one. Number two, what is the cataract do you see in galactosemia? Any idea? Which cataract do you see? You will see oil drop cataract. So oil drop cataract you see in a case of galactosemia. If oil drop cataract you see over here, where do you see sunflower cataract? Where do you see sunflower cataract? The answer is Wilson disease. The answer is Wilson disease. Remember that. Number one. Number two, these are the absolute contraindication in the baby. In the baby, what are the absolute contraindication of breastfeeding in the mother? The mother on chemotherapy, the mother on radiotherapy. So mother on chemotherapy, mother on radiotherapy, and mother having herpes simplex virus infection. Yes, exactly. The mother having HSV positive infection. Okay, so these are the important points you should know regarding the breastfeeding. Achha, one more thing also, let me ask you more question. If I compare the breast milk with the cow's milk, if I compare the breast milk with the cow's milk, what do you think, guys? How much calories do we have in the breast milk? The breast milk contains 65 kilocalories and the cow's milk contains 67 to 72 kilocalories. If we talk about the proteins, how much proteins is there in the breast milk? Remember 1.1 and 3.1. 1.1 and 3.1. So breast milk contains 1.1 gram of protein and cow's milk contains 3.1 gram of protein. So this was the FMG PYQ कि गाय के दूध में ऐसा क्या है जो माँ के दूध से 3 गुना ज्यादा होता है. What is there in the cow's milk which is 3 times more than the mummy's milk? The answer is protein. And very importantly, what about the lactose? Remember 7.4 and 4.7. 7.4 and 4.7. So each 100 ml of breast milk, remember, it contains 7.4 gram of lactose and cow's milk contains 4.7. Calcium कितना होता है मम्मी के दूध में? Calcium, it contains 33 milligram in the mummy's milk and around 250 milligram you have in the cow's milk. So these are the so important, important points regarding the differences between the cow's milk and the buffalo's milk. So very important. Cows, not cow and buffalo, mother's milk and cow's milk. Okay, someone is saying that cow's milk and buffalo's milk. Very nice. तो तुम भैंसे बन जाओ पहले फिर बात करेंगे. Vitamin K supplementation. Vitamin K supplementation is given to neonate to prevent what? So vitamin K supplementation, very importantly, it is given to a neonate to prevent the hemorrhagic disease of newborn. Very good. That's right. Hemorrhagic disease of newborn. Now this newborn, very importantly, will be a village delivery newborn. ये गांव में पैदा होगा and he will be exclusive breastfeed baby. Exclusive breastfeed baby. Remember that. Very good. That's right. Why exclusive breastfeeding? Because so why it is exclusive breastfeeding? Because we all know that breast milk very importantly, it is deficient. Breast milk is deficient in vitamin D, vitamin K, and vitamin B12 if the mother is a pure vegetarian. Breast milk is deficient in vitamin D, vitamin K, and vitamin B12 if the mother is pure vegetarian. So that is why. And breast milk is rich in which vitamin? So breast milk is rich in, remember, the mother is feeding the child in AC room. The mother is feeding the child in AC room. So breast milk is rich in vitamin A and vitamin C. Okay, tetralogy of Fallot is most commonly associated with which of the following? We have done that. Tetralogy of Fallot is associated with two syndrome, D for Down syndrome and D for Di-George syndrome. D for Down syndrome and D for Di-George syndrome. Remember that. Very importantly, tetralogy of Fallot is associated with that. Tetralogy of Fallot, what are the components of tetralogy of Fallot? Tetra means 4, right? So what are the components of tetralogy of Fallot? Tetralogy of Fallot, number one, the patient will have right ventricular hypertrophy. The patient will have pulmonary stenosis. The patient will have a ventricular septal defect, and the patient will have a overriding of aorta. Overriding of aorta. So these are the important points we have over here is regarding the tetralogy of Fallot. Right ventricular hypertrophy, pulmonary stenosis, ventricular septal defect, and overriding of aorta. And which is the heart you see in X-ray? So very importantly, where do you see boot-shaped heart? The answer is tetralogy of Fallot. 8-year-old boy came with, very importantly, dark color urine, oligurean hypertension. The patient has hypertension. Okay, and facial puffiness for 3 days. The urine test is positive for albumin. The patient has albumin urea, means protein urea. Now, this patient has protein urea, this patient has facial puffiness. Do you think it's nephrotic syndrome? The answer is no, because hypertension you don't see in nephrotic syndrome. Hypertension is not there in the nephrotic syndrome. This is, and the patient has a recent history of throat infection 2 weeks back, means the antigen has come, that a streptococcus has come in the cough and cold, and now he's attacking the kidney, causing a post streptococcal glomerulonephritis. Yes, PSGN, and there the patient can have a cola color urine or a dark color urine. The patient can have a hypertension. Why in any kidney pathology you will have hypertension? What do you think, guys? Why in any kidney pathology you will have hypertension? Because in any kidney pathology, in any hypoxia to the kidney, you activate the RAS, get activate the RAS. Any hypoxia to the kidney, RAS will get activate, that is renin angiotensinogen aldosterone system. And this renin angiotensinogen aldosterone system causes sodium water retention. It causes sodium water retention, which causes hypertension, like that. Okay, 7-year-old boy has a non-blanching rashes on the legs and the buttocks as seen in the picture. So any baby in pediatric population who has rashes over the, specifically in the buttocks, so you have Hinong Schonlin purpura. Okay, Hinong Schonlin purpura is which immunoglobulin accumulation? IgA. When you have too much of IgA accumulation in the skin, the patient will have palpable purpura. If you have IgA deposition in the joints, the patient will have joint pain or arthritis. IgA accumulation in the GIT, the patient will have abdominal pain. And IgA deposition in the kidney, the patient will have hematuria and also proteinuria. So this is a very, very importantly, important pointers you should know regarding these important things. So IgA deposition, the answer is Hinong Schonlin purpura. And yes, so, and there was a neat PG question here. This is a self-resolving. All these autoimmune conditions are self-resolving problems, but you have to give steroids. In which condition you will give prednisolone in this patient? You will give prednisolone if the patient has pain abdomen. In the case of GIT manifestation, if the patient has pain abdomen, तब आप prednisolone देंगे, वरना it is a self-resolving condition. Okay, a newborn baby presents with irritability and cyanosis which subsides on crying. Here only if I stop you, the baby has a distress or cyanosis which improves on crying. Definitely we're talking about choanal atresia. And what is the management for choanal atresia? So choana means nose बंद हो रखा है. तो अभी क्या करेंगे? If the nose is closed, you're gonna give a oropharyngeal airway you will put, and followed by intubation. If the child is very sick, if the oropharyngeal intubation se kaam nahi chal raha hai, if oropharyngeal airway is not getting succeeded, then you go for, very importantly, endotracheal intubation. If I talk about a neonate baby, who will tell me what is the normal heart rate of a baby? The normal heart rate of a newborn is 120 to 160 beats per minute. Definitely B is the best answer. What is the normal respiratory rate of a baby? It is around 40 to 60 per minute. What is the normal capillary filling time? The normal capillary filling time is less than 3 seconds. A baby should pass stool within how many hours? PYQ. A baby should pass stool within 48 hours, and he should pass urine within 24 to 30 hours. Number one. Number two, what is the normal blood pressure of a baby? The normal blood pressure of a baby, adult, it is 120 by 60. So half of 120 is 60 and half of 60 is 40. So 60 by 40 mm of mercury is the normal blood pressure of a newborn baby. एक बच्चे में खून कितना होता है? How much blood is there in a newborn baby? Blood around 60 to 80 ml per kg is the blood in a baby. And what about the preterm baby? In a preterm baby, it is 90 to 110 ml per kg. 90 to 110 ml per kg. So has everyone understood this much? Yes or yes? Please let me know. थोड़ा बहुत समझ में आया या कुछ भी समझ में नहीं आया? जिंदगी का बस एक अंदाज रखें, जिंदगी का बस एक अंदाज रखें, जो तुम्हें ना समझे उसे नजरअंदाज रखें. 1 hour of class is over. Let's have a quick break. 1 hour is over. Should take a break of 10 minutes because this one person has come who is fixing the door of my room. That is why little noise will be there. So we'll start the class at 6:10. We will start the class at 6:10 because one fellow he's clearing the door of my house. That's why. So see you guys at 6:10. Thank you. Good evening and regards. I hope my voice is audible to everyone. Please let me know if my voice is coming to everyone. Thank you so much. Let's start off this class. A 10-month-old child undergoes treatment for diarrhea with hypokalemia, but the child does not respond to the treatment appropriately. And on examination, muscular weakness is noted. So this is a very straightforward question. Remember, hypokalemia and hypomagnesemia happens together. Just remember, hypokalemia and hypomagnesemia happens together. If with after hypokalemia also the muscle weakness is not going, that means the patient has very importantly hypomagnesemia. So this is something you have to remember. Hypokalemia and hypomagnesemia happens together. A child who was fed only on rice water presents with a swollen belly and a dull face. So swollen belly and a dull face, what do you think? What are we talking about? And he has a fat sugar appearance. Definitely the answer is Kwashiorkor. Now let's do more MCQs about it. So we all know that, okay, how do you define severe acute malnutrition? So acute malnutrition, which is the parameter affected in acute malnutrition? So remember, W for weight, H for height, and A for age. If you have decreased weight for height, if there is decreased weight for height, that is known as acute malnutrition, and which is also known as wasting. Number one. Number two, if there is decreased height for age, if there is decreased height for age, that is known as chronic malnutrition, and the parameter affected is known as stunting. The parameter affected is stunting. So this is important. One is wasting, one is stunting. One is acute malnutrition, one is chronic malnutrition, and very importantly, it is weight for height less than -3 standard deviation. This is a PYQ, remember, for exam purpose for FMG. Child is brought to the pediatrician with short stature. On examination, growth hormone levels are found to be high. So growth hormone levels are high, and insulin like growth factors, basically they are low. So this is also a very interesting question. If growth hormone levels in my body are high, see, remember always, if normally what happens, the growth hormone, it acts on the receptor, and that basically leads to increase in the insulin like growth factors. Normally what happens in our body, normally our growth hormone, it acts on our growth hormone, basically it acts on some receptors, which basically causes basically increase in the insulin like growth factors, and that basically helps in my growth of the body. But in this case, what is happening? The growth hormone levels are found very high, means the growth hormone is not acting on the receptor, and that is why the insulin growth like factor should go very high, but here the insulin like growth factors levels are low. So iska matlab simple sa hai, there is a growth hormone receptor anomaly. Remember, there is a growth hormone receptor anomaly because growth hormone is not acting on the receptor properly, because if growth hormone was acting on the receptor, then it would have acted on insulin like growth factors, and their levels should go high, and that's how I should grow. But here it is not acting on the receptor, that is why insulin like growth levels are low in the body. Remember that. Okay. Yeah. Next important point, we have a 3-day-old male neonate who has not yet passed meconium. Straight away, if I ask you a question, 3 days old baby has not passed meconium, 3 questions should come to your mind. That is anal atresia, that should come hypothyroidism, and that should come Hirschsprung disease. So this doesn't look like a hypothyroidism, this looks like a Hirschsprung disease, where one part of the bubble, there's an absence of ganglion cells in one part of the bowel, and that is why we'll do a rectal examination. And rectal examination, very importantly, yes, rectal examination, forceful expulsion of stool was observed. That gripping of finger, basically a gush of stool after removing the finger. Yes, Dhania, very good. Gush of stool after removing the finger. And what is the investigation of choice? The investigation of choice is rectal biopsy. And what is the name of the surgery we have? Yes, very good. Full thickness rectal biopsy. The name of the surgery we have is Duhamel procedure. MCQ surgery. Where do you do Duhamel normal procedure? The answer is very important in a case of intersusception. Yes, very good. Next question. In a child presenting with febrile seizure, what is the drug of choice? So what do you think, guys? What is the drug of choice for febrile seizure? Yes, it is rectal diazepam. It is rectal diazepam or intranasal midazolam. Rectal diazepam or intranasal midazolam, very importantly, is a drug of choice. Very, very importantly, is seen in a case of febrile seizure. अच्छा, कौन बताएगा what is the drug of choice of a neonatal seizure? Any idea? What is the drug of choice for neonatal seizure? The drug of choice for neonatal seizure is phenobarbital. The drug of choice for neonatal seizure is phenobarbital. Acha, where else have you used phenobarbital? Who will tell me where else have you used phenobarbital? Phenobarbital, it is used in Crigler-Najjar. Phenobarbital, it is used in Crigler-Najjar syndrome type 2, and also it is used in Sydenham's chorea. It is also used in Sydenham's chorea. So that's what. So phenobarbital, it is used in, very importantly, we have done that. हमने पढ़ा हुआ already in the neonatal jaundice वाला chapter, Crigler-Najjar syndrome type 2 and Sydenham's chorea also. So 3 questions very importantly. It is the phenobarbital. Why it is not sodium valproate? Because sodium valproate is not the drug of choice in febrile seizure. Sodium valproate drug is the drug of choice in juvenile myoclonic epilepsy, or also it is in the drug of choice, very importantly, of absence seizures. In a case of absence seizure, either you can give ethosuximide followed by sodium valproate. Like that, you should know. Okay, very good. Next question. 31-year-old lady with a diabetes mellitus delivers a term neonate. Which of the following problem may be associated with the baby born to the lady? क्या हुआ? Okay, so just think about it and let me know. I'll give you 1 minute. Yes, that's right. So very importantly, the most common congenital heart in infant of diabetic mother is a VSD. The most common congenital heart disease in infant of diabetic mother is a VSD. And this baby, we all know that the mother, so very importantly, the mother will be hyperglycemic. The mother will be hyperglycemic and baby will be, yes, the baby will be hypoglycemic. Very good. So who told this answer? Very good. If the mother is hyperglycemic and baby is hypoglycemic, what is the hypothesis known as? This is known as Pedersen's hypothesis. This is known as Pedersen's hypothesis. That is one thing. An extra question, which is the most common congenital heart disease in infant of diabetic mother? The most common congenital heart in infant of diabetic mother is a VSD. And most specific कौन सा होता है? The most specific is TGA. Now, very importantly, TGA is transposition of great arteries. What is the X-ray finding of TGA? कौन बताएगा? That is अंडे पे धागा, egg on side appearance you see in a case of TGA. Is TGA a duct dependent congenital heart disease? What do you think, guys? Is TGA a duct dependent congenital heart disease? Are you okay? Someone said no, TGA is not a duct dependent congenital heart. Welcome, see you after 6 months again, because the answer is yes, TGA is a duct dependent congenital heart disease. In TGA, keeping the PDA open is very, very important. TGA is a duct dependent congenital heart disease. Okay, अपने आप को एक गद्दी सी गाली दें जिसने कहा था कि TJ is a not a duct dependent. It is a duct dependent. Remember that. Which of the following statement is incorrect about colostrum? Yes, कौन बताएगा? Which of the following statement is incorrect about the colostrum? Okay, now this is an interesting point. Colostrum, very importantly. So we all know, listen very carefully, my dear. So everyone will clear, yes, I know. So breast milk, we all know that breast milk contains very high amount of lactose and less amount of proteins, right? 7.4 gram was the lactose and 1.1 gram was the protein as we compare to the, yes, very good, Dr. Bacteria, as compared to the cow's milk. But this is not breast milk, this is the colostrum, the first milk of the mother. So first milk of the mother, this is an incorrect statement about the first milk of the mother. Colostrum actually contains less amount of lactose and more amount of protein. This is the first 2 to 3 days or that first milk of the mother. But apart from that, normally breast milk contains high amount of lactose and less amount of proteins. This is like very simple, genuine question you should know for the exam purpose. Acha, wo kaun batayega the beginning part of the breast milk? The beginning part of the breast milk is known as, any idea? Yes, very good. The beginning part of the breast milk is known as foremilk. So beautifully, everyone is answering. The beginning part of the breast milk is known as foremilk, and the end part, the end milk of the breast is known as hind milk. Very good, that's right, number one. Number two, now who will tell me, acha, which one helps in the thirst of the baby? Yes, the foremilk helps in the thirst of the baby, whereas satiety value, it is there in the hind milk. Foremilk contains all the proteins, vitamins and minerals, except, who will tell me, except the answer is fat. The answer is fat. So foremilk contains all the protein, vitamins and minerals, and hind milk contains fat. Very good, beautiful, everyone is beautifully answering. Again, a FMG PYQ, dystrophin protein is absent completely in which disease? The answer is very importantly, that is Duchenne muscular dystrophy. Okay, Duchenne muscular dystrophy, definitely yes. Duchenne muscular dystrophy, what sign do you see? The answer is Gover sign. That's very well true. Duchenne muscular dystrophy में Gover sign का अलग से photo आता है, where the patient is not able to get up from the sitting position. They might show you a photo. And very importantly, in the calf muscle, what they will show you, any idea? In the calf muscle, there will be pseudo hypertrophy. In the calf muscle, there will be pseudo hypertrophy. Because why? Because muscle has been replaced by, yes, the muscle has been replaced by fat. Number one. Number two, as I'm saying, I'm having a Gover sign, I'm not able to get up from, yes, very good, Goli beta, very good, not able to clean get up, by himself. Is it a proximal muscle weakness or a distal muscle weakness? So very importantly, this is a proximal muscle weakness. This is a proximal muscle weakness, number one. Number two, what is the treatment? Treatment ke liye, do we have any drug? Please remember, we have Drisaperson. Drisaperson is the drug we have over here in a case of Duchenne muscular dystrophy. So these are the beautiful points must appreciate for the exam purpose. Calf muscle pseudo hypertrophy, Gover sign, muscle has been replaced by a fat, proximal muscle weakness, and Drisaperson. Someone was talking about tripod position. उस किसी ने मुझसे पूछा कि tripod position कहाँ पे था? So in the respiratory chapter, where you're at tripod position, yes, in a case of acute epiglottitis, the patient comes to you casualty with distress, dysphagia, dysphonia, and drooling of saliva, and he's in a tripod position, sitting as a hyperextended neck and tripod position. 6-year-old child brought to her pediatrician for routine well baby checkup. Her physical examination is normal except for a systolic murmur and a wide fixed split of the second heart sound. This is very interesting. So yahi to padna hai. This is what the highlighter you have to pick up. Remember, we have ASD, we have VSD, and we have PDA. In the ASD, you will have wide fixed split of the S2. V for VSD, V for variable split of the S2. Okay, so ASD has a wide fixed split, V for VSD, V for variable split of the S2. P for PDA. What is P for PDA? P for paradoxical split of the S2. Paradoxical split of the S2. This is the important point. Everyone should clear. Everyone will clear. There's no doubt about it, bro. But please, please, please look at the highlighters. So wide fixed split of S2. The answer is atrial septal defect. Yes, beautiful rotavirus. Beautiful. Next question, please. Which is the most common acyanotic congenital heart disease? कौन बताएगा? The most common acyanotic congenital heart disease, the answer is VSD. And which is the most common cyanotic congenital heart disease? The most common cyanotic congenital heart disease at day of life 1, अगर एक दिन का बच्चा है MCQ में, then the answer is TGA. And whereas in the older children, the answer is tetralogy of Fallot. The answer is TOF. Very good. That's right. Now we're talking about FMG June 2022 questions. What is the pattern of inheritance of the neural tube defect? Yes, this was the question they had asked. Yes, Monkey King. What all IDs we have? We have rotavirus, we have Monkey King, and we have Rohit Sharma, Amitabh Bachchan. Very good. Very inspiratory channel, I must say. The pattern of inheritance for neural tube defect is multifactorial inheritance. Number one. Yes, Udta Tir. We have Udta Tir also in the market. Very good. That's nice. अच्छा, name some autosomal dominant inheritance. कौन बताएगा? Any autosomal dominant inheritance? So autosomal dominant inheritance. Remember, guys, the mnemonic is MAT. So M for MAT, M for Marfan syndrome, A for achondroplasia, A for achondroplasia, and T for Treacher-Collin syndrome. Treacher-Collin syndrome. Number one. Number two, M for Marfan syndrome. Opposite of M is W. Opposite of M is W. Yes. Dolan. It is Donald Trump only. You have written Dolan Trump just to make fun. I know. That's why I'm thinking why I'm having difficulty in pronunciation. So M for Marfan syndrome. Opposite of M is W. W for Williams syndrome. And W for, very importantly, yes, W for von Willebrand disease. Now these all condition, guys, please remember, it is autosomal dominant. It is autosomal dominant inheritance. So MAT is the mnemonic. M for Marfan syndrome, A for achondroplasia, T for Treacher-Collin syndrome. Opposite of M is W. W for Williams syndrome, and W for von Willebrand disease are all the examples of the autosomal dominant. They ask in exam that all of the following are autosomal dominant except, like that you should know. Next question. 7-year-old female brought to the OPD with cramping abdominal pain. On examination, she is found to have rashes on the back of her legs, buttocks, and extensor surface of her forearms. Now, very importantly, yes, so we all know. So mostly on the legs and buttocks, mostly on the legs and button and abdominal pain again, and he has proteinuria and hematuria also. The answer is Hinong Shonlin purpura. Yes, exactly. Now, if I ask you a simple question, okay, yes, Anushka, okay, name, who will tell me this Hinong Shonlin purpura? Is it a large vessel vasculitis, or it is a medium vessel vasculitis? What do you think, guys? Is it a large vessel vasculitis or a medium vessel vasculitis? The answer is it is a small vessel vasculitis. What are the examples of large vessel vasculitis? Who will tell me? So it is Takayasu arteritis. It is Takayasu arteritis and giant cell arteritis. Takayasu arteritis and giant cell arteritis are the examples of large vessel. Medium vessel vasculitis, the mnemonic was peekaboo. Peekaboo was the mnemonic. P for polyarteritis nodosa, K for Kawasaki disease, and B for Burger disease. B for Burger disease. That's what. So polyarteritis nodosa, K for Kawasaki, B for Burger disease. And what are the small vessel vasculitis? Small vessel, we have Hinong Shonlin purpura, we have SLE, we have Wagner's granulomatosis. Wagner's granulomatosis. So these are the important points of the large vessel, medium vessel, and small vessel vasculitis. Okay, so this is very, very important. Has everyone understood little bit? Yes or yes? Please let me know. We have to clear the exam. We have to. Do you think you guys can clear? We can clear. Imagine a cerebellum party. We're taking selfies. We're dancing on. Oh baby doll, मैं सोने दी. Oh baby doll, मैं सोने दी. सोने सोने पटोले लखा. सोने सोने पटोले. मैं तकदियां रहंदियां खा मैं तकदियां रहंदियां है कि दसां अपनी वे ऐ चंद करदा है तारीफा हो मेरे हुस्न दी कोने 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 दी हो कोने कोने दी हो बेबी डॉल में सोने दी हो बेबी डॉल में सोने दी. The next important point we have is do what is right, not what is easy. Do what is right, not what is easy. So do what is right. What is right? Making a timetable. What is right? If I am shifting from the timetable, focus again. What is right? Focus, relax, meditate, 5 deep breaths, 5 deep inhale and exhale, and then start the topic every day when you study. Morning, afternoon, evening, guys. Whenever you're starting studying again, 1, 2, 3, 4, 5. Inhale. 1, 2, 3. Hold. 1 and 2 and 3 and 4 and 5. Exhale before the exam or paper. Also, please do this before starting the paper. A laborer's younger child is brought to the OPD with a swollen belly and dull face. He has fed rice water in his diet. So, what do you think? Definitely, we're gonna have a lot of repeated question. FMG PYQs all is about repeat. Lot of repeat topics are there. So, of course, we're talking about Kwashiorkar. लेकिन बात यहाँ खत्म नहीं होती है. I'm gonna ask you a lot of other questions of Kwashiorkar. So, definitely, we're gonna talk about severe acute malnutrition. We can also diagnose by using a tape. What is the known of that tape? Any idea? That is Shakir tape. Let's talk about Shakir tape, guys. So number one, Shakir tape has how many colors? Yes, Shakir tape has 3 colors. We have red, yellow, green. Red, yellow, green. Beautiful. Yes, that's right. Shakir tape has 3 colors. That is red, yellow, green. So Shakir tape, we check the mid upper arm circumference. Remember, less than 11.5, less than 12.5, and more than 12.5. Simple, very easy. So a mid upper arm circumference less than 11.5 centimeter, that is known as SAM. Mid upper arm circumference less than 12.5 centimeter, that is known as MAM. What is MAM? MAM is moderate acute malnutrition. SAM is severe acute malnutrition. MAM is moderate acute malnutrition. Very good, beautiful. 3-year-old child was brought to the OPD for regular checkup. His growth chart shows BMI between 85 to 95 percentile. Straightforward question. When the BMI is between 85 to 95, very importantly, that is known as overweight. If the BMI is more than 95th percentile, that is known as obese. Straightforward question. BMI 85 to 95th percentile is known as overweight, and more than 95th percentile, that is known as obese. If I ask you very simple, okay, microcephaly, कौन बताएगा? Microcephaly is defined as, microcephaly is head circumference less than -2 standard deviation. And what is macrocephaly? Macrocephaly is head circumference more than 2 standard deviation. That is the first thing. Second important point, definition of short stature. Who will tell me what is, how do you define short stature? It is height less than -2 standard deviation. Short stature. And what is tall stature? Tall stature is height more than 2 standard deviation. So this is something very straightforward. They ask this question. Remember, for exam purpose, very, very important. Okay, next question, please. Mother complained that her child is reluctant when it comes to taking feeds appropriately. Her child, a 15-month-old baby, has a height for age less than -2 standard deviation. When the height for age is affected, it is definitely stunting. But the problem is it a moderate stunting or a severe stunting? So yes, very importantly, when height for age is less than -2 standard deviation, that is known as moderate stunting. That is known as moderate stunting. Let me ask you one more question also. What is the dose of vitamin A? What is the dose of vitamin A in severe acute malnutrition? So dose of vitamin A less than 6 months, how much do you give? So less than 6 months baby, 50,000 IU. 6 months to 1 year baby, 1 lakh IU. Less than 6 months, 50,000 IU. 6 months to 1 year, 1 lakh IU. More than 1 year, 2 lakh international units. And if the child is more than 1 year and less than 8 kg, then the dose is 1 lakh international units. Number one. Number two, vitamin A, if the patient has, हाँ जी ये oral है dear, yes ये सब कुछ oral, vitamin A का syrup आता है, ये oral है. And if the patient has vitamin A deficiency features, you know, then what is the, what you call the dose you will give? So then the dose very importantly will be day 1, day 2 and day 14. ठीक है, हाँ, day 1, day 2 and day 14. Okay, so very importantly this you should know for the exam purpose, day 1, day 2 and day 14. Number 1. Number 2 also very importantly, okay, routine. अगर routine आपको vaccination देना हो, if you have to give routine vaccination, then what, when all you'll give vitamin A? In the routine vaccination, vitamin A is given at 9 months of life. Vitamin A, it is given at 9 months of life. Very, very good. And after 9 months, very importantly, when do you give? So after 9 months, very importantly, you will give every 6 monthly. Yes, we will give every 6 monthly till 5 years. We will give every 6 monthly till 5 years. Remember that. Okay. So these are the important points you should know. Acha, total how many doses? Yes, the total doses you are covering is 9, and total units you are covering is 17 lakh international units. The total units you are covering is 17 lakh international units. We will clear, we have cleared. I want everyone to write on their first page of the notebook that I have cleared FMG exam. I want everyone to write on the first page of their notebook that I have cleared. Even you can you know, put a marks also. I took an interview of a student. He told, sir, I had written 202 marks, I will get it, and I got 215. So like that. So on every page of the workbook, the first page, and wherever your wall, your studying, no, study room is there, wahan bhi somewhere you write, I have cleared the exam and my score is 202, like that. Like, so that's what. Very, very good. So that's how you do it. Which of the vitamin is breast milk is deficient in which vitamin? Breast milk is deficient in vitamin D, vitamin K, and vitamin B12 if she's a pure vegetarian. So definitely vitamin K definitely is the best answer. 1.5-year-old child brought to the hospital with history of breathlessness, fever, fever less than 37 degree, cough, cold. On examination, the RR is 46. Now RR is 46. ये क्या है? Is it pneumonia or is it severe pneumonia? So this is interesting question जो पक्का एग्जाम में आएगा. So we all know fast breathing with or without chest in drawing. Fast breathing with or without chest in drawing, that is known as pneumonia. So fast breathing with or without chest in drawing is known as pneumonia. If there are danger signs, that is known as severe pneumonia. So 0 to 2 months, 3 months to 1 year, and 1 year to 5 year. What is the respiratory rate cutoff? Respiratory rate more than 60, more than 50, more than 40. Right? This is a very important exam question. Very, 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 very important. I'll repeat again. Fast breathing with or without chest in drawing is known as pneumonia. And in this case, the child is 1.5-year-old having RR more than 40. We did 1 to 5 year RR more than 40. That is fast breathing. Okay, number 1. Number 2, yes, the child has pneumonia, even though there are no chest retraction, but still the child has pneumonia. But the child does not have severe pneumonia. There is no refusal to feed. There is no lethargy. There is no vomitings and all that. So that is why this is pneumonia. And the answer is administer oral antibiotics and warn for danger signs and send home. Fever definitely is not a part of pneumonia. Fever plus minus. Okay. And the treatment is home treatment. That is amoxicillin for 5 days. Yes, Dr. Batura, very good. Which is the most commonest cause of seizure in a 2-year-old child? The most commonest cause of seizure in a 2-year-old child is febrile seizure. Number 1. Acha, which is the most commonest cause of seizure in a newborn? Which is the most commonest cause of seizure in a newborn? Is that he has not cried immediately after birth, something known as hypoxia, something known as HIE, hypoxic ischemic encephalopathy. Achha, which neonatal seizure has the worst prognosis? Which neonatal seizure has the worst prognosis? So worst has a W, opposite of W is M, so myoclonic seizure. Myoclonic seizure has the worst prognosis, and the one which is worst is least common. The one which is worst is least common. Remember that. That is myoclonic seizure. So this is something important for the exam purpose. You should know. Young boy with fatigue is found to have hemoglobin less than 9. Peripheral smear shows sickle shape RBCs. So in a case of sickle cell anemia, exactly, common things are common and rare things are rare. So see, remember, whenever you have a sickle cell anemia patient or if you have a thalassemia patient, you have to keep the hemoglobin around 10 gram per deciliter. ये हमारे हॉस्पिटल का भी रहता है. If you have a patient of thalassemia, sickle cell anemia, any patient who requires any bleeding disorders, hemolysis patients, thalassemia, sickle cell anemia, our always the cutoff is 10 hemoglobin. So he is less than 8 hemoglobin. I would like to give blood transfusion. I would like to give blood transfusion, number one. Number two, very importantly, in sickle cell anemia, what is the amino acid change? Any idea? MCQ. So remember, very importantly, gluval. So the glutamate amino acid has been replaced by valine. So when glutamate amino acid has been replaced by valine, so the beautiful biconcave RBC has become sickle shape RBC. The beautiful biconcave RBC has become sickle shape RBC. इस वजह से क्या हो रहा है? इस वजह से हो रहा है hemolysis. That is why hemolysis is happening, and the patient is having splenomegaly. More the hemoglobin will break down, and that's what what you called more the spleen, the graveyard of RBC spleen, the patient will have splenomegaly. And yes, you are right, after 5 years, जब बच्चा 5 साल का around हो जाएगा, the patient will have autosplenectomy. And this is the sickle shape RBC. If you zoom this picture beautifully, so these are the sickled shape, very classical sickled shape RBCs are there. So this is very important for the exam purpose. Yes, you're right. Now we have FMG January 2023. Let's have a quick 1 minute of break. Can we clear this exam? Do you think it's possible? No, sir, it is impossible. I don't think so I can do it. Do you think it's possible? Maybe, maybe not. What do you think? Maybe not. What do you think? The answer is it is definitely possible. Life is so beautiful. Life is so amazing. Everything is so beautiful. Why can't you just see, man? Everything is beautiful. You just need to breathe. You just need to enjoy the day. You must feel successful. Successful is the one who enjoys his daily routine. Don't say, once I achieve something, then I will be happy. Say, I am happy and let's achieve this. Do you think it is possible? Can I say I am happy and let's achieve this? Do you think it's possible? It's definitely possible. वो ओके, पुराने वाला शेर सुनाता हूँ. वो कहते ना कि मेरी हर बात से इनकार करते हो, मैं कैसे कह दूं कि तुम मुझसे प्यार करते हो, याद कभी कभार करते हो, मैं कैसे कह दूं कि तुम मुझसे प्यार करते हो, तुम जो करो असूल क्यों, तुम जो करो असूल क्यों, मैं जो करूं फिजूल क्यों, हो जिस बात से चिढ़ मुझे, वही बार बार करते हो, मैं कैसे कह दूं कि तुम मुझसे प्यार करते हो. That's what. Think about it. गाना पानी आड़ी पानी प्यादे, पानी आड़ी पानी प्यादे, कुएं और खड़ी होगी, I am thirsty, give me water. During neonatal resuscitation of a term baby, what is the amount of oxygen you will start with? This is a very nice question. Okay, पहली बात तो ये कि हाँ, so whenever you're giving oxygen to anyone, you will give 21% of oxygen. For example, this is very important, okay? 21% of oxygen. For example, if a baby has a heart rate less than 100, straight away question, baby has a heart rate less than 100, what will you do? The answer is I will do bag and mask ventilation, which is also known as positive pressure ventilation. Now this bag and mask ventilation, remember, so if this is the bag and mask, there is a full mask is there. Now in this bag and mask, remember always there is a reservoir also, and there is one oxygen inlet pipe also. एक ऑक्सीजन का पाइप होता है और एक रिजर्वॉयर का पाइप होता है, and this is the bag and this is the mask. Okay, so whenever you're giving bag and mask ventilation, you don't put the reservoir and if you don't put the oxygen inlet, आप खाली बैग एंड मास्क कर रहे हो, पीछे वाला बैलून, पीछे वाला रिजर्वायर और पीछे से ऑक्सीजन अटैच नहीं कर रहे हो, तो आप कितना ऑक्सीजन दे रहे हो? आप दे रहे हो 21% ऑफ ऑक्सीजन. If you're not attaching the reservoir, if you're not attaching the oxygen inlet, you're just doing a back end mask, this because that is what you should do, and then you're giving 21% of oxygen. And if you are attaching the reservoir and you're attaching the oxygen inlet, अभी हम कितना ऑक्सीजन देंगे? Now you are giving 100% of the oxygen. Now you're giving 100% of the oxygen. Remember that. Acha, one more question also. What is the ideal temperature of labor room? Let's revise neonatology. What is the ideal temperature of labor room? The ideal temperature of labor room is 25 to 28 degrees Celsius. What is the normal temperature of newborn? What do you think, guys? What is the normal temperature of newborn? It is 36.5 to 37.5 degrees Celsius. Okay, thoda thanda, that's true. Then what is mild hypothermia? So mild hypothermia, it is also known as cold stress. Mild hypothermia, it is also known as cold stress, where the temperature will be between 36 to 36.5 degrees Celsius. Now, what is moderate hypothermia? In moderate hypothermia, the temperature will be 32 to 36, and in severe hypothermia, the temperature will be less than 32 degrees Celsius. And this is important for the exam purpose. UPSC question: a mother while touching her child, touching her child, she said कि my baby's peripheries are cold. बच्चे के हाथ पांव ठंडे हैं डॉक्टर, क्या ये नॉर्मल है? So C for cold stress, C for cold peripheries, the patient has mild hypothermia. The patient has mild hypothermia. Remember that. In the pediatric advanced life support, A, B, C, D, E, all pairs are matched correctly except. So airway, breathing, circulation, D for disability. D for disability and E for exposure. D for disability and E for exposure. So dehydration is not the right answer. And if in the basic life support, you went to a metro station and someone collapsed. You went to a metro station and someone collapsed. What will you do? Number one, shout for help. What will you do? Shout for help. After shouting for help, if you are alone, after shouting, yes, exactly. I'm telling the main stuff. So definitely after the scene safety, listen very carefully. What I'm telling, just listen to that. It will be very easy. You went to a metro station, someone collapsed. You will do shout for help. Number one, if you are alone, what will you do? You will stay with the victim. You will stay with the victim. And if you are with your friend, you plus your friend is there, then what will you do? Any idea? You will stay with the victim, but your friend will activate the AED. Your friend will activate the AED. I'm telling in a very shortcut way. It will be very easy for you. What is AED? Any idea? Very importantly, what is AED? AED is automated external defibrillator. Automated external defibrillator. Okay, remember that. I'll repeat again. This is very interesting. Yeah, I went to a metro station. By looking at your face, someone collapsed. What will you do? You will shout for help. Second, you will stay with the victim and your friend will activate AED. What is AED? Automated external defibrillator, and the picture of that also comes in anesthesia question. So after that, what will you do? Any idea, guys? Uske baad kya karenge? After that, very importantly, you will do something known as BP. Now, what is BP? B for breathing and P for pulse. B for breathing and P for pulse. Breathing is also there and pulse is also there. Now, what will you do, guys? What do you think? Breathing is also there and pulse is also there. Now what will you do? Very important anesthesia question. No, breathing is there, pulse is there. Why will you start CPR? Ayush, no dear, you will not start CPR. Yes, you will keep the patient in the left lateral position. You will keep the patient in the left lateral position, also known as left decubitus position. Remember that. If there is, breathing is there and pulse is there. Number one. Next important point, no breathing, no pulse. नो ब्रीदिंग, नो पल्स। अब क्या करना चाहिए? अब चढ़ जाओ पेशेंट के ऊपर। यस, नाउ यू विल डू CPR। व्हाट इज द रेशियो ऑफ CPR? इज इट 30:2 और 15:2? इफ यू आर अलोन, अकेले अगर आप कर रहे हैं, सिंगल रेस्क्यूअर थेरेपी, सिंगल अकेला बचाने वाला, if you're alone it will be 30:2, and you plus your friend is there, means two rescuer therapy, two rescuer, दो बचाने वाले, then 15:2 is the ratio. Yes, exactly. So 15:2 is the ratio. So this is important for exam question. Single rescuer therapy, it is 30:2 ratio. Two rescuer, then the ratio is 15:2. And neonatal resuscitation, the CPR ratio is, it is 3:1. It is 3:1. 6-year-old child presented with short stature. The height of the child is to the parent's height, and the chronological age of the child corresponds to the bone age. They are saying that the bone age corresponds to the chronological age. So bone age is equal to the chronological age happens in familial short stature. Remember that. Whereas other issues, the bone age is less than the chronological age. Okay? So this is one thing you should know. 30:2 if you are single rescuer, 15:2 if you have two rescuer, and in neonate it's specifically 3:1, the CPR ratio. Fluid of choice for a child in shock with severe acute malnutrition. Yes, this question also has come. So yes, Sam baby is there, and that Sam baby is in shock. Then definitely that baby you will give ringer lactate with 5% dextrose. You will give ringer lactate with 5% dextrose is the best answer for Sam baby. Very importantly, who is in shock, remember that. Okay, someone is saying कि वो वाला revise करवा दो is okay. So we have bone age is equal. So bone age, in which condition the bone age is less than the chronological age? So bone age, yes, important. So bone age is less than the chronological age. It is seen in constitutional short stature. It is seen in constitutional short stature. And just imagine, no, just imagine yourself, bone age less than the chronological age. For a chronological age matlab, chronological age means the Aadhaar card age, whatever your Aadhaar card age is there, no. For example, you are a 5-year-old child. Can you tell me, 5-year-old child, for the bone age, what is the X-ray I should get it done? Any idea? For 5-year-old child, to know the bone age, you should get a X-ray wrist. 1 से 12 साल तक के बच्चों का हम कराते हैं X-ray wrist. So number one, X-ray wrist is the wrist of the X-ray, the bone age. X-ray wrist is the answer for the bone age for 5-year-old baby. Now 5-year-old baby, how many carpal bones are you expecting? In 5-year-old baby, you're expecting 5 carpal bones. In 5-year-old baby, you're expecting 5 carpal bones. So that's what, this is normal. But I have a baby which has just 2 carpal bones. I have a baby which has 2 carpal bones. So the bone age will be less than the chronological age. Why? बच्चा तो 5 साल का है और 2 ही हड्डियां क्यों है उसके अंदर? Because that might be suffering from anemia, because that baby might be suffering from malnutrition, or that baby might be having constitutional short stature. The baby will be having constitutional short stature. So these are the important points you should know, where the bone age is less than the chronological age. Okay, newborn is presented with history of continuous drooling of saliva and frothiness in the mouth. It is also associated with distress. So very simple, very easy. Drooling of saliva, choking while feeding. ये भी question आता है. Choking while feeding. So where do you see choking while feeding and you got this X-ray done? So it's a case of tracheoesophageal fistula. Number one. Number two, what is the name of the classification for TEF? The name of the classification is Gross classification. Which is the most commonest type of TF? The mnemonic is CAD. It is type C, followed by type A, and the least common is type D. Now, which type of TEF will have no gas in the abdomen? Which type of TEF will have no gas in the abdomen? Type A and type B will have no gas in the abdomen. And if you get an X-ray done, you will see the coiling of the nasogastric tube. 5-year-old child came with edema for last few months. It started on the face, but now it is generalized with pedal edema and ascites. He showed good response to steroids. So what do you think, this guy who is having a NASARCA and he showed good response to steroids, what are we talking about? We're talking about nephrotic syndrome. And the question, and also in electron microscopy, there is effacement of photocytes, then the answer is minimal change disease. Now, this is a separate question, okay? What is the electron microscopy in minimal change disease? The answer is effacement of the food processes. That's a separate dedicated MCQ. Number one. Number two, very importantly, okay, 8-year-old child came with sudden onset of high-grade fever, loss of consciousness, and anemia. On examination, the child is hypoglycemic and no focal neurological deficit is noticed. Okay. So yes, now this is also very important for exam purpose. If the patient has fever followed by loss of consciousness, okay, a loss of consciousness means agar main bolu the patient has altered sensorium. If the patient has fever with altered sensorium, anywhere if you see anemia or hypoglycemia, anywhere in the MCQ, if you see anemia and hypoglycemia, yes, rotavirus is right. Anemia is the biggest clue. Malaria, in the malaria, the pathogen kills, basically it causes hemolysis. In malaria, this basically they destruct the RBC. In malaria, basically this pathogen destruct the RBC, causing hemolysis, and that basically causes anemia. So this is very important. Okay, anyone who is having anemia and hypoglycemia, please think of cerebral malaria. TB meningitis will not cause anemia. Anemia is specifically a malaria who is entering the RBC, killing the RBC, causing hemolysis and anemia. During neonatal resuscitation, at what heart rate do you start the chest compression? So we all know when the heart rate is less than 60 beats per minute, you will start the chest compressions and bag and mask ventilation in the ratio of 3:1. For how many seconds you should do the chest compression and bag and mask ventilation? This whole thing you will do for 60 seconds. You will do for 60 seconds, and then again you will check the heart rate. If still the heart rate is less than 60, then what will you give? Then you will give adrenaline. Then you will give adrenaline, which is also known as epinephrine. That's right. And what is the dose of adrenaline? The dose of adrenaline is 0.2 ml per kg. 0.2 ml per kg in 1:10,000 dilution. 0.2 ml per kg in 1:10,000 dilution. 0.2 ml per kg means 0.02 mg per kg. 0.2 ml per kg means 0.02 mg per kg. Someone is asking IV or IM. Remember, umbilical vein. The best route for giving this drug is umbilical vein. So definitely intravenous. अलग से question आता है. How do you, why, like, where will you give adrenaline? So umbilical vein. So intravenous, IV. Remember that. And 0.2 ml per kg in 1:10,000 dilution. And yeah, so that's it. This is the important point you should know for the exam purpose. Okay, number one. Number two, yes, now we have FMG July 2023 questions. A quick small break over here. FMG July 2023. Yes, exactly. 100 more slides are left. We'll do it very positively. Let's have a relax 1 minute of break. We'll do it. We will clear. We have to clear. It's nice. It's easy. You can do it. We can do it. It's not a big deal. Please make a proper timetable. That's it. Pani pire, pani. So it's 7 o'clock. So shall we take a small break or something? Can we start the class in 10 minutes? Please let me know. Thank you. Let's start the class at 7:15. So we can have a small quick break if you want. So we can start the class at 7:15 a.m. So last segment is left. Okay, done. So let's have a small break, I think, so that we can start the class, I am also writing exam. Yes, I am also writing. So see you guys at 7. Sorry, AM I'm saying PM. See you guys at 7:15 PM. 14 minutes are left. See you guys at 7:15 PM. सबको भी राहत चाहिए. That's why I'm saying. Last segment. This will be the last segment, and see you guys at 7:15 PM. 7:15 PM. See you and bye. Bye. बैठ के सर मैसेज नहीं पढ़ते रहते और कुछ काम नहीं है क्या जीवन के अंदर? मैं बैठा था अभी मैं इधर। बहुत अच्छा होगा, बहुत अच्छा होगा, बहुत अच्छा होगा, बस मैनिफेस्ट करो, बहुत अच्छा होगा, सबका बहुत अच्छा होगा। नहीं बड़ी, वाई सॉरी, आई अपोलोजाइज इफ आई हैव हर्टेड एनीवन। Yes. Chalo ji, let's start. Okay. Good evening, everyone. This is the last segment. I request everyone to join as many answers as possible. Try to answer. Number one. Yes, a child has presented with the birth defect as shown in the image. What is the diagnosis? When the brain and spinal cord is fully exposed, this was the question. This is craniorachis, and yes, there is a microcephaly or anencephaly also. So craniorachis with anencephaly, and mother would not have taken which drug during pregnancy? अगर मम्मी ने प्रेगनेंसी में फोलिक एसिड नहीं खाया तो बच्चे को ये हो जाएगा. What is the dose of folic acid in preventing of neural tube defect? Remember, 400 and 4000. So 400 microgram is a dose of folic acid in the primary prevention. If there is a first pregnancy, then the dose of folic acid is 400 microgram. And if the mother has a baby of history of neural tube defect, then the dose of folic acid will be 4000 microgram. Yes, Dolan Trump, my dear. Yes, yes, yes. Next question. What is the amount of milk given to a term baby in the first 24 hours of delivery? So this also important. This is also a proper FMG PYQ. If I ask you a simple question, एक बच्चे में खून कितना होता है? What is the normal blood volume in a term baby? The blood volume in a term baby is 60 to 80 ml per kg. And just remember that way, 60 and 60. Newborn baby, you should give blood you should give milk in the first 24 hours of life, that is 60 ml per kg. Remember that. A child with celiac disease can be given what? So very importantly, can be given, चावल खा सकता है? हाँ जी, चावल खा सकता है. क्या नहीं खा सकता है? barley and bread and rye and oats and wheat he cannot have. So important for the exam purpose. And classification, I told you everything. I've told you. A child presented in the pediatrics OPD with fever for 5 days with cough, coryza, and conjunctivitis. Cough, coryza, and conjunctivitis important for the exam purpose. There's a swelling which starting from behind the ear involving the face. Yes, कोई कुत्ता भी बता देगा. This is the answer is measles. Which is the most common complication of measles? The most common complication of measles is otitis media. And the most common cause of death in measles is pneumonia. And what is the late complication? The late complication is subacute sclerosing panencephalitis. In the treatment of the measles, which vitamin is important? So vitamin A. Vitamin A is important in the treatment for the measles. A child came to the clinic with complaints of recurrent infection. Physical examination shows height for age less than -2 standard deviation. So when you have height for age less than -2 standard deviation, very importantly, we know that is known as stunting. So best very importantly, height for age, that is known as stunting. हाँ, वो ऑलमोस्ट हो गया, वो जा रहे हैं, सारा काम गेट का हो चुका है, गेट का डोर खराब हो गया था, दैट्स व्हाई. ओके, सो खत्म हो गया, ऑलमोस्ट डन है. ठीक है. So number one, what is the mid upper arm circumference for severe acute malnutrition? The mid upper arm circumference, very importantly, is nothing but less than 11.5 centimeter. Someone was saying less than 11 centimeter. No, less than 11.5 centimeter. Please remember that. Okay, Shakir tip colors, I told you. Diarrhea with dehydration, I told you. Achha, someone was telling me about diarrhea maintenance fluid. Now, in a case of diarrhea patient, what is the maintenance fluid formula? So to calculate the maintenance fluid in a diarrhea patient, or even in normal patient also, we have a formula known as Holiday and Segar formula. The formula name is Holiday and Segar formula. This is used for calculating the maintenance fluid in a baby. So we have 1 to 10 kg, 10 to 20 kg, and more than 20 kg. Remember that. Remember, it is 100, 50, and 20. 100, 50, and 20. For the beginning 10 kg baby, we give fluid basically at the rate of 100 ml per kg. For the next 10 kg, we give fluid at the rate of 50 ml per kg, and after that we give fluid at the rate of 20 ml per kg. So this is the maintenance fluid requirement formula for any normal child also and diarrhea patient also. For example, 3 question if I ask you, 10 किलो के बच्चे को कितना maintenance fluid देना चाहिए? 10 kg baby, how much maintenance fluid will give? So 10 kg baby definitely will give 1000 ml. So if I ask you a simple question, that is what is called, okay, now look at the camera. In the camera, what can you see? So if I ask you a simple question, Devash, आपकी nose का है? Nose का है? देवर्ष की आईज का है? आईज? अच्छा, हैंड किधर है? हैंड का है? हैंड? वाओ, देव के नेल्स का है? नेल्स का है? अच्छा, हेड का है? देव का हेड का है? वाओ, अच्छा, पापा किधर है? पापा? देव पारी कैसे करता है? अरे वो गल्ला कैसे खाता है? अच्छा, देव रोता कैसे है? देव हंसता कैसे है? देव मारता कैसे है? देव प्यार कैसे करता है? अच्छा, पारी पारी देखो भागता क्या? तू भाग जाए यहाँ से। देखो भागता कैसे? देखो भाग के दिखाएगा, दफा होके दिखाएगा, मार खा लेगा। इधर मत आजियो। Apologies. So yes, very importantly, this is the maintenance fluid formula we calculate in children. That is the Holiday and Segar formula. A unit came with post-feed vomiting and hypoglycemia. In the first week of life, urine was positive for reducing substances, but there was, yes, no glucose in urine. And the patient also, very importantly, the neonate also had a reversible oil drop cataract. Now, this is something an important highlighter. We're talking about, very importantly, the patient has a reversible oil drop cataract, and also the patient is a case of inborn errors of metabolism. So oil drop cataract, definitely it is seen in classical galactosemia, where basically there's a deficiency of enzyme GALT. So whenever the mother will feed her baby, so the mother's milk has galactose. Okay, the mother's milk has galactose, which gets converted into glucose, and the enzyme responsible is GALT enzyme. I'll repeat again. Whatever the mother will feed her baby, अच्छा ठीक है बताता हूँ. Whatever the mother will feed her baby, mother's milk has galactose, and that galactose, actually बच्चा दूध पीता है, and that galactose gets converted into glucose, and the enzyme responsible is GALT enzyme. In a case of galactosemia, this GALT enzyme is totally deficient. So whatever the mother will feed her baby, in the baby GALT enzyme is deficient, so conversion will not happen. So lot of galactose will be there, and the baby will have hypoglycemia. The baby in your MCQ, he will have hypoglycemia, like that. Okay, that you should know. Okay, this is a classical galactosemia. That's why you don't see oil drop cataract in galactokinase deficiency. Okay, next question. Someone is asking me कि 20 किलो के बच्चे का maintenance fluid बता दो एक बार. So who will tell me 20 kg baby? Now 20 kg baby, what is the maintenance fluid? 20 kg baby, I will do 10 plus 10. Sir, why are you doing 10 plus 10? Because my dear, the beginning 10 kg will be always on the formula of 100 ml per kg. 1 kg baby, you will give 100 ml fluid. So 10 kg baby, 10 into 100 is 1000 ml. Okay, the beginning 10 kg will be always on the behalf of the first formula, this one. And the whatever remaining 10 kg will be on the behalf of the next formula, that is 50 ml per kg. So 1 kg baby will give 50 ml of fluid. 10 kg baby, 10 into 50 is 500 ml. So total 20 किलो के बच्चे को अगर आपको बोतल लगानी है तो पूरे दिन में उसको 1500 ml आप डेक्सट्रोज नॉर्मल सलाइन लगाएंगे. If you have to give maintenance fluid to a 20 kg baby, you will give 1500 ml. You will give what you called 24 for 24 hours, and that will be dextrose normal saline. Okay, that you should know. A child presented to the clinic with complaints of malnutrition and dehydration without shock. Yes, this is a very nice question. So see, every year Sam topic is FMG's favorite topic. Kwashiorkor, marasmus, Shakir tape, this, that. So now very importantly, yes, Goli beta. So the patient has a SAM without shock. So SAM without shock, very importantly. So the best of the best answer will be Risomal, but Risomal right now it's not here in the MCQ, so I will put ORS. Okay, remember that definitely. So I'll put ORS. Risomal option mein nahi hai na, so that is why. If this patient was with shock, if the patient was with shock, then I would have thought of Ringer lactate and 5% dextrose. Okay, simple. It is. See, hello everyone. Choose the closest best answer. Choose the closest best answer. Okay, चॉइस ऑफ आईवी फ्लूइड लिखा है, इसको आईवी को हटा दो, ऐसे नहीं आएगा, चॉइस ऑफ फ्लूइड आएगा, चॉइस ऑफ फ्लूइड फॉर दिस पेशेंट. ओके, आईवी फ्लूइड फ्लूइड ही है, दिस इज अ फ्लूइड ओनली. चलो अगर आईवी की बात भी करें तब मैं लिख सकता हूँ आरएल इन 5% डेक्सट्रोज. ओके, अगर हम फ्लूइड की ही बात करें तो इट विल बी आरएल 5% डेक्सट्रोज, लेकिन आईवी को हटाना पड़ेगा बिकॉज द बेस्ट द बेटर वर्जन फॉर द क्वेश्चन विल बी what is the choice of fluid for the patient. The answer will be ORS or nothing but Risomal. Okay, हाँ IV लिखा है तो definitely RL with 5% dextrose. What is the karyotype shown in the picture? In the picture, you have a single palmar crease, and single palmar crease is seen in trisomy 21. That is nothing but Down syndrome. And which is the most common congenital heart disease in Down syndrome? It is endocardial cushion defect. It is endocardial cushion defect is the most common congenital heart disease in Down syndrome. One more question. Where do you see butterfly shaped vertebra? Any idea where do you see butterfly shaped vertebra? So butterfly shaped vertebra you see in a case of Allegili syndrome. And Allegili syndrome, what is the most common congenital heart disease in Allegili syndrome? It is pulmonary stenosis. Very good. Now we have FMG Jan 2024 questions. Congenital biliary atresia should be suspected when the jaundice is present beyond how many weeks? So anything more than 2 weeks is abnormal. Okay, anything which is more than 2 weeks, it is abnormal. So remember, congenital hypothyroidism, congenital biliary atresia, that is more than 2 weeks of jaundice. Which is the most common indication of liver transplantation in children? Which is the most common indication of liver plant transplantation in children? The answer is biliary atresia में बच्चे का पूरा liver transplant करते हैं. Number one. Number two, okay, someone is saying, okay, what are the causes of unconjugated hyperbilirubinemia? Can you name some syndrome causes unconjugated hyperbilirubinemia? The mnemonic was very importantly CNG gas. C for Crigler-Najjar syndrome, C for Crigler-Najjar syndrome, and G for Gilbert syndrome. G for Gilbert syndrome. G for Gilbert, G for good type. G for Gilbert, G for good type. Good type means the patient usually stays asymptomatic. The बच्चे usually क्या होते हैं? Asymptomatic होते हैं unless they do some stress or exercise. Unless they do some stress or exercise, and the patient will be totally asymptomatic. He can live a normal life unless he do some stress or exercise, and that is one thing. And in Gilbert syndrome, you have immature UGT. The uridyl glucuronide transferase enzyme is immature. And Crigler-Najjar syndrome. How many types of Crigler-Najjar we have? Crigler-Najjar syndrome, we have two types, type 1 and type 2. In type 1, C for Crigler-Najjar, C for cancelled or absent UGT. C for Crigler-Najjar, C for cancelled or absent UGT. So that enzyme is totally deficient in Crigler-Najjar syndrome type 1. Whereas in type 2, there is still 10% of UGT activity is positive. And what is the drug of choice here? The drug of choice over here to increase this activity of UGT enzyme is phenobarbital. So that you should know. So these are the important points of conjugate or unconjugated hyperbilirubinemia. Anencephaly occurs due to inability of the neural tube to fuse in which week of gestation? मतलब मोटा मोटा याद रखना कि प्रेगनेंसी में के 1 महीने के अंदर पूरा का पूरा न्यूरल ट्यूब बन जाना चाहिए. By the 1 month of pregnancy, by the first month of pregnancy, the whole neural tube beautifully should form, and neural tube contains the brain and the spinal cord. Now the question is neural tube defect. So by the 4th week of gestation, if still there is a neural tube defect, so that defect can be a anterior neuropore defect, and that defect can be a posterior neuropore defect. And anencephaly, very importantly, is an example of anterior neuropore defect. Okay, yes, exactly. So anterior neuropore defect. A newborn is delivered with a defect seen in the image below. all the intestinal contents are out, but they are covered in a sac. This is known as omphalocele. This is known as omphalocele. When does stranger anxiety appears in a child? Stranger anxiety, anxious on meeting the stranger. So say 6 to 7 months, the baby is anxious on meeting the strangers. If anterior neuropore defect, the answer was anencephaly. What are the example of posterior neuropore defect? मतलब caudal वाले, spina bifida occulta, meningocele, meningomyelocele. They are the posterior neuropore defect. They are the posterior neuropore defect. वो एक तो नाउ जल्दी से एक गाना वो कहते हैं ना, कुछ तुम सोचो कुछ हम सोचें, फिर खुशी का मौसम आए, तन्हा तन्हा कौन जिया है, रह के तन्हा दिल घबराए. So motivation. Do you think where is the motivation? The motivation, yes, couple, it is right inside you. 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 Once you know how to live a beautiful life, once you know that you should no longer get affected by people, situations, or emotions, then your life becomes so beautiful and extremely deep and extremely meaningful. Angular cheilitis, stomatitis, and glossitis are associated with vitamin deficiencies. Remember vitamin B2. Vitamin B2, very importantly, is responsible for the angular stomatitis and everything. Number one. Ananya, milestone पूरा तो revise करवा दिया, straight line drawing skills सब तो revise करवा दिया. Now vitamin B1 is thiamine. Vitamin B1 is thiamine, and thiamine deficiency causes what? Any idea? It causes beriberi. It causes beriberi. Beriberi is of two types. We have dry beriberi and wet beriberi. If in the MCQ you have CNS involvement like meningitis, encephalitis, then it is dry beriberi. If you have in wet beriberi, heart is involved. If you have cardiac failure or cardiomyopathy or cardiomegaly, then the answer has the patient has wet beriberi. And ये कौन सा चीज खाने की वजह से होता है? This is because of polished rice. This is because of consuming polished rice. You're gonna have this problem. Number one, so that you should know. Identify the milestone shown in the picture. लो जी milestone आ गया. When can a baby transfer object to one hand to another? A baby can transfer objects from one hand to another. That happens by 6 to 7 months. Okay, by dexterous approach, holding something with both the hand. But this fellow तो is holding something with one hand only. So by dexterous approach, दोनों हाथ से पकड़ना, ये होता है 4 महीने पे. Hand regard. Oh my God, I have my hands. I can kill you after the FMG result. So hand regard comes by 3 months, and hand comes in midline by 4 months. Hand regard comes by 3 months, hand comes in midline by 4 months, and mouthing कब आता है? डॉक्टर जो भी दो बच्चा मुंह में डाल लेता है, जो भी दो मुंह में डाल लेते हैं, जैसे तुम भी कई लोग मुंह में डाल लेते हो. So 5 months. Mouthing comes by 5 months. Mouthing comes by 5 months. This milestone right now in the picture, the baby is transferring objects from one hand to another. So this is transferring object from one hand to another. So transferring objects from one hand to another comes by 6 to 7 months. Bidextrous, दोनों हाथ से पकड़ना, comes by 4 months, and hand regard comes by 3 months, hand comes in midline by 4 months, and mouthing comes by 5 months. Bleeding gums are seen in which vitamin deficiency? So very importantly, yes, we all know that scurvy. The patient will have painful, bleeding gums. Very important. Osteogenesis imperfecta. What is the triad of osteogenesis imperfecta? How the question will come in my MCQ, and I will clear the FMG exam. If the patient has blue sclera, with recurrent fracture and deafness, if the patient has blue sclera with recurrent fracture and deafness, the answer is osteogenesis imperfecta. And in the treatment for osteogenesis imperfecta, we give something known as bisphosphonates. Any idea? Any example? So we have pamidronate and we have elpradronate. Pamidronate and we have elpradronate. So pamidronate and elpradronate, these are the bisphosphonates we give in cases of Osteogenesis imperfecta. Identify the condition in the image shown below. The baby has a swelling confined. It is a confined swelling. It is a confined swelling. Number one, cephal hematoma. Cephal hematoma, it is because of prolonged labor or forceps delivery. This cephal hematoma, it is because of forceps delivery. And as the name says, hematoma, so means hemolysis will happen and the hemoglobin gets converted into bilirubin. The hemoglobin gets converted into bilirubin and बच्चे को क्या होगा? बच्चे को होगा jaundice. And this one is confined to suture line. Hello everyone. Common things are common and rare things are rare. Okay, so that's what crossing the midline नहीं होता, suture line होता है. Midline कहाँ से आ गया यहाँ पे? Suture, confined to suture line, not the midline. Suture line, suture. You know na suture na? This how many sutures, how many frontally we have. So this baby, very importantly, number one, over here we have the metopic suture, over here we have the coronal suture, over here we have the sagittal suture, and last but not the least we have the lambdoid suture. And they ask in so this is very confined to suture line over here or over here. It is confined to suture line, remember that. Okay, now cephal hematoma, it is because of forceps delivery. As the patient has hematoma, the patient will have jaundice. Or doctor kitne din mein theek hoga ye? This will get resolved in 3 to 6 weeks. Number one. Number two, very resolve automatically. Automatic babu, Dr. Gulati, it will resolve in 3 to 6 weeks. Whereas caput succedaneum, it is because of prolonged labor. The babies who are born because of prolonged labor, they have a swelling over the head, that is caput succedaneum, and definitely it is a diffuse swelling. This one crosses the suture line. Okay, and will it cause jaundice? Yes or no? The answer is no. It doesn't cause jaundice, and it resolves in 3 days. 3 and 3 is the mnemonic. Caput will resolve in 3 days, whereas hematoma will resolve in 3 to 6 weeks. Conjunctival cirrhosis is associated with which vitamin? So definitely vitamin A. So which is the earliest symptom and which is the earliest sign? Yes, very importantly, 30 more minutes and this class is over. Which is the earliest symptom? Which is the earliest sign of vitamin A deficiency? So remember night blindness. Remember night blindness is the earliest symptom, and conjunctival cirrhosis is the earliest sign. And bitote spots is seen in which classification of vitamin A? B for bitote spots. It is seen in X1b classification of vitamin A. फिर शाम तन्हा जागी, फिर याद तुम आ रहे हो, फिर जान निकलने लगी है, फिर मुझको तड़पा रहे हो, फिर मुझको तड़पा रहे हो. 5-year-old child came with complaints of swollen and bleeding gums. Yes, my dear, and fatigue and bone pains, bleeding gums. So you are talking about vitamin C deficiency. If this was bleeding from the umbilical cord, then which vitamin I should have clicked in the exam? Any idea? If this was bleeding from the umbilical cord, then I would have thought of vitamin K. If there is bowing of legs, or widening of wrist, which vitamin I should have thought of? Bowing of legs and vitamin, yeah, what you called? Yes, thank you, Shivangi. Bowing of legs and widening of wrist. The answer is vitamin D problem, rickets, and any eyes, blindness, night blindness, and all that. The answer will be vitamin A. Rachitic rosary is because of which vitamin deficiency? So this one, ये जो एकदम rose जैसा है, this round, it is because of vitamin D. One is rachitic rosary, one is scorbiotic rosary. If rachitic rosary is because of vitamin D deficiency, then scorbiotic rosary, it is because of vitamin C deficiency. Rachitic rosary, remember, it is painless, whereas vitamin C deficiency, it is painful. Remember that, okay? Number one. And in vitamin D deficiency, X-ray में क्या मिलेगा? कौन बताएगा? A vitamin D deficiency, very importantly in the X-ray, you will have cupping, fraying, and splaying appearance. Something known as cupping, fraying, and splaying appearance you will see over here. Okay. And here, what you will see? Where do you see white line of Frankel? So white line of Frankel, or you can say Trummer field zone, white line of Frankel, all these are very importantly you see in a case of vitamin C deficiency. Very good. Next important, scorbiotic rosary is associated with which vitamin? The answer is vitamin C. Identify the image and it's associated with which vitamin deficiency. Yes, this is important. Do you like the patient's necklace? This is like a necklace. So this is the case of Kessel's necklace. Yeah, it is a case of Kessel's necklace, which is because of deficiency of vitamin B3. So vitamin B3 is niacin. Niacin deficiency causes a problem known as pellagra. And the pellagra patient will have D. That is diarrhea, dementia, dermatitis, and death. Diarrhea, dementia, dermatitis, and death. Yes. और ये what will be the staple diet? What will be the staple diet? जो लोग भुट्टा खाते हैं, जो लोग बहुत भुट्टा खाते हैं, मेज खाते हैं, maize is deficient in vitamin B3, so that you should know. And very importantly, let's talk about craniosynostosis. First question I have over here is how many sutures and how many fontanelles we have. So we have four suture. Remember, we have four suture and we have six fontanelles. Four suture and six fontanelles. The sutures are, we have metopic suture, we have coronal suture, we have sagittal suture, and we have lambdoid suture. We have lambdoid suture, number one. Now, very importantly, craniosynostosis. Synostosis. Now, premature fusion of the suture. If premature fusion of the metopic suture causes something known as trigonocephaly, it causes trigonocephaly. Premature fusion of the coronal suture छोटा सा हो जाता है, it causes a small head known as brachycephaly. Premature fusion of the sagittal suture causes where the AP diameter is more than the transfer, known as dolichocephaly, also known as scaphocephaly. And premature fusion of the lambdoid suture cause this asymmetric head. This is normal skull, kind of an asymmetric head known as plagiocephaly. Plagiocephaly. Has everyone understood? Quick 30 seconds break. Quick 30 seconds break. Yes. तड़पाए मुझे तेरी सभी बातें, एक बार है दीवाने, झूठा ही सही प्यार तो कर, मैं भूला नहीं हंसी मुलाकातें, बेचैन करके मुझको मुझसे यूं ना फेर नजर. The condition shown in the picture below is associated with which problem? So yes, it is a very importantly we can appreciate over here is the webbed neck. We can appreciate is webbed neck, and webbed neck it is seen in Turner syndrome. The karyotype is what you call the karyotype is 45XO. And which is the most common congenital heart disease in Turner syndrome? The most common congenital heart disease in Turner syndrome is a bicuspid aortic valve, and the most common cause of death in what you called Turner syndrome is coarctation of aorta. Number one. Number two, very importantly, it will be a female patient with a webbed neck with short stature, very importantly with widely spaced nipples. That is the first point. Second important point, who will tell me why it is important to get an ultrasound done in a Turner syndrome patient? Ultrasound doing is important because I need to check the ovaries and I need to check there is a streaking of ovaries. There is a streaking of ovaries. That is one thing. कि ovaries काम नहीं कर रही होती, and that is why there is a compensatory increase in the FSH and LH levels. My ovaries are not working properly, still my body will try, and there is a compensatory increase in the FSH and LH levels. Next, very importantly, where do you see horseshoe shaped kidney? Exam question. Where do you see horseshoe shaped kidney? So horseshoe shaped kidney you see in a case of Turner syndrome. Newborn came with respiratory distress. Chest X-ray shows air bubbles in the left hemithorax. So a very beautiful air bubble, air bubble, air bubble in the left hemithorax is congenital diaphragmatic hernia. The details we have already spoken 1,000 times, so it's fine. After how many seconds of chest compressions and bag and mask should we start the adrenaline? Yes. After how many seconds of chest compression and bag and mask? Chest compression and bag and mask, it is done for 3:1 ratio. It is done for 60 seconds, and then you check the heart rate again. If it is still less than 60, then you will give adrenaline. Now, one more question. Whenever a newborn comes to you in resuscitation, what are the three things you see in a baby? You see something known as TTC, that is term, tone, and cry. Term, tone, and cry. If the term, tone, and cry is there, बच्चा अच्छे से रो रहा है, तो आप क्या करेंगे? Something known as routine care. Something known as routine care, and in the routine care, you should know something known as delayed cord clamping. Delayed cord clamping. You clamp the umbilical cord. How much delayed? After 60 seconds, because you want that the extra blood in the placenta and the umbilical cord, you want that blood to reach the baby. So when blood in the placenta and umbilical cord, you want that blood to reach to the baby, and then you want to clamp. What are the benefits? The benefits will be the chances of anemia and the chances of blood transfusion will be less in the baby. These are the benefits. And what are the negative points? The negative points, ज़्यादा खून अगर जाएगा, if too much of blood you're putting in the baby will have asymptomatic polycythemia and jaundice. The baby will have asymptomatic polycythemia and jaundice are the negative points. Okay, if the baby has not cried immediately after birth, then you what will you do? तब तो बच्चे को रुलाना पड़ेगा. You have to make the baby cry, and then you will do something known as initial steps. What are initial steps? The mnemonic is PSSR, that is position, suction, stimulation, and reposition. Where do you suction a baby? You suction the mouth followed by the nose. How do you stimulate a baby? बच्चे को रुलाते कैसे हैं? Do you put water on the back? Slapping the baby, Rohit Sharma, I will slap you, the spank. So basically, how do you stimulate the baby, Baba? You stimulate the baby by rubbing the back, or tickle the sole. अब तो हम गुली गुली करके गुली गुली भी कर सकते हैं. So very importantly, by rubbing the back. Even the latest edition says कि tickle the sole भी छोड़ो, just rub the back, rub the back, rub the back, and rub the back. A 5-year-old child who is eagerly drinking the bottle of water and skin pinch goes back slowly. Which category are we talking about? So eagerly drinking. So diarrhea with no dehydration, diarrhea with some dehydration, diarrhea with severe dehydration. If the child is eagerly drinking the bottle of water, yes, definitely this is the typical FMG PYQ. It is a yellow color coding, and severe dehydration will be a pink color coding, and no dehydration will be a green color coding. FMG July 2024 questions. Let's do them. CFTR gene mutation. Nice question. CFTR gene mutation. It is seen in which condition? We are talking about cystic fibrosis. A mother while kissing her child. Found her child's skin salty tasting. Which gene problem? CFTR gene mutation is there. Or what is the hallmark of cystic fibrosis? Main क्या होता है? Hallmark is elevated sweat chloride levels. Elevated sweat chloride levels more than 60 milliequivalent per liter. So elevated sweat chloride levels are important. Very importantly, more than 60 milliequivalents per liter. And sweat chloride. So main channels we are affecting over here is the chloride channel. And which is the second best investigation you want to get it done? The second best investigation will be NTPD. That will be NTPD. What is NTPD? Nasal transmembrane potential difference. Nasal transmembrane potential difference is the second investigation you want to get in cystic fibrosis. All the secretion gets stuck. बार बार एक चीज को याद रखना है कि all the secretion gets stuck. When all the secretion gets stuck, very importantly, in the respiratory system, what will you get? You will get upper respiratory tract infection, lower respiratory tract infection. You will get, the patient will have recurrent pneumonia. In the pancreatic features, in the pancreas feature, what will you get? So the beta cell of the pancreas releases insulin. So beta cells is not working properly, insulin is not getting secreted, the patient will have diabetes mellitus. The patient can land up into diabetes mellitus. And yes, very, very importantly, you will have a foul smelling stool. You will have a foul smelling stool or a steatorrhea in your MCQ, because Sara ka Sara, all the pancreatic enzymes are not getting absorbed properly in our body. They're coming out of my body. Once they are coming out of the stool, you will have foul smelling stool, steatorrhea, and all these things. Number one. Okay? And the patient will have pneumonia. Yes, which is the most commonest cause of pneumonia in cystic fibrosis? It is Staphylococcus aureus. It is Staphylococcus aureus followed by Pseudomonas aeruginosa. Okay, Staphylococcus aureus followed by Pseudomonas aeruginosa. Number one. And last question, which is the most commonest cause of mortality? Which organism causes mortality in cystic fibrosis? Yes, Amitabh Bachchan, very good. It is Burkholderia cepacia. It is Burkholderia cepacia. That is the organism causing mortality in cystic fibrosis. Has everyone understood this much? Yes, or yes, 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 yes. Yes, in the treatment we have Eva or Alexa. We have Eva, that is Ivacaftor. We have Alexa, that is Alexaftor. Eva and Alexa, they have a friend known as Teza. So Tezacaftor. These three drugs which are there important for cystic fibrosis. Okay. सब गाते हैं, सब ही मदहोश हैं, हम तुम क्यों खामोश हैं, साजे दिल छेड़ो ना, चुप हो क्यों, गाओ ना, आओ ना, आओ ना, आओ ना, आओ ना. So yes, so muscle wasting, very importantly, skinny appearance, muscle wasting, very important. What are we talking about, bro? Yes, sukha bacha, sukha jeevan, sukha bacha. Marasmus, we are talking about, very importantly. Remember, Kwashiorkor is deficiency of proteins. Kwashiorkor is deficiency of proteins, and marasmus is deficiency of proteins and calories. Marasmus is deficiency of proteins and calories. Please remember that. Which vitamin deficiency is associated? Yes, very same. We have the Kessel's necklace. So vitamin B3 is niacin. Niacin deficiency causes this problem. Okay, and vitamin B12 deficiency causes what? Any idea? So yes, we have yes, vitamin B12 is methylcobalamin, and methylcobalamin deficiency will be there. The patient can land up into any problem. The patient can land up into megaloblastic anemia. In a case of megaloblastic anemia, what is the peripheral blood smear finding? Yes, patho question. What is the peripheral blood smear finding? Classical, that is hypersegmented neutrophils. You will have MCQ. Where do you see hypersegmented neutrophils? The answer is megaloblastic anemia. Or skin में क्या मिलेगा? Skin में मिलेगा hyperpigmented knuckles. You will get hyperpigmented knuckles. Very importantly, pure vegetarian patient, hyperpigmented knuckles, and hypersegmented neutrophils in the peripheral blood smear finding. Important for the exam purpose. Yes, MCV will be more than 100 femtoliter. It will be a macrocytic anemia. Macrocytic anemia, very true. अच्छा, आयरन कहाँ पे, यहीं लिख देता हूँ. आयरन कहाँ पे absorbed होता है? Where is the iron absorbed? The answer is duodenum, jejunum, or ileum. What do you think, guys? Iron is absorbed in duodenum, jejunum, ileum. So very importantly, remember, important for the exam purpose, that is Indian Federation of Bank. Remember, my dear friends, that is IFB Bank, Indian Federation of Bank. So iron is absorbed in duodenum. Folic acid is absorbed in jejunum, and B12, it is absorbed in ileum. Straight away exam questions that you should know. Which of the following condition is associated with vitamin A deficiency? So the condition associated with vitamin A deficiency, the answer is bite out spots. Arse, line, walks, try are not important, so that's why I'm not mentioning them over here. What is the fluid requirement in a 3-day-old baby with birth weight of 1.3 kg? Now, this is a very interesting question, actually. So we have revised it. That's why it's looking so easy to you. Okay, so 3 days old baby, what is the fluid requirement? Yes, exactly. So very importantly, yes, option number C is the best answer. What is the fluid requirement on day 1? पहले दिन पे कितना फ्लूइड चाहिए होता है आपको? सो अराउंड 90 to 110 ml per kg. In a preterm baby, 90 to 110 ml per kg is fluid you need. 20 से बढ़ाएंगे, so roughly around then 110 to 120, and then 120 to 130 ml per kg is the fluid requirement day wise. 10 to 20 ml, 10 to 20 ml हम बढ़ाएंगे. यस, वेरी ट्रू, दैट्स राइट. कौन बोला? अमिताभ बच्चन कह रहा है एग्जाम में पूजा करके मत आना. दैट्स ट्रू. डोंट डू सिली मिस्टेक्स. ओके, योर फर्स्ट थॉट इज द फाइनल आंसर. योर फर्स्ट आंसर, first thought, that is the final answer. Don't overdo it, please. Okay, so yes, in a preterm baby, 1.3 kg, 90 to 110 ml per kg or 90 to 100 ml per kg is the fluid. फिर 10 से बढ़ाएंगे, so roughly around 120 to 130 ml per kg. Okay, yes, this is again a typical PYQ of FMG. Now you'll say why the question is so easy, but that's what the question came. Mid-parental height. Calculate the mid-parental height, very importantly, of a male patient. So we have the father height, we have the mother height, and divided by 2, and plus 6.5 if it is a male patient, minus 6.5 it is a female patient. Like that you calculate. This is the mid-parental height. This was the question came in the PYQ. Yes, 185 is the best answer. A newborn baby, feeble lower limb pulses and bounding upper limb pulses. Yes, very importantly, where do you see feeble lower limb pulses and bounding upper limb pulses? So this was a coarctation of aorta, where the blood basically in the upper limb is very good, but very less blood is going down. So feeble lower limb pulses and bounding upper limb pulses you see in coarctation of aorta. What is the X-ray finding of coarctation of aorta? The answer is figure of 3 appearance. Where do you see figure of 3 appearance? The answer is coarctation of aorta. A baby who can ride a tricycle. When can a baby ride a tricycle? Tri means 3. So 3-year-old can ride a tricycle. He can walk alternate steps on stairs. 3 साल का बच्चा ही अल्टरनेट स्टेप्स चलता है और 4 साल का बच्चा डाउन स्टेयर्स आता है. ये याद रखिएगा, 3 साल का बच्चा सीढ़ियां ऊपर चढ़ता है और 4 साल का नीचे आता है. ही कैन नॉट डू हॉपिंग. हॉपिंग कब आता है? हॉपिंग कम्स बाय 4 years and skipping comes by 5 years. So what is the age of the baby? Definitely it is not 4 years because he cannot do hopping. So that is why 3.5 years becomes the best answer. Identify the condition. Yes, number 1, 2, 3. Where do you see triple bubble sign? Like the question was big one. So where do you see triple bubble sign? So single bubble sign pyloric stenosis, double bubble sign duodenal atresia, and triple bubble sign you see in jejunal atresia. Which of the following condition associated with unconjugated hyperbilirubinemia? So unconjugated, we have the CNG gas. So very importantly, so unconjugated, no, yeah. So Crigler-Najjar syndrome and Gilbert syndrome. So definitely Gilbert syndrome is associated with unconjugated. And the causes of conjugated hyperbilirubinemia, the mnemonic is Dr. Bhatia. D for Dubin-Johnson syndrome, R for Rotar syndrome, B for biliary atresia. Which of the most common electrolyte imbalance in pyloric stenosis? This was a NEET PG question also. So pyloric stenosis, this is the tummy and this part is known as the pylorus. Once there is a pyloric stenosis, whatever the mother will feed her child, the baby will vomit. So number 1, all the HCl ions also baby will vomit. The baby will have hypochloremic metabolic so baby vomit, all the acid goes out, so the patient will have metabolic alkalosis. Remember that. And remember, imagine vomit, all the sodium and all the potassium also goes out. The patient will have hypokalemic metabolic alkalosis. लेकिन most common electrolyte imbalance कौन सा होता है? It is potassium. The most common electrolyte imbalance is potassium. Yes, it is the olive. Once the baby take milk, no, it will be like a olive shaped mass. It will be a olive shaped mass with left to right peristalsis. Stomach left में होता है, so left to right peristalsis will happen. And what is the name of the surgery for pyloric stenosis? The name of the surgery for pyloric stenosis is Ramstead pyloromyotomy. It is Ramstead pyloromyotomy. Remember that. FMGE Jan 2025, last segment of the class. FMGE Jan 2025 questions. The image shown below depicts characteristic skin lesions with which nutritional deficiency it is associated. So we're talking about acrodermatitis enteropathica. It is because of deficiency of zinc. And what is the gene mutation? The gene mutation is SLC39A4. It is SLC39A4. 5-year-old child came with rapid breathing and respiratory distress. Based on the X-ray, what is your diagnosis? So here, very importantly, we have a laryngeal spasm known as steeple sign. Steeple sign you see in a group, also known as acute laryngotracheobronchitis. Which is the most commonest cause of croup? The most commonest cause of croup is para-influenza virus. The most commonest cause of croup is para-influenza virus. And इसमें क्या देंगे? Will you give antibiotics or will you give oxygen? In this, we'll give steroids. Steroids. It is dexamethasone plus adrenaline nebulization. Dexamethasone plus adrenaline nebulization. This is what you'll give over here. Okay, what is the mid upper arm circumference in measurement of severe acute malnutrition? Yes, less than 11.5 is the mid upper arm circumference for the Shackett tape. A child came with disproportionate increase in the upper segment lower segment ratio. The child came with disproportionate increase in the upper segment lower segment ratio. So what are the causes of upper segment lower segment ratio? We have RHA, R for rickets, H for hypothyroidism, and A for achondroplasia. In these conditions, there is increase. The patient has a increase in the upper segment lower segment ratio, and decrease upper segment lower segment ratio, Alagille syndrome, TB, spine and spondyloepiphyseal dysplasias. Sachiv says Jan 2026 का भी करवा दो sir. Yes, my dear, yes. 2-year-old child came with bowing of legs and shown in the X-ray. So bowing of legs and widening of wrist. Yes, definitely we're going to talk about its rickets. Why it is not scurvy? Scurvy patient also has this problem. Scurvy patient, very important, will have bleeding, or it will be painful. This is very important. Number one. Number two, what is the treatment of rickets? क्या देते हैं इसमें हम? विटामिन डी का सैचे देते हैं. Will give vitamin D. कितने यूनिट्स का आता है? Will give 60,000 international units. The vitamin D sachet comes under 60,000 IU. कितना देना है? Like 5 doses. Imagine like every Saturday, 5 Saturdays. Every Saturday, 5 Saturdays you'll give. So 5 into 6 is 30. So total you are covering, that is 3 lakh international units. The total doses of vitamin D you are covering is 3 lakh IU. Number one. 2-year-old child came with complaints of fast breathing. On examination, the RR is 48 with no chest in drawing. So 1 to 5-year-old. So we have 0 to 2 months. 3 months to 1 year, and 1 year to 5 year, more than 60, 50 and 40. So this baby has a 48 RR. So definitely this is pneumonia. And what is the treatment of pneumonia? It is home treatment and oral amoxicillin for 5 days. Oral amoxicillin for 5 days. Which of the following feature is not a part of classical triad of congenital toxoplasmosis? Now, T-O-R-C-H-T for toxoplasmosis. So, toxoplasmosis, the patient will have intracranial diffuse calcifications, hydrocephalus, and chorioretinitis. Hepatosplenomegaly is not a part of the TORCH profile. Number one. Number two, in the TORCH, in this all three, which is the most common clinical feature? तीनों में से most common कौन सा होता है? The most common is C for common, C for chorioretinitis is most common. Number one. Number two, in the treatment, मम्मी ने क्या खाया होगा? मम्मी को क्या दवाई देते हैं इसके अंदर टॉक्सोप्लाज्मोसिस में? Maternal spiramycin. Maternal spiramycin is given to the mother. Number one. Which is the most common torch infection? The most common is the cytomegalovirus. Which one causes a stillbirth? अच्छा, stillbirth, मरा हुआ बच्चा किसमें पैदा होगा? S for stillbirth, S for syphilis. S for stillbirth and S for syphilis. Acha, which one is very bad in the first trimester? The one which is very bad in the first trimester is rubella. Remember that. Acha, which one has the lowest risk in perinatal period? कौन से torch infection का has a lowest risk in perinatal period? So the answer is rubella. Rubella has the lowest risk in the perinatal period because rubella is very bad in the first trimester, not in the perinatal period. What is perinatal period? Perinatal period is nothing but 22 weeks of gestation, 22 weeks of gestation to 7 days after birth. That is perinatal period. Which anthropometric parameter indicates chronic malnutrition? Every year there's a question from Sam. Sam, milestone, Sam, breastfeeding vaccine. Milestone, Sam, breastfeeding vaccine. So chronic malnutrition, the parameter affected is height for age. FMG July 2025 question. Let's have a 30 seconds break. Then we'll start FMG July 2025 questions. So we'll have a 30 seconds break, then we'll start. Yes, Oscar is there. He's lying down. He's taking rest. Avinash is saying, where are the FMG Jan 2026 questions? Yeah, they are all there. You only will tell that. That you only will tell. Once you finish, no, then you will tell. Anand sir, that's the question for this. And if you still have any doubt, you have my mobile number. You can put a hello right now to me, 93544076777. Put a hi to me in this number if you have any doubt also, and I'll be happy to help you. Okay, yes, okay. Yeah, definitely. If I don't reply, you can message again. If I still not reply, you can message again. And till the time I block you, you can message. I got a message from, I've got a phone also. ये problem है, number देगा, phone पे phone आने शुरू हो जाते हैं. Yes, you can call or message because there is a very beautiful option known as BLOCK block. Okay. Last 10 seconds, relax, deep breath. So what are the take home messages we have before the paper? Number one, before the paper, please, very importantly, before the paper, 5 deep breaths. Like, let's do it. How do you take deep breath? Let's take one deep breath. So 1, 2, 3, start. So it will be like 1, 2, 3, 4, 5. Hold 1 and 2 and 3, and uske baad 1, 2, 3, 4, 5. Like that, you should take breath. Remember that. Okay. Very good. Sa sa re re ga ga mama papa dha dha ni ni sa sa. This is what my music ma'am always tells me that you should always revise. Sa re ga ma pa. A 12-year-old child came with short stature on an evaluation. The bone age is found to be 10 years. It's a 12-year-old child with short stature. The bone age is found of 10 year. He is a 12-year-old, but his bone age is 10-year-old. Okay. His US-LS ratio is 1.1:1. What is the normal US-LS ratio at 7 year of life? The normal upper segment, lower segment ratio at 7 year of life is 1:1. Okay. Whereas after 7 year, the ratio is 1:1.1. Okay. Number one. There are no dysmorphic features, and what is the likely diagnosis? Now, very importantly, so isme kya hai? Isme everything is fine actually. It looks everything is normal, bro, because that is how it is, This looks like a normal to me because 7 year the USLS ratio is 1:1. After 7 year is 1.1:1. So this baby, a little bit of age difference is there, but everything is almost normal. That is why this is constitutional delay of growth and puberty. This is a constitutional delay of growth and puberty because the USLS ratio is normal. थोड़ा ही difference है, इतना drastic difference नहीं है. That is why it is normal. A newborn born to a diabetic mother presents with 24 hours of life with sugar less than 35, and the patient is symptomatic. Yes, if a neonatal hypoglycemia, the sugar is less than 45 and the patient is symptomatic also, simple, you start 2 ml per kg. You start 2 ml per kg of 10% dextrose and start that GIR. And start the GIR. What is GIR? That is glucose infusion rate. Okay, glucose infusion rate. So 2 ml per kg of 10% dextrose and start the GIR, that is glucose infusion rate. That is why this is the best answer for this question. Which genetic syndrome result from deletion of the short arm of the chromosome 5p? Yes, 5p deletion. Where do you see 5p deletion? So 5p deletion you have in cry-do-chart syndrome. Is the baby will have a cat-like cry. And also one question had come on chromosome number 15. Who will tell me chromosome number 15 involvement was there in a case of uniparental disomy? This was a case of uniparental disomy. Normally, one gene comes from the father and one gene comes from the mother, but here it is uniparental, same parents say disomy. So the examples are Angelman syndrome, and the example is Prader-Willi syndrome. Angelman syndrome, Prader-Willi syndrome, and even Russell-Silver syndrome also. Russell-Silver syndrome also, the patient has a uniparental disomy. Prader-Willi syndrome. Prader-Willi, पापा की मोटी गर्लफ्रेंड, पापा की मोटी गर्लफ्रेंड. P for paternal gene is deleted and maternal gene is doubled. M for micropenis, M for micropenis. O for obesity the patient will have, and TII for intellectual disability, I for intellectual disability. This is important, and the patient will have obesity, hypogonadism, micropenis. This was the question. Angelman syndrome. Now there was a micro puppet show. एक show था. There was a micro puppet show which got delayed by 15 minutes. There was a micro puppet show which got delayed by 15 minutes that made the mother hyperactive. इससे मम्मी को नाराजगी हो गई. That made the mother hyperactive. That means number one, micro for the patient will have microcephaly. Puppet for the patient will have a happy puppet faces. Happy puppet faces. The show got delayed for developmental delay. And which chromosome problem? Chromosome number 15 problem. And that made the mother for maternal gene is deleted and paternal gene is doubled, and that the child is hyperactive. These are the examples of uniparental disomy. Thank you for giving the heart. A young boy is brought to the clinic for developmental assessment. On examination, he has a prominent apicanthal fold and a single transfer palmar crease. Oscar, where do you see single palmar crease? The single palmar crease you see in a case of Down syndrome. And the most common congenital heart disease in Down syndrome is endocardial cushion defect. That is endocardial cushion defect, number one. Number two, where do you see rocker bottom feet? Any idea? So rocker bottom feet, yes, rocker bottom feet you see in a case of Edwards syndrome. Where do you see polydactyly? P for Patau syndrome, P for polydactyly. And if the patient is a case of, very importantly, M, and M, it is a male patient with macrocephaly with mental retardation. Male patient with macrocephaly with mental retardation, and this patient has large ears. This patient has large ears, and this patient has large testes. Then the answer will be Fragile X syndrome. Yes, okay, large ears and large testes. और क्या large नहीं होगा? NEET PG question. Remember very importantly, क्या large नहीं होगा? Nose. No nose. Nose will not be large. Yes, Amir Khan types the Fragile X syndrome. The patient will be male patient, but with microcephaly, with what he called mental retardation, large ears, large testes, and mental retardation, and the nose will not be large. Teenage boy previously raised as a girl came with primary amenorrhea and absence of secondary sexual characters. On examination, he has small testes, micropenis with gynecomastia. So micropenis, gynecomastia, what are we talking about? We're talking about, very importantly, is Klinefelter syndrome, that is 47XXY, and it is the most commonest cause of hypogonadism in males. 8-year-old child with enuresis. Okay, the parents mentioned that the child had a fall from bed once but has no other problem. What is the best next step? Hanji, 8-year-old child, this one. So obviously, motivational therapy, alarm therapy, behavioral modification, and all that. That's it. And what is the drug of choice? The drug of choice will be D for drug, D for desmopressin. लेकिन behavioral modification is important. क्या किसी को तकिया लगा दो, घंटी बजा दो? हाँ, ये भी कर लो. 5-year-old child came with exertional dyspnea. History of cyanotic spell. Cyanotic spell. Cyanotic spell. Where do you see cyanotic spell? In tetralogy of Fallot. There is a clubbing. Yes, tetralogy of Fallot is a cyanotic congenital heart disease. Whenever you get a cardiology question in FMG, someone having a clubbing, so you're talking about cyanotic congenital heart. A cyanotic congenital heart doesn't cause clubbing. Okay, C for clubbing, C for cyanotic congenital heart, and we have tetralogy of Fallot. And very importantly, कौन बताएगा what is the name of the surgeries for tetralogy of Fallot? क्या क्या था? The name of the surgeries for tetralogy of Fallot was a Blalock-Taussig shunt, there was a Waterson shunt, and there is POTT pot shunt. Now, what do you do in Blalock-Taussig shunt? I told you in tetralogy of Fallot, there is a pulmonary stenosis. So once there is a pulmonary stenosis, I told you I need to connect my pulmonary artery somewhere else. I need to connect my pulmonary artery somewhere else. And what is the mnemonic of that? The mnemonic of that is SAD, SAD. That is pulmonary artery to subclavian artery, pulmonary artery to ascending aorta, and pulmonary artery to descending aorta. That is Blalock-Taussig shunt, Waterson shunt, and POTT pot shunt. Okay, that's it. कपिल, कोआक्टेशन ऑफ एओर्टा में तो दूसरा था ना. कोआक्टेशन ऑफ एओर्टा में क्या था? ये हमारा एओर्टा है और यहाँ पे एओर्टिक ऑब्स्ट्रक्शन है. सो ये हमारा जब वन सेकेंड, ये हमारा जब एओर्टा है और यहाँ पे अब आ नहीं रहा. ओके, नेक्स्ट क्वेश्चन करता हूँ. वन सेकेंड. So if this is the aorta and this is the aortic obstruction, so now very importantly, what will happen? The blood basically will come, but as there is a aortic obstruction, very less blood will go down. So what happens in coarctation of aorta? Can I say bounding upper limb pulses? Can I say that? Bounding upper limb pulses and feeble lower limb pulses, number one. Can I say blood pressure basically in the upper limb will be more than the lower limb? And can I say very importantly that what you called USMLE question, late manifestation क्या होते हैं? When Delhi to Hyderabad, when Delhi to Hyderabad, I'm not able to go. How will I go to Hyderabad? I will go to Hyderabad via Mumbai. I'll go to Hyderabad via Jaipur. Okay, via Qutub Minar. So means the body, to make the blood go down, the body will start making collaterals, and once they start making collaterals, छोटे छोटे रास्ते जब बनेंगे, so that will cause notching of the inferior margin of the ribs, notching of the inferior margin of the ribs. A 4-year-old child brought to the clinic with low-grade fever, sore mouth, and painful rash on the hands, feet. So hand, feet, and mouth. If you have 3 question of hand, feet, and mouth, it is HFMD caused by Coxsackie A16 virus. That is important. It is a viral infection basically. 9-month-old infant brought for a routine checkup. The infant is able to sit without support and transfer objects. Which of the following milestones is most likely to be present at this age? 9 महीने के बच्चे से क्या expected है? If I say mature pincer grass, when does mature pincer grass appears? It appears by 1 year. So it is not expected from a 9-month-old baby. He can run steadily. When can a baby run? A baby can walk independently by 15 months. He can run by 18 months. It is not expected from a 9-month-old baby. Hopping comes by how many years? Hopping comes by 4 years. Langdi tang khelna, not expected from a 9-month-old baby. That is why the automatic, really the best answer comes is creeping. वैसे creeping आता 10 महीने पे है. Crawling comes by 8 months and creeping comes by 10 months. But still 9-month-old baby, according to these options, option number B is the closest best answer. Which of the following practices is considered harmful to a newborn in the immediate neonatal period? Cleaning the eyes with wet sterile swab. Okay, if you want, you can clean. Initiate breastfeeding, yes. Placing the baby on the mother's chest, yes. But giving a bath to a newborn, no. That is, we don't do that. 4-month-old infant brought to the emergency department with his RR46. Again, a pneumonia question. 4 months. Only the age they have changed, but the question remains the same. So 0 to 2 months baby having RR more than 60. and 3 months to 1 year baby having RR more than 50. So he's 4-month-old baby. So he's coming under his RR is 66. So definitely, yes, it is a case of along with chest drawing. Okay, fine. So fast breathing with or without chest drawing is pneumonia. There are no danger signs. So that's it. Then the answer is pneumonia. 6-month-old infant came with sudden brief spasm, and EEG shows hips arrhythmias. So we are talking about a case of West syndrome, where the triad of West syndrome is number one, EEG will shows hips arrhythmias. Number two, the patient will have infantile spasms. So infantile spasms with developmental delay and EEG showing hips arrhythmias is the triad of West syndrome. And what's the drug of choice for, very importantly, this West syndrome? The answer is adrenocorticotropic hormone. Remember that. If same thing, infantile spasms, developmental delay, same thing happens in a case of Sturge-Weber syndrome also. Okay, or you can say in tuberous sclerosis also. Then the drug of choice was vigabatrin. Child came with recurrent sinusitis, repeated lung infection, and genetic testing shows CFTR mutation. Which test is considered gold standard? The answer is elevated sweat chloride levels more than 60 milliequivalents per liter. 2-year-old came with high conjugated direct bilirubin, conjugated, dark urine and clay colored stool. Definitely. So the causes of conjugated hyperbil, it is Dr. Bhatia. So D for Dubin-Johnson syndrome, R for Rotar syndrome, and B for biliary atresia. Yes, that finishes the last 5 years previous year question. Yes, where is Jan 2026 questions? Jan questions, guys. You're gonna tell me. Thank you so much, everyone. Life is beautiful. Life is amazing. Thank you so much for bearing it with me for 3 to 4 hours. These were the important PYQs, PYTs, important topics. Number one, you have got this. Number one, please write your score and please write your handwriting. I have cleared the FMG paper in every first page of the book. Whichever book you have, the first page you write, I love you to you write, I have cleared, and my marks is 202 or 198, like that. Start manifesting it, and please, one day before the exam, sleep well. And very importantly, on the day of exam, touch your parents' feet, go to your favorite temple. Like, it's cold right now, but at least just take blessings from everyone. And very, very important, before starting the paper, everyone, Karthik, all the students, before starting the paper, 5 deep inspiration, like inspirations, hold your breath, expirations, 5 times. Then you open your eyes and then you start the paper. Okay, everything will make sense. So please take care. Life is beautiful. Lot of love and respect. If you felt bad for anything, I extremely apologize. All I want is a good positive energy. That's it. प्लीज टेक केयर। एंड वो कहते हैं जाने से पहले सबके लिए गाना हम सब गाएंगे। गाना कौन सा है? हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन, हो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन। थैंक यू सो मच एवरीवन। प्लीज टेक केयर। बाय बाय। दफा हो जाएं, अपने अपने घर को हो लें, क्योंकि इतने में इतना ही मिलेगा। सो प्लीज टेक केयर एंड बाय बाय।